and esteemed. Welcome to the IHOP conference, dedicated to fostering intelligent discussion, sharing in knowledge, and exploring advancement in various disciplines. We are honored to have you all here today as we embark a journey of enlightenment and discovery. Through this scientific program, we have meticulously curated a series of engaging sessions and lectures spanning a diverse range of specialists. Our esteemed moderator will lead the discussions, ensuring immersive and insightful experience for all attendees. In our first sessions, we'll delve into the competitive will estimate moderator Dr. Hazza Al-Ghamdi. Dr. Hazza Al-Ghamdi is the main outpatient pharmacist manager at King Faisal Specialist Hospital and Research Center. He is also founder of Saudi Health Informatics, a pharmacist assembly at Saudi Pharmacist Society, with a background as a registered pharmacist. Dr. Hazza holds a master's degree in health informatics and executive MBA from Prince Mohammed bin Salman College. He is BMB ITIL certified with experience leading a project in e-health and the pharmacy automation. Dr. Hazza, please join us. Mike is yours.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for such a great event and the scientific committee for choosing me to moderate one of the sessions that are very dear to me about artificial intelligence. About the first session or the first presentation will be led by Dr. Hamdan Al-Ajmi. Dr. Hamdan Al-Ajmi obtained his bachelor's degree in pharmacy from King Saud University and then followed by a master's degree in industrial pharmacy in 2014. He worked at King Faisal Specialist Hospital for a few years before he moved to King Saud University Hospital. King Saud Medical City, I'm so sorry about the confusion. And he also served as an editor-in-chief for the monthly newsletter of the Saudi Commission for Health Specialists. Also, he established many medical newsletters for different societies. Additionally, he authored numerous medical articles, newspapers, and has published 18 scientific papers. Dr. Hamdan, the floor is yours.
Okay, hello everyone. The voice is clear. Is it clear? Okay. Today we're going to talk about the effect of professions. Okay? It's not just the pharmacist, different specialty. So it will be interesting. And we're going to start. Let us start. Okay. And I will ask one question. Has anyone here ever been afraid that AI would take their job? Everyone, huh? So why that happened? Why? Why we have an anxiety of that AI will take our job? Because of the media. The media full of articles about naive optimism, sometimes extreme and non-professional journalism that are talking about replacing our jobs. So all of this will create something very bad to us as a practitioner. What is that? What we are feeling? It's uncertainty, an anxiety. This is very bad for a practitioner to be an anxious status. So first I start to tell my friend, you know, I will lose my job. Yeah. and I have to work very hard to change my job. So, and I have another solution. I have to invest my saving in AI stock market like Nvidia and some kind of, and I did that, by the way, and the stock market is now up and up. And I told him, if I invest my money in these kind of stocks, what will happen? If it is up and I will lose my job, I will have what? A lot of money, and that's will save me. So I saved, and I will be honest here, I saved money and I invest in a lot of AI companies. And I found that not only me, 73% believe that AI will replace their job. It's not from America, it's in Saudi Arabia, 2023. So this is a very problematic issue. Riyadh Book Fair, take because I want to know what's happening. And I discovered that recently, just in 2022 and 2023, more than 50 books translated to Arabic in the AI subject. This is very interesting. So there is a lot of demand about this subject. But I noticed something. The best book that you should read about AI is this book by Stephen Wolfram. The journey, if you want to take a journey to understand AI, I recommend for you not to come to a presentation like this in a conference. The only way is to read by yourself from the sources, from the people who invented the articles, the research, and you will find it in the books. And there is a lot of people, like the people in the Nvidia, Microsoft, and OpenAI. What you will start if you read these books, you're gonna predict the future. This is very important. If you read the media, you will be in an anxiety mode. If you read these books, you will understand what's happening here, what is happening in our future as a practitioner. So I start to read, and I read for more than 3 months, books, article, anything related to AI. And what happened after that? I make it in a report. I make a report of 40 pages about مستقبل الممارسة الصحية في عصر الذكاء الاصطناعي with more than 100 references, 40 pages. And I make the relation and the effect of AI on the doctors, radiologists, dentists, pharmacists, nurses, and of course, healthcare leadership. This report will gonna be in your mails, personal mails, within 1 month to 1 month and a half by Saudi Commission. It's free. So all the lecture here will be free, very detailed report, what's happening with me in the 3 months. After that, I give this report to a PhD AI professional people. Dr. Shuruq al-Sinan graduated from MIT in AI. So she reviewed it and she make a recommendation for the healthcare practitioner, what they should do. What is your roadmap? The AI will replace you? How? Or not? Or is it a tool? Let us start that journey. So today, very short brief, 10 minutes, about the impact of AI in 5 healthcare professions, and I will give you some recommendations. So what I did is this. I make a schedule of 3 parts. The first part, what is happening now, this day, current development, the product that it's in the market. The second schedule, the any progress, what is expecting in 2 to 5 years. The third one is what we are expecting after 5 years to 10 years, which is make it a very good roadmap to someone who want to decide what will happen. Should I be like continue my profession, or I will make some modulation? What I should do? Should I invest? Should I change the pharmacy practice? Okay, so let us start with the doctors. The current now development, there is a lot of products. People are like a lot of friends of mine in practice. They are using the chat GPT to ask some questions. And this is like coming regular. But what you don't know, that now there is a product by Microsoft. It will be in the market within 1 year. And I think in Saudi Arabia within 2 years. It's about a microphone. The patient will come to the doctor in the clinic, and the microphone will be there. The AI will gonna put all the history between the doctor in the system. It will be a very good conversation between the doctor and the patient. What is your name? Do you have allergy? What is your weight? And the whole history will, there will be no procedural and routine work by the doctor. So all of this will be what? Automated in the system. For example, Epic system, now they have like a prototype, and also Oracle and IQVIA products. So within 2 years, you will have and you will hear that the doctors will not document the history of the patient. Also in the development for the doctors, we are expecting like generating reports. For example, the doctor will not waste his time in making a detailed report about the patient. In the future, we are expecting that the doctors and the AI embedded in the system will be proactive. The prediction will be more accurate, and the whole data about you from the genetic point of view, from a lot of your compliance with the medication will be embedded in the system. So it will be generate a lot of recommendation for the doctor about this. This is the doctors. Now we will go to radiologists. I will be frankly here. Radiologist is really will be affected by the AI. The research is that AI is more accurate than the radiologist in many aspects. So we will remove the radiologist? No. From ethical point of view, there should be a human factor here to verify the AI results. So what we are expecting in the future, that the demand of radiologists will be decreased in the 10 to 20 years now. But there is like another specialist of the radiologist, like interventional radiologists, will be stable. But for the regular radiologist work, the AI is near and better than the human factor, especially that AI can see what is the eye cannot see. Now we will go to ophthalmologist. Do you know who is this doctor? Doctora who? Salwa Al-Hazza. She is the founder of SIDM. SIDM is a product of Doctora Salwa Al-Hazza. But before we started this, I want to mention that before 100 years, the blindness in Saudi Arabia was 2%. And I found here from Oman here, huh? I think. And the blindness population in Oman was 7% before 100 years. But now in the Gulf country, we are improving. We are improving in many ways in Oman, in Saudi Arabia. Now we have AI founder who are doing this. You go to, here, this is in Saudi Arabia. This patient have diabetes. And hi, how are you? Do you have diabetes? Come to the car. They will give him this an instrument, what is founded by Dr. Salwa Hazza, and they will give him a retina picture that will predict if you have any issue in the retina. This is remarkable from AI point of view. So what we are expecting now from ophthalmologist's point of view, that the ophthalmology working will be changed. It will be a tool for helping them for more accurate and for making this an instrument in distant area. For example, in primary care in the villages. So we are expecting more and more of these instruments to be distributed in the villages and the distant area. If there is a problem, he will come to the cities where the specialty is available. Now we will go to dentist. Dentist is one of the example of at least affected by AI. Why? Because there is a physical and barrier that the dentist should be there, But what we are expecting now within 2 years, that the AI will give a very good example and tool for dentists to analyze the X-ray. Okay? The X-ray will be more easily for the dentist, more accurate. And in the future, within 10 years, what we are expecting is this. You will go to the mall, you will have a dentist technician. He will give you a picture of your mouth, and he will not to predict your just the mouth problem. He will detect a lot of problems, like heart problems, like sometimes diabetes from the picture of the AI. And there is a lot of research about this. So we are expecting the product within 10 years after the validation. So now we will come to the pharmacist. I make more details about the pharmacist, inpatient, what is the AI we're gonna have to the inpatient, to the outpatient, clinical pharmacist, supply chain specialist. Okay, for the clinical pharmacist, I will refer you to the Dr. Ahoud Bahari. She wrote a very good article in the Saudi Commission about the future of AI in clinical practice. You can find this article in Saudi Commission on LinkedIn, and it will show you in details the product for a clinical pharmacist that can be used in AI. For example, how for vancomycin level and for prediction of some of the level of gentamicin. Okay, what is the AI will make for this? AI can predict the curve from few number of levels. Yes, Dr. Abdurrahman, huh? You know this, huh? So we are expecting within 2 to 5 years from now that the clinical pharmacist will gonna use this instrument more and more. Now, so what is the current development? Like Qatar, like Dubai, there is a lot of smart pharmacy system in the current situation that they are using AI for reducing error. But we, in the long run, we are expecting a change of the relation between the pharmacist and the patient. More tools for the pharmacist. And that tools not in our mobile, it will be embedded for and inside the system, like Epic, like Oracle. Okay, how gonna this tool will help us? Less medication error, as the literature said, and there is very important way. For example, if you have a patient with low compliance, a history of low compliance, the AI in the system will gonna alert the pharmacist, please, this patient have a low compliance. You have to educate in that matter. And that's so we have like for inpatient and outpatient is like many tools. It will come in the way, and we are expecting it within 5 years. Now, since I have just few minutes, I will give recommendation. Okay, after I read all of this literature, and you know, this is the report, 40 pages. It will be in your mails within 1 month. What is my recommendation and the expert recommendation that I use in my report? First, don't come to lecture. Is the voice is real? Okay. Don't come to lecture like this to learn about AI. You have to read from the sources that will train you to predict the future. If you come like a lot of AI presentation like this, you will be in an anxiety mood. Okay? You have to read about the philosophy of AI. You have to read about the basis, the deep learning, the machine learning. So you will predict more, and it will remove that anxiety from you. Second, the rule of academia. They should put AI in their curriculum. Okay? Third part is, if you have an idea about AI and how to improve it, for example, one of my friends told me, calling center, why the pharmacist should answer the calls? And I told him, yes, there is an idea and there is a prototype about AI who will take calls from the pharmacy. Hello, my name is Hamdan. I want to have a refill. The AI will answer you in Arabic. And that chat will be in the market within 5 years after the validation, I'm sure. Within 5 years, the calling center will be deleted. So, the third thing that I recommend, go to Gaia. You know Gaia? Gaia, okay. Gaia is accelerator established by Wali al-Ahd, Al-Amir Mohammed bin Salman. It's inside Al-Karaj in Kaxt. If you have an idea, go to them. They will give you $500,000 real, and they will invest in you. They will give you place. They will give you money. They will give you expert programmer. One of my colleagues, he is a dentist. He went there and he established the Kamed. Now he is there in the Al-Karaj, and they are, you know, giving them the whole opportunity to make their idea as a product and go to the market. Okay. What is also I recommend is, don't fear for your job because of AI. Fear for it because of the employee who has the skill to use AI tools. You have to train on the AI tools like هندسة الأوامر, prompt engineering. Before 2 days only, Dubai announced that they will train 1 million people on the prompt engineering as a skill, a very important skill to deal with AI. From my perspective of view, I am the chief editor of the Saudi Commission monthly newsletter. I added like a section for أضواء على الذكاء الاصطناعي in the newsletter, monthly newsletter. and I put news about AI in that monthly newsletter, and we are expanding because the importance of the AI. Okay, this is the end. I think I took more 2 minutes. Good. Thank you very much. So in the end, I will tell you this. All the lecture detailed in Arabic. It will be in your mail and in the Saudi Commission LinkedIn and Twitter account. PDF, easy to read, reviewed, and I hope you will enjoy it. Thank you very much.
Thank you. Thank you so much, Dr. Hamdan, for an impressive presentation. The amount of effort you gave and the time that you spent to just learn about AI, how many books you read, how many papers you wrote in this area. It's very commendable. Thank you so much for enriching the Arabic content when it comes to AI. Many people will learn from it, I believe. Now we will open the stage for questions and answers. So if anyone have any questions to Dr. Hamdan,
تفضل.
can we have a mic for the question?
السلام عليكم.
عليكم السلام. حياك
الله يعطيكم العافية. أول شيء شكرا جزيلا. إحنا كشباب داخلين على المستقبل هذا، كيف من الممكن أني أسبق هذا الذكاء الاصطناعي السريع؟ كيف من الممكن إذا ممكن في شهادة مثلا أو شغلة تميزني أني أكون مؤهل أني أكون صيدلي أتعامل مع الذكاء الاصطناعي؟
جميل.
الله يعطيك العافية. شكرا.
الله يعافيك. طبعا أنا ذكرت الهندسة الأوامر، لكن الأهم هو القراءة عن الموضوع، لأن اللي صاير في الميديا والمسليد يو as a student. يعني احنا يتم الخداع، يتم خداعنا بشكل يومي في الميديا من قبل صحفيين غير متخصصين صراحة. فهذا الشيء خطر علينا كأشخاص في البراكتس. فأنصح في البداية في قراءة المصادر من المصدر. الشيء الثاني، في بعض الدبلومز اللي الآن في المملكة، الآن جامعة الأمير سطام عندها ماستر ديجري في الاي اي، وتقريبا هي 2 سنين، ويعطوك البيزكس of the AI in your journey. I recommend this. And I think the AI trainer in the pharmacy field will be like a huge investment in yourself. After you take the pharmacy degree, you will learn not the informatics only. You have to train yourself and take a diploma how to train the systems on the big data. And if you are a pharmacist, it will be a huge assets. And if I were you, I will be like this. After I graduation, I'm gonna invest in myself to be a trainer, AI trainer. Thank you.
شكرا.
Thank
يعطيك
you, Dr.
العافية.
Thank you, Dr. Hamdan, for the nice answer. Until we move the mic, just a follow-up for my colleague. I believe in the near future, AI is not gonna replace us, but a person who uses AI properly is gonna replace the person who doesn't use AI. So what I would recommend is that try to investigate, try to play with all of those tools of AI that you have, and then maybe you will not need to go to master's degree if you don't want to be that deep in the topic, but at least be able to use it and utilize it for your daily use, I'm not gonna say use it in your work only or in daily work, but make it your companion. Now Microsoft is releasing Copilot. Copilot is gonna be your co-pilot whenever you are driving or living your life. So in general, what I would recommend is that keep a curious eye in everything that you do in your life, and imagine how an AI can help you to improve it, and try to use it. You don't need to be perfect. You don't need to have all the master's degree or all the education. Just try to inject it in your daily life. You will see how amazing it is, and then keep a curious eye on where can you apply it. So either in your work or in your personal life. Good luck.
Assalamu alaikum.
تفضل.
First, thank you so much for this amazing presentation.
Thank
معك الدكتور يوسف جامعة الإمام عبد الرحمن بن فيصل.
الله.
Actually, when نتكلم عن ال AI as academic أو as a pharmacist, clinical pharmacist, في تخوف أو في عدم توازن ما بين الريسك والبنفيت of ال AI. For example, عندنا في الجامعة أو في المجال الأكاديمي في تخوف إنه ممكن ال AI يستخدم في أشياء ممكن not legal. إنه ممكن دبل كليك ممكن أطلع لي أبحاث، ممكن assignment. في مجال المستشفيات ممكن إنه في تخوف لاحظت أنا حتى لما كنت في أيام الابتعاث في الولايات المتحدة الأمريكية، كان الفارماسيست يخاف إنه ال AI يحل محل الفارماسيست أو إنه يأخذ مكان الشغل البشري أو فالتوازن ما بين الريسك والبنفيت في ال AI.
جميل. لو أتخيل المستقبل بعد 30 سنة، افرض إنه تطور الموضوع، صار ال AI more and more accurate, there is a validation from FDA that we can replace the pharmacist. الصيادلة تاريخيا قادرين على خلق خدمات جديدة للمريض تخلق لهم وظيفة. كيف؟ الحين الكلينيكال فارماسيست ايش تاريخيا كيف بدأ الكلينيكال فارماسيست؟ بدأ لأنه شركات الأدوية في الأربعينات والخمسينات قاعد توفر برودكت جاهزة ready to use for suppository, tablet, creams to the market. So the pharmacists look at this and tell, okay, what is our job? They created the clinical pharmacy as extra work for the patient. If there is an AI and we have more free time, we have to create more services, innovative services to the patient as a pharmacist to make his journey better. I don't know what is the service that we should, but we should create in the future if we have free time that the AI will give us. For the research point of view, like for using AI in research, is it ethical? I think within 5 years it will be ethical. And for resident people, for example, residency, they are ordered to have 1 or 2 research. But after 5 years, they will allow to use AI. But you have to give how many research? 10. This is the future. That's what I'm thinking. You cannot prevent it, okay? And I think there is from Dr. Abdurrahman. Do you have any comment about this?
Yeah, honestly, I'm definitely a pro AI utilization.
Yeah.
Soon, inshallah, there will be a position statement that will be released by the Society of Hospital Information Pharmacists and also the Saudi Society of Clinical Pharmacy in this particular regard that will target both two different main aspects. The first one is going to be the data governance part, and also the other one is going to be more towards the AI utilization. So we believe, as we had just mentioned, that AI is definitely going to be a big part of our life in the future. So the only solution for us is to evolve and not just to believe in the status quo and say that this is going to be just taking our job, We have to just, accept this reality, and we don't have to do anything else. Definitely, we have to evolve as a profession. Definitely, we have to expand in so many levels, in all aspects related to pharmacy. It's not only clinical pharmacy, I mean, academia, supply chain, operation aspects, and you name it. The thing that probably needs to be, done more strategically, though, is that there's supposed to be some sort of a governing body to make sure that, these enabling tools are technically has been, monitored closely. Just like any other tools, these tools can be great if it was, put in the right hands, and it can be also bad if it was not, utilized by the right people. So to properly use this, possibly you have to have some sort of guidance. That's why we have bylaws for practitioners. That's why we have bylaws for everything. I think the way forward is to have possibly maybe a yearly updated guidelines to how to optimally use AI and how to use that. From an academic standpoint, it's about research. Definitely using AI, and this is possibly my personal point of view and my couple of colleagues, and this is not by any means representing any societies, is that possibly you can utilize AI to generate ideas, maybe to assist in certain parts of grammars and writing. However, the critical thinking part is definitely has to be done by the researcher. The AI, as you know, is gonna write the projects based on the data that was already provided. And we know that sometimes these real data events, can be supplemented by other things. Though amazing presentation. It was definitely a pleasure listening to you, but that was just my only comment. Thank you.
I'm going to end with this. I will try every year to update this guideline and send it to your emails, inshallah. And thank you, everyone, for sharing knowledge. Dr. Hazza.
Thank you, Dr. Hamdan, and thank you, the audience, for the amazing discussion. I believe we run out of time, and our next session moderator, who's the one giving the long question, is going to be late for his session. So thank you so much, and have a nice day.
Thank you.
Recognize Dr. Hazza and presenting them with award as token of our deepest gratitude. Hazza. 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 Pleasing joining me and recognize Dr. Hamdan and presenting them with this award as a token of our deepest gratitude. Thank you so much, Dr. Bakr. Moving forward, we transition to the critical care session, where Dr. Abdurrahman al-Shaya. Dr. Abdurrahman al-Shaya is Assistant Dean of Academic Affairs and Associate Professor of Pharmacy Practice at the College of Pharmacy, King Saud bin Abdul Aziz University for Health Science. He is also a consultant clinical pharmacist specializing in internal medicine at King Abdul Aziz Medical City in Riyadh. Dr. Shaya holds a Doctor of Pharmacy degree from the University Arizona at Chicago, and he has complete postgraduate training in internal medicine pharmacy. He currently serves as a chairperson of Internal Medicine Pharmacy Specialty Network under the Saudi Society of Clinical Pharmacy. Dr. Ahmed, please join us. Mike is yours.
السلام عليكم، يعطيكم الف عافيه، صبحكم الله بالخير. جمعة مباركة للجميع. صراحة فرصة سعيدة أمانة اللقاء بكم جميعا، وشاكر ومقدر صراحة اللجنة العلمية واللجنة التنظيمية ال IHOP for this amazing opportunity. صراحة it's amazing time to meet colleagues, leaders and learn from their experiences in this particular time. Without further ado, let me introduce my colleague and dear friend, Dr. Abdullah Al-Harthi. Dr. Abdullah Harthi is the head of clinical pharmacy department and assistant professor of clinical pharmacy at Shagara University. He's also a critical care clinical pharmacist at the moment. Dr. Abdullah completed his PharmD in 2017 from Taif University. Then he joined King Abdulaziz Medical City National Guard Health Affairs as a PGY1 since 2018. Later on, he finished his critical care in 2021. He completed his PGY2 in critical care, and then later on he obtained his dual American board certified specialties in pharmacotherapy and also critical care. He's also a board member of the Saudi Society of Clinical Pharmacy in the Critical Care Emergency Medicine PSN. He's also a board member of the newly established SCAPE Society as well. He's interested in trauma, burn, infection diseases in critically ill patients. So without further ado, welcome Dr. Abdullah to talk about post-intensive care clinics, a global outlook and local future directions.
السلام عليكم جميعا. الصوت واضح؟ طيب. Management state for critically ill patients or discussing PKPD changes or medication related changes in critically ill patients. And also as a critical care clinical pharmacist, we usually used to see our results for our intervention within a maximum of 3 days. But what if my patient need me after 3, 6 or 12 months post ICU discharge? So by the end of this lecture, we are going to define post-intensive care syndrome, which I will call it PICS, identifying its risk factors, prevention as well as management. Then we will describe PICS clinics globally with more explanation on pharmacist role. And finally, we are going to discuss local challenges in our country as well as future directions. So post-intensive care syndrome need to be defined before going to post-intensive care syndrome clinics or PICS clinics. So the definition of post-intensive care syndrome, it's a worsening, new or worsening impairments, either cognitive, physical, or mental, that raised after ICU and prolonged for prolonged period after ICU discharge. The term actually was proposed initially for PICS patients. After that, their families also were involved in this impairment. So this term and definition is applied for both PICS patients by themselves as well as PICS family member or PICS-F. So let's talk about impairments in post-intensive care syndrome. We have, as mentioned before, physical impairment, which is muscle weakness, impairment in doing daily physical activities, as well cognitive impairment like memory loss, like attention deficit, and we might have been read that book by Dr. Rana Audish. She was an intensivist. At the same time, she experienced critical illness. So she mentioned in her diaries or in her book that some of her ICU stay days are not memorized, or she cannot memorize them. Also, we have anxiety, depression, as well as post-traumatic stress disorder as psychological impairment. So, okay, we are talking about PICS. Is it prevalent in our patients or not? Is it rare disease or rare condition or not? Actually, according to data for, on more than 2,000 patients, they found that the prevalence of post-intensive care syndrome is around 50%. And the risk factors or the triggers for those patients are either patient-related factors or ICU-related factors, patient-related factors like demographics, like age, sex, ethnicity, as well personality, as well as previous health, if the patient has previous ICU admission, and so on. For the ICU-related factors, ICU admission could play an important role in causing PICS, as well ICU treatment, or if the patient developed delirium, if the patient was experiencing a pain during ICU stay, as well as the bed rest. So there is a multiple proposed strategies that could prevent PICS. However, they are not preventing PICS by 100%. The first strategy is using ABCDEF bundle that was recommended by the latest PADIS guideline, which was published in 2018. We can also use minimizing sedation approach. We can also support patients psychologically as well as ICU diaries. However, I want to mention that these preventive strategies are not applicable for all patients. And if it's performed for any patient, we cannot ensure that it could prevent PICS by 100% or totally. So as long as these preventive strategies are not preventing PICS by 100%, so we need to discuss the management strategy. There is three main approaches that could be used for PICS patient, either referring to post-ICU rehabilitation centers. The only drawback in ICU rehabilitation center, the patient is referred to his specialist. So if patient experiencing stroke during his ICU admission, so he will refer to rehabilitation center dedicated for stroke patients, as well as he will refer or she will refer to be reviewed by a neurologist. The other mode of management for PICS or for post-intensive care syndrome is ICU supportive groups. However, it's also insufficient to manage PICS. And the final thing and the trend these days is post-intensive care clinics. Let's go back a little bit. In 1993 in London, the first post-intensive care clinics started in UK by intensivists as well as nurses. It was called intensive after care after intensive care. After that, in 2002, during the International Conference for Surviving Intensive Care, they proposed and emphasized that each patient experienced ICU stay need to be reviewed for at least 3 to 6 months, and they are emphasized more and more on post-intensive care syndrome clinics. After that, in 2010, the Society of Critical Care Medicine proposed or established Thrive Collaboratives, which is a group of pioneers in critical care field. Globally, they are supporting and emphasizing on the establishment of PICS clinics, as well as providing support to ICU survivors and their families. And at the same time, the first PICS clinics was established in USA, and it was involving pharmacists. After that, and finally in 2017, NICE recommended that adults who are experiencing post-intensive care syndrome should be followed up for at least 12 months. So this is a brief history about the establishment and development until these days for PICS clinics. Okay, just to emphasize on Thrive Collaboratives, which was established by the Society of Critical Care Medicine, they published a paper that concerned with the 5 most important key elements that need to be implemented or taken into consideration for those patients and their families. They are described these key elements as new target for quality improvement or projects for quality improvement, or creating a new survival role, as well as inviting colleagues to post ICU programs to have more benefits from their experience, and also improving morale for patients, as well as understanding the patient experience. So is PICS clinics is beneficial? Of course. As well, it's provide individualized care, it provide rehab services, it could address cognitive and psychological impairments, as well as reduce the burden on other specialties. As mentioned before, most of ICU rehabilitation centers are run by specialized physician in either neurology, cardiology, trauma, and so on. So if it's beneficial, it needs to be effective. How we can measure its effectiveness? So the effectiveness of PICS clinics can be measured through a lot of domains, such as improving patients' quality of life, reducing readmission rates to the ICU and hospital, as well as enhancing functional recovery. What is the optimal structure for post-intensive care syndrome clinics? Actually, the evidence is still new and there is still insufficient data. However, the most appropriate structure for post-intensive care clinics is by including a nurse practicing in ICU, intensivist or physician, pharmacist or critical care clinical pharmacist, dietitian, as well as physiotherapist. And here are some examples that could be done by those healthcare practitioners. Like physician, he can do tests, assess the patient, and review and approve also the whole plan for the patient. Clinical pharmacist is the one who is dealing with medication-related problems in general. The ICU nurse or ICU nurse practitioner, she can facilitate the process of reviewing the patient. She can ensure that the patient is attending his clinic and so on. And also, the psychologist can also do screening for psychiatric diseases as well as therapeutic dialogue, and case manager for facilitating logistic-related issues. Does my patient or is my patient is eligible for post-intensive care syndrome clinics or not? Actually, again, there is insufficient data till today for the eligibility criteria for post-intensive care syndrome clinics. However, there is some criteria that was adopted in most of PICS clinic studies, being adult, being in ICU for more than 48 hours, experiencing ARDS or septic shock, is authorizing the patient to be followed up post-ICU discharge. And there is other criteria as mentioned here. Of course, if there is eligibility, so there is exclusion criteria. The most important one is patient with short life expectancy, like less than 6 months, as well as those with pre-existing dementia, those who are residing in nursing care facility. Okay, so let's have a look or quick look on literature and what literature said to us about PICS clinics. So the first study is a randomized control trial was conducted as a parallel design for patients. They included patients either in intervention group, which is PICS clinics, versus usual care, no PICS clinics. If you see here, there is some contradicting variables, like if you see the time to readmission, okay, it was statistically significant. The composite outcome, which also was statistically significant. However, readmission rate in general, there was no difference, and we need to be aware that this study has limited generalizability as well as low outpatient engagement. The other study, which was done by Dr. Yasin Ali. It's also an RCT, but it was pilot study, so it was having small sample size. Actually, another thing, this study was conducted only on type 2 diabetic patients, and most of outcomes were related to diabetes, like HbA1c, blood glucose, and so on. So also for this study, neither the diabetes-related outcomes nor the health-related quality of life showed any significant difference. Just getting back, if you see here the structure of the clinic involving almost all of the specialties that was proposed for optimal PICS clinics. These two studies was nurse-led program, so nurse was running the clinic, and this practice is they were practicing this for years in Europe and UK. However, studies on nurse-led programs showed no significant, and one study, if you see, found there is more cost for PICS clinics without any additional benefit. Okay, so as a pharmacist, we need to know our role in managing patients with post-intensive care syndrome at the clinic, as long as patient discharged from ICU experiencing at least 80% of medication-related problems. Before exploring pharmacist role, we need to know which qualifications that qualifies me or authorize me to run or to get engaged in the clinic. So the first thing that you can get involved in the clinic with your PharmD, with your Master of Clinical Pharmacy, with your fellowship, PGY1 or PGY2. However, around 80% of pharmacists in USA practicing in post-intensive care clinics are holding PGY1 plus PGY2 in critical care settings. Okay, which activity I can provide for my patient in the clinic? So I can educate patient, I can get involved with multidisciplinary team, I can conduct quality improvement projects and researches, as well as medication related problem like medication reconciliation, adverse drug event prevention, and so on. Moving back to literature review, so studies on pharmacists are a lot, which was evaluating the impact of pharmacist intervention in post-intensive care syndrome clinics. And I know some of it is descriptive studies. However, they found that pharmacists can prevent a huge number of medication-related problems. And if you see in the next study, which was conducted by Rima Mohammed et al., they found that significant difference after 6 months of follow-up reduction in patient or medication-related problems. The other two studies I would like to highlight on Joanna Stolling's et al. Study. By the way, Dr. Joanna Stolling is the leading pharmacist in US for post-intensive care syndrome clinics. She had a lot of publications, mashallah. The last one was published in 2023 and involved around 11 ICUs. However, the study also was descriptive, but another thing, they found a huge number in reducing medication-related problems. So, sorry. Okay, so now we discussed post-intensive care syndrome. We discussed how we can prevent it, how we can manage it, which trigger post-intensive care syndrome, and we get a brief look on post-intensive care clinics globally. We need to know what is our local perspectives, what we are doing here in Saudi Arabia or in our region regarding post-intensive care syndrome and post-intensive care clinics. Actually, until today, there is no post-intensive care syndrome clinic in Saudi Arabia. We wish that by 2030, with our vision in Saudi Arabia, that the clinic is run and with an involvement of pharmacists. Until now, regarding post-intensive care syndrome, only 3 studies in Saudi Arabia was conducted to evaluate or to assess the incidence or the patient experience with ICU post-discharge or patient experience with PICS. The first study and the third study were led by pharmacists. The first study was published this year by Dr. Abdullah Al-Hammad, and the third study was published by Dr. Yahoud Al-Jahani in 2021. The second study was led by nurse, and all of studies was questionnaires experiencing patient follow-up and related outcomes. So, what is the status of post-intensive care clinics in our country? Let's get back and let's talk generally. Generally, post-intensive care syndrome is a new concept or new condition, and post-intensive care syndrome clinics or PICS clinics is also another new concept. There is until now no standardized guideline, no recommendation or statement from any authority. So it still need more evidence to know where we are and where PICS patients are. Actually, another thing is before implementing PICS clinics here in Saudi Arabia, we need to have epidemiological data. We need to know the prevalence of post-intensive care syndrome in our country. In order to establish a clinic, we need to have a data or epidemiological data that we can rely on. Another thing to be discussed, we had a lot of challenges and barriers need to be addressed in our country in order to manage and establish post-intensive care clinics. We need to increase awareness not only for healthcare providers but also for patients. We need also to train our pharmacists, nurses, physicians for post-intensive care clinics, because intensivists and critical care clinical pharmacists are usually working in inpatient settings. And I don't think that one day we've thought before and we can work in ambulatory care settings or in outpatient settings. Also, we need to allocate resources as well as collaborate with institutions or between institutions. As you all know, still intensivists number in Saudi Arabia is not low, but it's not reached to the target. So until now, there is a scholarship for intensivists for post-residency fellowship in ICU. For future directions, we need to ensure that we are expanding and standardizing the practice. We need to ensure that we are training and educating not only healthcare practitioners but also patients. We need to do a lot of researches, and as I mentioned before, we are lacking epidemiological data. As well, you cannot establish a clinic without a policy, procedure, funding, collaborative practice agreement, and so on. And we need to get more integration with community practice or with primary care practice. So by this, I'm concluding my presentation by saying surviving the ICU is only the first step in a long journey of recovery. Thank you so much, and I wish you enjoyed the presentation.
Thank you so much, Dr. Abdullah, for your amazing talk. Next, we have a debate. And this is possibly one of the unique things, honestly, about IHOP holding these debates in an annual basis. We will have a debate about the therapeutic anticoagulation for new onset atrial fibrillation in ICU. That will be delivered by two different speakers. But maybe before we jump into the speakers and have biased opinions, I would like to know if you are a pro anticoagulation. Please raise your hand. 1, 2, 3, 4, 5. Okay, if you are against full anticoagulation for new onset AFib in ICU, please raise your hand. Oh, so you're the only one so far. All right, so without further ado, let me introduce our esteemed speakers. The first one is going to be Dr. Namariq Fahad Al-Dardir. She's a critical care clinical pharmacy consultant, and she's also a medication officer at King Faisal Specialist Hospital and Research Center as well in Jeddah branch. She completed the PGY2 residency in critical care specialty at King Saud Medical City here in Riyadh. She earned a 3 American board certification, mashallah, in pharmacotherapy, critical care, and nutritional support. She has more than 10 years of experience between pharmacy services, clinical and administrative work, and she's currently the chairperson of the Critical Care and Emergency Medicine PSN at the Saudi Society of Clinical Pharmacy. Without further ado, Dr. Namariq, you have the floor.
Hi. Assalamu alaikum jami'an. So, inshallah, today, myself and Dr. Saleh, we are going to, talk about one of the debates that I have been recently faced a lot in the ICU during the practice, which is should we or we should not start full anticoagulation for those patients who have this new onset AFib in the ICU. So we have nothing to disclose. Generally, what we are going to do is we're going to explain the area of the controversy that we have in this topic in general, and we're going to support this with a lot of evidence, inshallah. So, generally speaking, we need to know where is the gray area. Generally, any patient who have an AFib, based on the AFib guidelines, European or American, and their CHA2DS2-VASc score is more than 2 in men or more than 3 in women, so they are eligible for full-time anticoagulation for life. So that's it. When we come to the ICU patients in general, so there is many risk factors is contributing to this atrial fibrillation. For example, vasopressin and sepsis, and we're going to talk about it more later. So if these risk factors have been removed or treated or fixed, the question is, would the patient still be eligible for full anticoagulation? Yes or no, and for life? So there is two perspectives. The first perspective said yes, to prevent the stroke risk, because we know if we have an AFib and his chest vascular score is high, so we usually give the anticoagulation to prevent the thrombotic risk. The other says the risk factor is gone, so why we are starting this from the first place? So they don't recommend this because they are afraid or worried about the bleeding risk for those patients. So talking about the onset of new onset AFib in general, the rate, so we have it 5 to 15%, up to 46% of those patients with subgroups like the septic shock. So what happens generally? Here, what happens? There is a lot of risk factor, for example, in the ICU, including surgery, sepsis, vasopressors, and also thyroid storm. All of these contributing to either inflammation or fibrotic arterial fibrosis, or either changing in the intracellular ion of the heart. So that's leading to the structural remodeling, and for this, that is a trigger for AFib. So that's actually what happens in the ICU. So there is something happens in the ICU different than any patient outside. This thing is the reason why the patient is having this episode of new onset AFib in the ICU. So I'm going now to talk about the perspective of those patients, of those healthcare providers who think that we should give this anticoagulation after the onset of AFib. So common scenarios that I'm facing in my clinical practice. For example, a patient 67 years old, admitted with diabetes, hypertension, ischemic heart disease, admitted to the ICU as a case of septic shock. During his ICU admission, he has this new onset AFib. So they do the defibrillation for him, and they start in an IV amiodarone. They consult cardio comes, looks at the patient. His chest vascular score is more than 2. Okay, he's eligible for anticoagulation. Start this patient anticoagulation. So that's what usually happens in this scenario. So myself, I have spoken to those cardiologists and asked, you know, this patient's septic shock is gone, and he has only one episode of AFib. So why we are really deciding that this patient should take this full anticoagulation for life, and you know, just for one onset AFib in the ICU, which is based on these risk factors that he encountered. So the first perspective, the physician, the guideline. So they are referring to the American or the European guidelines, who said that any patients with just chest vascular score is more than 2, and he had an AFib, so they have to start this anticoagulation, but knowing that the community guideline should not really apply in the ICU setting. The other perspective, the physician, they said the ICU in general, they are in the high risk of thrombosis. So usually ICU patients, we are worried about this thrombosis. So also the evidence says that those patients with the AFib in the critical illness, they have increased risk of the thromboembolism, mortality and length of stay, and also the cost. However, we still don't know if this AFib in the ICU is contributing to this outcome, or it is an indicator that the patient is in the poor prognosis. We don't know this yet. Other studies that have been looking into this, they said, you know, those patients, after they discharge from the ICU, they don't have this stroke relevant, so they don't admit with a stroke, but most of them, they admit with a subsequent AFib. So if it occurs one time, it's more probably that those patients will have another AFib later. Talking about this, there is a recent study looking into the subsequent AFib in the ICU. So it occurs in 1/3 of all patients who are having a new onset AFib in the ICU. And there is some risk factors, including how long those patients were in AFib in the ICU, and how much is the structure of the atrial that the patient has. Okay? So all of these are contributing to the subsequent AFib. So that's from the perspective of the healthcare providers who believe that we should start anticoagulation for those patients. So my colleague, Dr. Saleh, he will talk about the other part, which is why we should not give the anticoagulation.
All right. Excellent talk. For those who were voting for Dr. Namarq, please stay tuned. We're going to listen still to Dr.
voting في النهاية حنسوي.
Wait a minute, yeah. Dr. Saleh Said Zahrani, he's a clinical pharmacy specialist. He's an adult critical care. He works currently at the Security Forces Hospital program as the program director. He's also obtained his PGY1 back in 2013 and his PGY2 recently in 2022 from King Saud University Medical City. Dr. Zahrani became also an American board certified in 2018. He's currently the head of clinical pharmacy services at his institution, in addition to his current work as a critical care pharmacist.
Thank you, Dr. Abdurrahman, for the introduction. Thank you for the scientific committee as well as the organization committee for the invitation and for this great opportunity to share the stand with such an amazing colleagues. So we're going to continue the debate about this presentation. And as Dr. Namarak mentioned previously that the critically ill patients, can I borrow it? The critically ill patients carries a lot of complexity, and the decision about making whether to anticoagulate versus no anticoagulation is way complex than we thought. So before we dig into the evidence, always we have to question about the safety and efficacy of such an intervention. So the first study was done back in the days in 2013. It looks into the safety and efficacy of the fully anticoagulation versus those who did not receive the anticoagulation and new onset atrial fibrillation. So it was a retrospective study, including nearly 115 patients, and they looked into the mortality, the transient ischemic attack as well as the bleeding as their primary efficacy endpoints. So among the anticoagulated cohorts, we will realize that the mortality was less compared to those who did not receive the therapeutic anticoagulation. However, when we look into the other aspect of the outcomes, among the high-risk population who received the full anticoagulation, we'll find that it doesn't affect the rate of ischemic stroke. However, it does increase the risk of bleeding and the hit as well. So another outcomes were also studied in this study and shows that the anticoagulated individual have shorter ICU length of stay and have higher hospital length of stay. Another study was done in a retrospective fashion. However, this time it's including more than 38,000 of patients. So they looked into the similar outcomes and they were assessing both the safety and efficacy as well. So in the primary or unadjusted results, we will see that the rate of ischemic stroke did not differ between those who received the anticoagulation and those who did not. And the rate of bleeding was more among the patients who received the therapeutic anticoagulation as well. Also in the adjustment of the scoring system, we'll find that the rate of ischemic stroke was less, as well as the rate of bleeding was more in those individuals who received the full therapeutic anticoagulation. Also, when they look into a patient or subgroup of patients, they found that among the newly diagnosed new atrial fibrillation, the rate of ischemic stroke was more if they received the therapeutic anticoagulation, and the rate of bleeding was more among those who received the therapeutic anticoagulation as well. So subsequently, another study was done in multiple cohorts of ICU patients. So they looked into the safety as well, the efficacy of the therapeutic anticoagulation. So among the sepsis individual, they found that the rate of stroke wasn't differ between those who received and those who did not receive the therapeutic anticoagulation. The bleeding tendencies was quite similar between the two groups. Even when you look into the multivariate analysis, they failed to find any association between the bleeding tendencies as well as the rate of ischemic stroke in a subset of patients who have a sepsis. So last study was done by Wolke again, and this time they looked into the outcomes after the hospital discharge. And they found that the rate of mortality was more if the patient did not receive any anticoagulation throughout the treatment period. And the bleeding tendencies as well as the rate of ischemic stroke was even more in the anticoagulated individuals. And within the 30 days of hospital discharge, we will find that again, also the rate of ischemic stroke was more in those who received the full therapeutic anticoagulation, and the rate of bleeding was not differ between those who received and those who did not receive the therapeutic anticoagulation. So to sum up all the findings, among the illustrated studies, we'll see is that a patient who received the full therapeutic anticoagulation doesn't have any statistical significant differences between when it's compared to those patients who did not receive. And the rate of bleeding was quite higher among those who just received the therapeutic anticoagulation compared to those who did not. And even though when we look into the guidelines, we'll find many of the guidelines where carries either two recommendations. Either they have no specific recommendations to treat atrial fibrillation in such case scenarios, or either to recommend against the use of the full anticoagulation in patients with new onset atrial fibrillation.
Yeah. Thank you, Dr. Saleh. So as Dr. Saleh said, that there is some of the guidelines, they say that it's not recommended to start full anticoagulation. But when we look to this one guideline that have, said that, it was saying that this guideline was based on only one study, and it was a systematic review. And the same study, when you go back to it, it's usually saying that we cannot generalize this because the ICU patients and the risk factors is really different. And that's what actually made us in the Saudi Arabia to initiate this study about the anticoagulation initiation in new onset AFib. طبعا the one who is the primary author is my resident. I can't say my resident, she's also a colleague, I would say, Dr. Ragad. And generally, we wanted to determine the risk factors and outcome associated with new onset AFib in the ICU. So we have included 5 centers in Saudi Arabia. And the study is finished. We are in the analysis phase. And what we found, I'm not going to burn it for Ragad. Inshallah, after a couple of months, she will present it at the Resident Day. But in general, we have really to look in these studies how much was the CHADV score for those patients and has bleed score. That's what we care, because that's what we depend in the outcome, which is the thrombotic and the bleeding outcome, and also the Apache score, how sick was those patients. So that's in general. Again, I'm not going to burn it for her. I didn't specify both group. In general, we found that there were no big difference in the bleeding risk comparing those patients who did have anticoagulation or not, but the thrombosis was higher in those patients with no anticoagulation. And as what Dr. Saleh said, the mortality consistently in all the trials says higher in those patients with no anticoagulations. And that's what we're going to do, inshallah, in our study. We want to study this, the mortality. Why the mortality is higher in patients who's not anticoagulated? What the risk factors that really related to this mortality? Is only the ICU sickness, or there is something else? Inshallah, we are going to publish this, inshallah, and we will know that. So now, we have this balance. So 2 perspectives from healthcare providers. One of them, they said, yeah, initiate, because whatever evidence, strong evidence that we have says CHADV score high, so we have to initiate. Subsequent AFib is mostly it will come again, so just initiate. Others says this is, some, even if it's weak studies, says that there is no difference in bleeding or thrombotic in bleeding in the thrombotic risk between those 2 groups. So why we make a patient live his whole life on anticoagulation based in one incident or in one AFib episode done in the ICU? So after this, we need your opinion. If you were in the round or anybody asked you these questions, scan the code and let us know, what do you think? Which direction you would go for based on the evidence that we have just said. Just a minute, let them scan the code, but then once you all scan the code, we will present the ball, inshallah. All done? Present the ball. So again, there is no right and wrong in here. We are just based on whatever evidence that we have as a clinical pharmacist here. Let's make an agreement. What would you think, and which direction you would go for? هنا. Yeah, still yes. Thank you. By this, we ended our presentation. Thank you for attending, and inshallah for many more to come. Thank you.
Thank you so much. Would like to invite Dr. Abdullah also to join the discussion panel. We will open the questions for the audience at the moment. So if you have, please, any questions, who was handling the mic? Any questions from our audience? Maybe we can get started possibly on the PICS process. As you had just mentioned, that Joanna Stallings has been leading the work. Currently is being led by also West LA and that amazing group in Vanderbilt. However, looking at the pharmacoeconomics aspects of this, there are still some concerns about how do you quantify the value of PICS. Have you come across, Dr. Abdullah, any pharmacoeconomic valuation that justify the value of PICS?
الصوت واضح؟ الصوت واضح؟
لا يرفع صوتك. اتوقع المايكات بعضها تحتاج شوي ترفع صوتك.
طيب يعطيك العافية دكتور عبد الرحمن. Thank you for your question. Actually, up to my knowledge, there is no until now pharmacoeconomic evaluations. However, as I mentioned before, in the nurse-led program RCT, there was it's not pharmacoeconomic. They concluded that PICS found to be costly. However, they measured the cost in not only in pharmacoeconomic point of view, but in whole point of view or logistics point of view.
ايه دكتور انا ما اقتباس.
Assalamu alaikum. I just want to ask Dr. Abdullah something regarding the clinics, and I want to get everyone here in the ambulatory care or someone dealing with the clinics the same question. I would love to start the ICU post clinic, but regardless about the cost, regardless about the resources, I'm just thinking about the patient. Do you think that patients, along with whatever clinics that they have, medicine, anticoagulations after, they would really accept to come to the ICU clinic, they would really, be convinced to come to this clinic, or it will be a burden for them to have an extra clinic added to all the clinics that already they have. So usually with those patients in the ICU, they are medically, diabetic and so on. So it's a question to you, a question to anyone who has an experience with those patients who they come to the clinic, or it could be virtual, for example. Is this an option to make it a virtual, even for the physical assessment part? So that's my question.
طيب, thank you so much, Dr. Namariq. For the first question, I think before of that, we need, as mentioned before, to have an epidemiological data about the prevalence of PICS here in our country. As well, we can improve the patient experience by conducting qualitative studies, and after that, we can, or we could convince patient by attending the clinic after giving them more awareness about post-intensive care syndrome. This is the first thing. The second question, sorry. Yes, there is some studies conducted using virtual reality module. However, for the physical assessment, it's not possible that much as long as the patient is not attending the clinics. Some of outcomes like physical daily activity and so on need to be assessed on site, not virtual reality. And by the way, there is until now, there is no study compared virtual reality with on-site in terms of outcomes related to post-intensive care syndrome that can be assessed or can be discussed in virtual reality mode or in on-site mode. I wish I answered your question.
Excellent. From our dear audience, anyone who would like to ask about PICS before moving to the heated debates about anticoagulation? يا دكتور عبد الله ترى دكتور عبد الله الحماد.
السلام عليكم، صبحكم الله بالخير جميعا ويعطيكم العافيه دكتور عبد الله، دكتور نمارق، دكتور صالح. سؤالي للدكتوره نمارق والدكتور صالح، ما ادري في الليترشر اللي موجوده حاليا هل لاحظتوا بعض الدراسات اللي تكلمت عن الكارديو فيرجن مثلا بيوزنج اميودرون بلس مغنيسيوم versus before you start the anticoagulation? Would that be an approach at least في الاي سي يو before you anticoagulate the patient?
Thank you, Dr. Abdullah, for the question. So let's say most of these studies illustrated previously have discussed the initial management and briefly. So even though in very small percentage, some of the patients were initially cardioverted using electrical more than pharmacological previously, and some of the patients were using amiodarone initially before the cardioversion. So even though when we look back into any evidence to support this practice, again, this area is an area of a debate itself. So which agent I have to start first? Am I going to assess my patient whenever he or she was clinically stable or hemodynamically unstable patients?
Any points, Dr.
Yeah, I echo
Namara.
صراحة my colleague Dr. Saleh, and this is another area of debate. طبعاً we usually know that if the patient is unstable, they will usually cardiovert and then we start the infusion. Some, if they are stable already, so we start this 150 bolus and we start the infusion afterward. So this is another area of, you know, of a debate. إن شاء الله ممكن next year ولا شيء. So yeah, so here it's, we are just, if this episode occurred, regardless of whatever you know intervention done, should we give or not the anticoagulation? So that's, yeah, it's
Excellent. If you allow me, just there are two, I think, I think necessary questions to be asked. The first one is that we know that most of the used tools currently to assess AFib are driven from our colleagues in cardiology, so they are usually assessed on annual basis. Chad's VASC, maybe Hasbled. So there is still no validated tools to be used to assess AFib in ICU. So how do you think that using these tools can impact our judgment and assessments in ICU patients?
We need a Chad VASC score for ICU. That's what we need. That's the ideal thing.
Okay.
Until it comes, يعني.
Thank you. I would say the opposite, because literally, if you back again into the SHAD VASC, we will see that the patients were enrolled, they were not critically ill patients. So I cannot extrapolate the findings to those subgroup of patients, given the fact, the complex of the disease itself, the alterations in PKPD.
I think you're on the same page. So she's saying that we need a new tool.
Really? So?
Yeah. So you are on the same page. That's I think that's a wise decision. And think honestly, thinking about ICU patients, there are so many medications that we can utilize in ICU, IV, oral, new warfarin, and the DUAX and other stuff. So is there like specific agents during your study, Dr. Namariq, maybe in Dr. Saleh, that you would likely to vouch for to be utilized early on if you would like to initiate anticoagulation? He's already against.
Sure. So when we're back again, the only references that we have, the only 5 studies that already presented. So we will look into the practice or prescribing pattern of these patients. Most of these patients receive either low molecular weight heparin or they receive the heparin. And when we back into the first study, which is done by Wolke, 2013, we will find some of the patients initiate warfarin, especially in the critically ill patients. So when we look into warfarin, again, the alterations, as we just mentioned previously, pharmacokinetics, pharmacodynamics, definitely, we couldn't agree that it's an ideal approach to start anticoagulation in such case scenarios. So it was varied. Definitely the DUAX out of the question here. If we tend to use definitely the heparin as well as the low molecular weight heparin will be an ideal approach.
Excellent. Do you agree in the same?
Yeah, but يعني generally the start of warfarin, because many of the ICU patients, when they come with a septic, for example, they have this AKI, and sometimes this AKI would never resolve. Right. So usually the studies have said that the warfarin is the one that we are choosing, but that doesn't mean that it's like we cannot use the other if the kidney was fine. There is no study says that it's not safe, but because the ICU, usually their kidney function is not really good, so these studies have more looked into this warfarin thing. But again, we need to see the efficacy of both, the bleeding wrist and both. Maybe the agent in the bleeding wrist, it's different between this and that. And you know, the warfarin, it's gonna make our patients, the ICU, just discharge and they come again for anticoagulation clinics and so on. So if the anticoagulation is indicated, so I would really study and look into the a lesser option like apixaban or so on to be initiated for our patients, just to make the quality of life better for those patients.
Yeah. Is there any more questions? I have one more question. If our audience, any questions? Maybe one last question is that what would be the consensus of no situations in which you wouldn't definitely want to restart or start anticoagulation in certain patients? Is there like a certain patient population that you would definitely say, no, these are not good candidates for anticoagulation at the moment?
For myself, as I mentioned, if the JAD VASC score and he was not having any risk at all from the beginning, so this is a big no, so we're not debating here. But if the JAD VASC score was high, and based on the evidence here, and which patient I would go, no need, if, as I have said, that the episode was one episode, and it did not last long, and the patient does not have any risk factors like the arterial stretching or so on as per cardiologist. So we need to look at it from this perspective more than just general risk factors, because as we said, the risk factors in the community is not really applying in the ICU, and we make sure that the risk factor is gone. It's just a temporary and it's gone. It's not like a risk factor, for example, that is lasting. And one of the risk factors is ischemic heart disease. We don't know if these gonna have sequences after that or not. So that's from my perspective in general.
Dr. Saleh, Dr. Abdullah.
So I will back again to the evidence-based. Literally, I cannot rely on a well-trusted and a prospective study that support my decision. Even though the guidelines, they always recommend against the routine use of the therapeutic anticoagulation in such case scenarios. So I would say no, given the facts. I have no any evidence that support my decision.
Okay, Dr. Abdullah.
For me, I still not with full anticoagulation. But again, I think a new tool need to be established for those patients for more assessment.
Yeah, I think basically I'm biased because I'm mostly neuro ICU pharmacist. Therefore, I see a lot of ICH cases and TBI cases, and I think these are definitely a no-no situation at the moment to start them until they stabilize. Looking at also the median time for ICU, generally is roughly between 3 to 4 days. I think maybe using IV heparin is going to be reasonable until patient stabilizes, and maybe oral anticoagulation can be started in the floor. Do you think this is a reasonable approach, Dr. Saleh, Dr. Namarq, Dr. Abdullah? Or
probably, and if you give or take the safety profile for easily reversibility, yeah.
Do we have any more questions, colleagues? All right, with that, possibly we are coming to an end to our critical care session. Thank you so much for our esteemed speakers. It's been a pleasure, honestly, being with you. And also, thank you for the audience for sharing the stage with us also at this early morning. Without any further ado, thank you so much. And maybe we're going to have to start the next session now. Thank you so much.
Please join me, recognize Dr. Ahmed Al-Shaya and presenting with this award as a token of our debate's gratitude. Please join me and recognize Dr. Abdullah Al-Harthi and presenting with them with this award as a token of our debate's gratitude. Please join me in recognize Dr. Namarik and presenting with them with this award as token of our debate's gratitude. Please join me in recognize Dr. Salih al-Zahrani and present them with this award as a token of our deepest gratitude. Thank you so much, Dr. Bakr.
صباح الخير جميعا. قبل ننتقل للجلسة الجاية أنا حابة أول شيء أقول لكم إنه ترى عندنا جائزة مقدمة من دكتور هاوس، لاب كوت أو سكراب أو قسيمة، فأنتوا حظك. حاليا الكاميرا مان راح يختار واحد من الموجودين من الحضور بشكل عشوائي وبتتقدم له هذه القسيمة، فكاميرا مان بليز اختار لنا واحد من الحضور. تتوقعون من المحظوظ اليوم؟ وترى عندنا 3 غيرها، فاحنا طول اليوم بنعطيكم كل شوي قسيمة. نختار واحد. ألف 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 مبروك، تفضلي معنا على المسرح. تفضلي معنا هنا. تفضلي. وشكرا دكتور هاوس مرة ثانية. شكرا لكم. أحمد عندك الموضوع.
Our journey continues with the internal medicine session, expertly moderated by Ghazwa Karim. Dr. Ghazwa is consultant to the General Secretary of the Saudi Commission for Health Specialists and Associate Professor at College of Pharmacy, Prince Noura bin Abdurrahman University. She had a Bachelor of Pharmaceutical Science degree from King Saud University in Saudi Arabia and a PharmD from Nov Southeastern University in USA. She completed her BGY1 and BGY2 internal medicine at University of Arizona Medical Center. She also a board certified pharmacotherapy specialist, pharmacist. In 2017, she was appointed as College Pharmacy Vice Dean of Prince Noura University, then the acting dean of the College of Pharmacy at Prince Noura University until 2019. Currently, she is a consultant internal medicine clinical pharmacist at King Abdullah bin Abdulaziz University Hospital. In 2020, she was elected to be the chairperson of internal medicine specialized network board under the umbrella of Saudi Society of Clinical Pharmacy. Dr. Ghazwa has won several awards in teaching and research. His research focused on internal medicine, COVID-19, and pharmacy education. Dr. Ghazwa, please join us. Mic is yours.
السلام عليكم ورحمة الله. يسعد لي صباحكم جميعا. Okay, so we'll start with the internal medicine session. The first session will be about addressing hypertension in non-cardiac hospitalized patient, examining treatment outcomes. This will be presented by Dr. Umar Salami. And let me start by introducing Dr. Umar. Dr. Umar is a PharmD graduate from Jazan University in 2018, served as hospital staff pharmacist at Prince Sultan Military Medical City, earned PGY1 pharmacy practice residency from King Saud Medical City in 2020, currently serving as a deputy clinical pharmacy manager and internal medicine clinical pharmacist at King Saud Medical City, Riyadh. Please join me welcoming Dr. Umar.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you all for being here today. I would like to thank IHOP Scientific Committee for giving me this opportunity. For next 20 minutes, we will go through addressing hypertension for non-cardiac hospitalized patient, examining the treatment outcome. Starting with our objective for today, define the prevalence of hypertension globally and in specific regions, describe the prevalence of hypertension in hospitalized patients, explain the current practices of asymptomatic hypertension, and evaluate the association between treatment of hypertension during hospitalization and patient outcome, and predict the potential risk of and benefit associated with intensifying antihypertensive agent at discharge. Let's begin by looking at the global burden of hypertension. According to the WHO, hypertension affects over 1 billion individuals globally, most of them, or majority of them, living in low and middle income countries, and it's more in male more than female. For Arab countries, a systematic review by Taylor et al. Found that a prevalence of hypertension among Arab world about 29.5%. A larger study analysis that found the lower prevalence, overall prevalence of 21.7. A Saudi Arabian systematic review found that the prevalence of hypertension is about 22.6%, and this prevalence increased with age and more in male. Elevated blood pressure is commonly observed in hospitalized patients. A systematic review also reports a prevalence of 50 to 72% of hospitalized patients having hypertension, and up to 38% of hospitalized patients have no prior diagnosis. Now, let's shift our focus to a current practice. In inpatient setting, hypertension varies from hypertensive emergency with acute end organ damage to a mild asymptomatic blood pressure elevation. Determining chronic hypertension is challenging, as there is a lot of factors in hospital like pain and nausea, fever, that may raise the blood pressure also. Also the current evidence guideline address the hypertension among outpatient setting and hypertensive emergency. Healthcare provider often start or adjusting medication to control blood pressure in hospitalized patients, and believing that will benefit the patient outcome. The key question we will explore today is among adults with non-cardiac admission, is treatment of hypertension during the admission or antihypertensive treatment intensification at discharge associated with better outcome? To address this question, we will explore a series of studies that have investigated the impact of hypertension management in hospitalized patients and their outcome. Our first study we will examine is titled Clinical Outcome After Intensifying Antihypertensive Medication Regimen Among Older Adults at Hospital Discharge. This study was purposed to investigate the association between intensification of antihypertensive regimen at hospital discharge and clinical outcome. It was a retrospective cohort study in single center, and the participant was aged 65 years or over and with hypertension and admitted for another other than a cardiac condition. The primary outcome was a hospital readmission, serious adverse event, and cardiovascular event were assessed by competing risk analysis. Also, the secondary outcome was the change in systolic blood pressure within 1 year of hospital discharge. The study identified more than 14,000 older adults with high blood pressure discharged after treatment for various conditions. Among them, 13.9 had their antihypertensive medication adjusted upon discharge. A propensity score matching created to balance between the groups with similar baseline characteristic of blood pressure of 138 plus or minus 19 millimeter mercury. Turning to the primary outcome, in the propensity match cohort, patient discharged with antihypertensive regimen intensification had a higher 30-day readmission rate compared to those without intensification. Patient with intensification also more likely to have a ER visit for a serious adverse event within 30 days. However, within 1 year of discharge, there was no significant difference in cardiovascular event between the intensified and non-intensified group. Turning to the secondary outcome, patients discharged with antihypertensive regimen intensification were more likely to experience cardiovascular event within 30 days. There was no significant difference in mortality within 30 days. Also, there was no significant difference in any secondary outcome between the groups within 1 year. Also, among patients with well-controlled baseline, patients who received intensification were more likely to be readmitted and experience serious side effects. For patients with elevated baseline systolic blood pressure, there was no significant difference in the primary or secondary outcomes between the intensified and non-intensified group. The authors acknowledge limitations for potential of residual confounding dismissed the propensity score matching, short 1 year follow-up, and also a lack of generalizability among women and younger population. For the conclusion, the author concludes that among older adults hospitalized for non-cardiac condition, discharge with intensified antihypertensive was non-associated with the reduced cardiac event within 1 year, but was associated with increased risk of readmission and serious adverse event within 30 days. Shifting practice from intensifying antihypertensive regimen during hospitalization to communicating concerns about patient long-term blood pressure control to outpatient practitioner for close follow-up may provide a safer treatment path for a patient. Following the previous study, let's look for another one titled Treatment and Outcome of Inpatient Hypertension Among Adults with Non-Cardiac Admission. This cohort study conducted within the Cleveland Clinic Health System in 2017 with 1 year follow-up, excluding those with cardiovascular diagnosis. Demographic and blood pressure characteristic was used for propensity matching, and they investigated the association between between hypertension treatment during hospitalization and complication, such as acute MI, acute kidney injury, myocardial infarction, and stroke. For post-discharge, they track the patient for stroke and heart attack within 30 days and monitor blood pressure control within 1 year. This study included almost 23,000 patients. The mean age was 65 years or older, and almost 57 being women and 70% being white patient. Among these patients, 78% have at least one elevated systolic blood pressure. 33.1 of them received a new treatment. Treated patient has higher rate of chronic kidney disease and hypertension. However, treated patients were less likely to be asthma patient or COPD patient. For blood pressure level analysis, treated patient had more hypertensive systolic blood pressure measurement, also had more measurement per day, and a hypertensive systolic blood pressure was higher in treated patient. Patients with higher maximum systolic blood pressure were more likely to be treating. Continuing with analysis of blood pressure treatment pattern, hypertensive reading only small fraction, 8.2%, actually triggered the treatment initiation, which is surprising because all the study that found 80% of physician or resident physician believed that inpatient hypertension has a priority. This lower rate of treatment they observed may reflect the new evidence regarding the antihypertensive urgency among outpatient setting. Moving to inpatient outcome, treated patient was more likely to experience composite outcome. Treated patient had more incidence of AKI and myocardial injury. Stroke was extremely rare between the two groups. Length of stay after index blood pressure was not differ significantly between treated and untreated group. In these figures, both IV and oral medication were positively associated with composite outcome, AKI and myocardial injury. There is no significant difference were observed by route of administration, and all three outcomes increased odds were seen to each blood pressure interval, and stroke did not different by treatment route or index blood pressure. Likelihood of more than 20 millimeter mercury for systolic blood pressure decline was similar in treated and non-treated patients. Untreated had shorter time for the next systolic blood pressure. There is no difference in pre-index AKI rates, but slightly higher for myocardial infarction in patient in untreated group. Moving to outpatient outcome, 9.2 of hypertensive patients had new oral antihypertensive at discharge. In the 30 days post-discharge, patient with and without intensification had a similar rate of myocardial infarction and stroke. Similar blood pressure control over 1 year, and also treated hypertensive patient had a higher cardiovascular risk and more experiencing of AKI and myocardial injury. For the study limitation, the definition of treatment may have undercounted treated patient, biasing the finding toward the null because the actual harm associated with the antihypertensive could be greater, while the inclusion of patients with other conditions could confound the results. The propensity matching and falsification tests suggest the outcome were not confounding. The potential limitation means that the actual harm associated with antihypertensive treatment in hospitalization may be underestimated. For the study conclusion, in the cohort study found that 78 of adult patients admitted for non-cardiovascular diagnosis had at least one hypertensive blood pressure measurement, but fewer than this, their medication intensified, which is more surprisingly that only 8% of hypertensive blood pressure reading promoted medication intensification for even reading above 220. Paradoxically, treatment which presumably were meant to prevent the end organ damage was associated with higher rate of AKI and myocardial injury, that there is no, they found that no benefit associated with any treatment route or any blood pressure interval. Their findings suggested the hypertension among medical patients should be managed conservatively. Intensification of treatment discharge also does not appear to be helpful. Now for moving to the last study titled Impact of Intravenous Antihypertensive on Outcome Among Hospitalized Patients. The study investigated the effect of IV as needed antihypertensive on blood pressure, hospital length of stay, and mortality. It was a retrospective cohort study, involved any patient with order of IV as needed antihypertensive medication, and the outcome was the hospital length of stay and mortality associated with individual medication. For the sake of time, I will not go deep with this study, but they found that hospital length of stay was higher in the group that received IV antihypertensive agent, and multivariate analysis showed that receiving IV antihypertensive increased length of stay by 53% compared to the patient not receiving IV antihypertensive. Also, in hospital mortality rate were higher for those who received IV as needed medication, but this effect was not seen after adjusting or confounding variable in the multivariate analysis. The most frequently administered IV antihypertensive medication was hydralazine, and was having had the largest effect in reduced systolic blood pressure compared to other medication. Patients who receive IV hypertensive for systolic less than 180 had a longer length of stay compared to those with systolic blood pressure more than 180 before receiving the medication, but the mortality difference was not statistically significant. The study limitation is observational study, and it was single center and limiting the generalizability. For the conclusion, for patients diagnosed with asymptomatic hypertension during hospitalization, and reasonable study to first address any factor that affect the blood pressure, then focus in gradually reducing the blood pressure. Also titrating home oral antihypertensive medication, gradually adding new oral antihypertensive medication, and if oral medication not feasible, considering schedule the IV medication or continuous IV drip with specific blood goal reduction goals. For take-home messages, hypertension is very common among hospitalized patients, non-cardiac patients, with many undiagnosed. Intensifying antihypertensive treatment during hospitalization or at discharge was associated with higher adverse outcome with no benefit. For older non-cardiac patients, intensifying medication at discharge increased readmission and adverse event risk without reducing cardiac event. Also recommending for conservative approach, addressing the reversible factors and gradually up titrating or adding the medication rather than aggressive treatment. Further research is needed to determine the optimal blood pressure target and develop a clinical care pathway for this population. Aggressive hypertension treatment in hospitalized non-cardiac patients may do more harm than good, and more conservative gradual approach is recommended based on the current evidence. And thank you.
Thank you, Dr. Omar, for this great presentation. Please join me for the next session, the role of biosimilar and biologics in IBD, a patient-centered approach in value-based health, presented by our distinguished speaker, Dr. Abdelhamid Al-Thaqafi and Dr. Samah Al-Shahri. And let me start by introducing our speakers. Dr. Abdelhamid Al-Thaqafi holds a position as an assistant professor in pharmacy practice department at King Abdulaziz University, in which he is focusing on teaching undergraduate pharmacy students and guiding pharmacy interns. He's also the Deputy Director of Clinical Services of Pharmaceutical Services at King Abdulaziz University Hospital. He's a consultant internal medicine pharmacist. And I'll also present our second speaker, Dr. Samah Al-Shahri. Dr. Samah got her the PharmD degree from King Abdulaziz University and completed her PGY1 in St. Elizabeth Medical Center and her PGY2 in internal medicine at University of Arizona Medical Center. She's currently an associate professor of internal medicine at the Faculty of Pharmacy, King Abdulaziz University, and Internal Medicine Residency Program Director at King Abdulaziz University Hospital, Jeddah. Please welcome on stage Dr. Samah.
Good morning, everyone. I would like to take this opportunity to welcome you all in the clinical debate about the biosimilar and biologics in inflammatory bowel disease. Before I start this presentation, on the behalf of Dr. Abdelhamid and myself, we like to disclose that the view and the opinion expressed in this presentation are based on the current evidence and the guidelines in the field of pharmacotherapy, and they do not necessarily reflect our personal opinions, and we have no financial interest or affiliation that could be perceived as a potential conflict of interest in presenting this material. During this presentation, our goal will be to provide an objective and balanced discussion to inform and educate healthcare provider like yourself to provide regarding the biologics and biosimilar and inflammatory bowel disease. So before I start this refreshment about the inflammatory bowel disease, it's a chronic inflammation of the GI tract that can be classified either into ulcerative colitis or Crohn's disease. Both diseases can be classified according to the severity into mild and moderate to severe. Moderate to severe diseases characterized by remission and relapses of the disease, and it can lead to systemic manifestation. The role of anti-tumor necrosis factor in the therapy of both diseases they are only approved to treat moderate to severe diseases as an induction therapy with or without the immunomodulator, and also as a maintenance therapy to prevent the recurrence. And the most common examples of medication use is the infliximab and the adalimumab. There is other agents that be approved for one or other indication, but for the sake of this debate, our focus will be the infliximab and the adalimumab, as both drugs have biosimilars available now in the market. So I will start by the biologic in the IBD. I will defend the arm of biologics today. So before I start, 20 years ago, infliximab was the first TNF to be approved in the inflammatory bowel disease. And since then, there is a lot of randomized control trials, meta-analyses, large cohort studies, and also post-marketing surveillances that measured its efficacy and safety. And after that, the adalimumab start entering the market, and they have a lot of researches to approve its efficacy in the induction, maintenance, and also in reducing mortality, hospitalization, and also in the decrease of the surgeries in patients with ulcerative colitis. I'll start with some of the researches, which is the landmark trial to get the infliximab into the market. I'll start with first one, which is the Targan study. Was the first phase 3 trial that examined the efficacy of short-term efficacy of infliximabs in the treatment of Crohn's disease. This study showed there is 81% reduction in the clinical outcomes, which is the Crohn's disease activity index, and that for short time. And after that, the other landmark trial, which is the Accent-1 trial, which is extend its efficacy, and it's measured in the 45, which is a 1-year efficacy, and it showed that it can induct and maintains the efficacy. And of course, that extended to pediatrics. So in REACH trial, which is an open label, multi-center randomized control trial that include more than 100 pediatric patients, showed also the same efficacy. So it's good for induction and the maintenance for more than 1 year. And also they use the pediatric Crohn's disease activity index, which considered to be a valid outcome to measure the efficacy of drugs in Crohn's disease. Moving to ulcerative colitis, Act 1 and Act 2 trials is the main studies, the landmark studies in terms of the efficacy of infliximab in the adult in ulcerative colitis. Both are randomized controlled double-blind trial, including a huge number of subjects. Both showed to be effective in the treatment as an induction and maintenance for 1 year. And just worth mentioning that each study that I'm going to mention today is they measure the clinical response according to a validated score. Like in this example, they use the Mayo score and adding to it multiple other clinical outcomes, which is important to the disease of ulcerative colitis. Again, this efficacy was extended to pediatrics. In this it's a registry from Japan. They calculated patients more than 300 pediatrics, and they measured the response according to the pediatric ulcerative colitis activity index. And again, these medications showed to be effective and safe until 1 year in pediatric. Moving to the other agent for today, which is the adalimumab. Adalimumab efficacy in Crohn's disease was effective, approved by 2 major studies, which is the these 2 studies that I'm going to talking about it today, and both showed that this medication is effective, and again for 1 year remissions. And if you're looking at the results, it's also used the 70% point from the baseline change in Crohn's disease activity index. I'm keep mentioning the outcome because these 2 medication originator, it's the only one who measure the clinical efficacy in patient with the diseases. Moving to pediatrics, also, adult with ulcerative colitis, also we have the ULTRA-1, ULTRA diseases, which usually use the Mayo score also to improve activity as an induction and also maintenance. And all the studies that I talk about, it's also measure the efficacy and safety, and which showed that this medication is relatively safe. Again, all these as approved in pediatric, either in Crohn's disease in IMAGINE or INVASION in ulcerative colitis. Both show the efficacy in long-term safety in pediatric with irritable bowel disease. All right, I'm going to move to the other point of debate today, which is the satisfaction of physician and patients. I will take you to the story, what is behind these studies. Some of the countries, after the approval of the biosimilar, they start to mandate the non-medical switch, which means that the insurance company or other entities can switch patient from originator to biosimilars without ever getting back to the patients or the doctor. And after that, we have a huge volume of researches to discuss what is the effect of that non-medical switch on the satisfaction of the physician and the patients. I will start with the first US survey that found more than 80% of the physicians, they didn't want their patient to be switched to from the originator to the biosimilar if the patient was stable. And they referred this opinion due to the limited in the practice and monitoring guidelines for that switch, and also the potential of the payer-initiated mandate that changed based only on the cost and not on the, even if it's a small change in the efficacy. And they think that it may be lead to nocebo, which is mean the patients since they switch because of some of the psychological issue, some of the psychological belief, and they start to feel less effective and more side effects once they switch, even that the randomized trial or the blindness will not gonna see this effect. Another survey that been done found that the patient is not willing to switch to biologics by 26% and hesitate to that switch in 41%, and that's, they think it's according to a legal concerns and burden in the practice, because they think patient, once they switch from the originator to the biosimilars, they will start to have more frequent visit to the emergency department, to the physician, which can burden the practice, not helping in the cost reduction. And that reflected again on the patient themselves, which makes sense since the doctor is not feeling confident, then that confidence issue will be moved to the patients. So there is a survey that published in 2013 showed that some patients report less efficacy when they switch in infliximab biosimilars, and that's a significant reduction in the efficacy. Again, this is not a clinically approved because it's subjective efficacy, and adding to that, all patients in the study who's transferred from the originator to the biosimilar experience high level of side effects, which also statistical significant difference. And in another study, some of the researchers start to frame biosimilars as a gold alternatives, which mean they try to increase the confidence of the public to the moving from the originator to the biosimilars. And again, the results of this study showed that even if we frame this medication as a gold alternative, their reference product will not gonna impact the public confidence in this medication. All right. The last survey I'm going to close the satisfaction with is a huge, large survey that happened to all patients who switched in Canada, because it's one of the countries that mandate the switch. It's Crohn's and Colitis Canada National Survey. They did it, or they performed this in conjunction with the Canadian Association of Gastroenterology. And in Canada, they before the switch, there was a 9 in 10 respondent was stable in remission before that switch. After the switch, 5 of 10 responded was experienced worsening of the health immediately after the switch, and that translated to 1 in 10 report they are having emergency visits or hospitalization, and 1 in 10 having undergo multiple tests and follow up by the doctor visit to ensure that this switch was going in the right direction. And 1 to 2 years after that switch, 8.5 from the patients only continue on the biosimilar, while 1.5 switched back to the originator medication. And regarding this survey and report, the Canadian Association of Gastroenterology start to take that mandation from the guidelines, and now they're not recommending anymore the direct or mandated switch without, which is the non-medical switch. Talking about the safety, I think medication being in the market for more 20 years, we cannot question the safety at this point, since there are multiple registries all over the world, and there is a lot of data documented about the safety after 20 years of being in the market. Adalimumab by itself have the largest safety database in all the anti-TNF medication, and it has a registry for all the 11 conditions, including the inflammatory bowel disease, and usually it's evaluate the long-term safety of Humira in the global clinical trials too. And now I will move to the other arm of the debate with Dr. Abdelhamid Al-Thaqafi, who's going to defend the status of the biosimilar in inflammatory bowel disease.
Assalamu alaikum wa rahmatullah. Well, first of all, thank you all for having me. And first, when we received the invitation from the organizing committee regarding the being a participant and speaker, so with the idea of the medical debate or scientific debate, I thought we should really take the advantage of this debate and focus on one major aspect or international debate going on in the world of IBD, which is between the biosimilar and the biologics, especially in the treatment or in the place of the treatment of the biosimilar in the guidelines. But first, let's start what really biosimilar means. So what is a biosimilar? Biosimilar usually, or they are biologics that has the same effect as biologics in terms of safety, purity, and efficacy. In the same time, they have a smaller molecular size, so one can assume that they are relatively less immunogenic than biologics. To detect a biosimilar, the generic name usually go with the 4 attached letters to the biologics. So these letters, as you can see here, they have to be lowercase, only letters and no numbers. So this is the only way that we can detect the biosimilar and the scientific name of biosimilars. When we talk about biosimilar and to understand the approval process with the FDA, we have to talk about 2 important definitions: exploration and interchangeability. So what exploration basically means, that if the biosimilar is approved with the biologics for the same or one disease state as the biologics, it can be approved for other disease states without going through clinical trials, only with the equivalency studies. While interchangeability means FDA will mandate the manufacturer to have clinical studies that actually show us lower or not inferior efficacy and safety profile to biologics. However, the terminology interchangeability is falling out of favor because it will put obstacle with the approval process. The definition or the terminology of exploration has streamlined the approval, with decreasing cost, leading to decreasing cost and leading to increased patient accessibility to medication, especially in IBD, where the choices for severe or moderate to severe patient are really limited. So the indication of biosimilar in IBD, there's usually, or you have 3 main indications: moderate to severe active Crohn's disease in patients who did not respond to steroid or conventional treatment; fistulating active Crohn's disease in patients who did not get better in drainage or in receiving antibiotics; and in moderately to severe active ulcerative colitis in patients who failed 6-mercaptopurine and azathioprine. So this is just to show you the booming manufacturing and how rapidly is growing the manufacturing of the biosimilar in our field. The biosimilar of infliximab, we have 5 different products, started in 2013 and now is 2021. And we have the Remsima and Inflectra. They both were approved in Europe 2013. However, in US they were approved in 2016. Why is that? Is because the terminology or the mandate of the FDA that says they have to have interchangeability studies. This is another example. We have the adalimumab biosimilar. In the last 7 years, we have 10 biosimilars that is going on from 2016 and 2023. And this is just to show us that the field is rapidly growing and the approval process is getting faster. So worth noting here is the launch date for all the biosimilar was 2023. Why is that? Is because of the legal settlement between the manufacturer or the original drug, and biosimilar. Now let's dive into some scientific data regarding the use of biosimilar and how is it compared to biologics. We have 3 different studies, the PROSET Bio and PROSET Bio Prolonged. So these 2 studies are prospective and multi-center trials. They included a high number of patients. However, both of them are observational studies. The intervention in both of them were anti-TNF arm, previous exposure arm, and switch from the infliximab arm. The other study, which is a NOR-switch study, is one of the major studies that was done to compare the efficacy and safety of biosimilar and biologics. It was an RCT, or rapid randomized control trial, with a number of 482 patients. We have 2-arm Crohn's disease and ulcerative colitis patients. Both has received infliximab and biosimilar. And if we take a look at the data and the efficacy trials and the safety trials for both arms, we can see the PROSET Bio and PROSET Bio Prolonged had basically comparable efficacy and safety profile when compared to each other. When we see NOR-switch trial, we see mostly, or infliximab has a little bit higher safety profile than a biosimilar. Another indication, or another study that investigated the use of biosimilar in active Crohn's disease or active naive Crohn's disease. This is an RCT, a multi-center randomized control trial with a phase 3 trial. We can see that in week 6 and weeks 14, week 30, there's no differences between biosimilar and infliximab in terms of efficacy. And this is one of the largest studies that was done to compare biosimilar and biologics. This is a real-life comparative equivalence study. It was done in France. They used a nationwide health database. We can see in terms of all-cause mortality, all-cause hospitalization, Crohn's disease-related hospitalization, and surgery-related hospitalization. We can see that there's no differences between the 2 arms, the biosimilar and biologics. Now let's dive into one of the most important aspects in the biosimilar, the cost. So this is just an example of how much does it cost to treat a patient in 1 year with the brand name of adalimumab, and then compared to the other biosimilar available. We can see there's almost a 20% or 30% differences in price range. Another example is the infliximab and its biosimilar. We can see also the differences between the brand name and the generic names. We can see the difference in price in 1 year between the biosimilar and biologics. And this is where with Dr. Samah that has the counteract for the biologics.
All right, back to the first defender, which is the biologics again. So after you hear both sides of the story and both clinical sides of the story, it's now just to challenge each other's opinion. I will start with the efficacy. So again, both originator in the market for more than 20 years with a huge body of evidence, and the approval of them was happened during a landmark trials. Other thing to worry about is that the moderate to severe disease, irritable inflammatory bowel disease, is a disease with high relapse rate. So even if there is any change in the efficacy, that might lead to hospitalization, admissions, and also increase in the morbidity in those patients. Most of the result that Dr. Abdelhamid represent is based on the totality of evidence, which means that the safety of these biosimilars is usually be due to the approval of the first medication. That being said, there is no specific safety profile was done to any of these biologics. Most of it is as a totality of evidence, which mean that if the biologics is approved in an indication, then the biosimilar will follow that indication. Other issue with the biosimilars is that the patient and physician satisfaction. Until now, there is no that much confidence in the biosimilars in the treatment, and we all know that these diseases, some of it is having an autoimmune part of it, which can be affected by the psychological beliefs of the doctors and the patients. Biologics have specific indications in a population like pediatrics, since there is a landmark trials that challenge this efficacy in pediatric population. And again, biosimilars use the extrapolation of the result, which mean that they extrapolate the data from the biologics to biosimilars, which sometimes not being transferred 100%. We are not talking now about brand generic switching. We're talking about biologics biosimilar switching. Other issue that raise now and on when we will switch from this medication is the immunogenicity. And the patient, if they switch from one biologics to the other, they start to develop antibodies from this agent, and that may be decrease in the responsiveness to the biologics at all. The non-medical switching dilemma that I just talked about, and how that will impact the practice and impact until some of the country they take it back now from their policy, and all the dilemma is behind the non-medical switch. And if you do a studies about the cohort or is not blinding study, again, you're gonna find some of the patients psychologically not preferring this agent. And again, as Dr. Abdul Hamid mentioned, there is a price changes. Yes, biosimilars is cheaper than the biologics by all means, even if we take it on all levels, it's cheaper. So there is a new study that published about the international impact of introducing these agents in the market, and they conclude that the policy decision should not be based on the price, because if it's really based on the price, then originator manufacturers should consider reducing their prices or start to negotiate the prices, like what happened in a huge purchase of the medication, like in Nopco, for example. These agents start to reduce to be in the market again. And to be honest, once the originator will decrease their prices, then that will change everything. So biologic will still be the drug of choice, since we getting away from it due to the price only. By that, I will switch back to the other arm to defend the opinion. Dr. Abdul Hamid.
Okay, thank you. As we all see from the presentation and the talk, so more the strength of the biosimilar is basically cost, right? All the study that was done says biosimilar are really the same as biologics in terms of efficacy and safety. Some of the patients dropped out of the literature or dropped out of the study because safety concerns, inefficacy concerns, but these percentages is not really that high. In terms of cost, as we saw, that biosimilar is relatively cheaper than biologics, and in our country we're moving toward cost minimization. The other thing is safety profile, which is showed through the study. There is not a lot of concern that says patients should have a different or special treatment if they were on biosimilar. At the end, I want to leave you with this note. The National Biotechnology Strategy has published recently, in January 2024, their guideline, and in the guideline they basically stated to build a state-of-the-art local end-to-end biomanufacturing platform to increase self-sufficiency, allow for the opportunity to export biologics and biosimilars globally, and also to foster biosimilar penetration. And this is specifically stated, to foster a biosimilar penetration into the market. So moving on, I think we're going to see more and more biologic and biosimilar in the market, especially biosimilar in the market, because it's a lot cheaper than biologics. And that's it. Thank you. And if you have any question.
Thank you. Thank you, Dr. Samah and Dr. Abdul Hamid, for this great debate. I'm sure that a lot of our audience and ourselves have many questions to ask and see which side to take. But let me start first with the first session where it was addressing the hypertension in non-clinical cardiac hospitalized patient, asking you, Dr. Umar. It seems that most of the studies that you presented were against intensifying treatment in patients who are hospitalized. If you had a patient with asymptomatic, moderately elevated blood pressure in the hospital, what would be the approach to manage their hypertension, and is there any different target that you would have for those patients? Because we know that most of the guidelines talk about kind of patients in the outcare setting, but there are limited guidelines that guide the clinician to decide on the management of patients in hospitalized setting.
Thank you, Doctor. As you said, for outpatient treatment of hypertension, there is current guidelines address this issue. For inpatient, they should, for asymptomatic mild hypertensive patient, they should do as well as outpatient practice. They should give a follow-up with OBD. No need for aggressive management at inpatient setting. You can start a medication on inpatient at discharge, but for the target of same as OBD or same as ambulatory care services.
I would like to check with the audience of if any of the audience here has any questions directed to Dr. Omar about his session. All right. So maybe I'll ask you, Dr. Omar, this question. So how can you rule out that the increase in blood pressure in patients who are admitted in the internal medicine ward is not a pseudo hypertension, where it is caused by the disease itself, pain? You might increase the blood pressure, agitation, all of these infection, all of these kind of factors could be the cause of the increase in blood pressure. So how could you assure in patients that this is not caused by all of these patients, or does this affect any of the management, or your decision will be regardless of these factors being present in the patient?
As I said in the beginning of the talk, it's difficult to determine this hypertension is a real hypertension. Is the patient for chronic patients it's okay, but for not having hypertension before, it will be difficult to determine if it's because of the factors related to the hospital or related to the disease, or it's real hypertension. This is actually difficult. It needs some days, wait for multiple 2 days or 3 days. If still there is a hypertension, we can add a new medication, but with a target as well as outpatient management.
If the patient is already on hypertension medication and was admitted to the hospital, would you rather to go up on the dose that the patient is present on if there is room, or would you add another agent? What would be the approach or the ideal approach?
Actually, it also it should be treated as well as outpatient or ambulatory care for hypertension. Adding if the patient with stage 2 hypertension, it need to be on 2 medication rather than increasing the dose or titrating up the dose.
Thank you so much. I believe this closes the question for the first session, and moving to the debate between Dr. Abdelhamid and Dr. Samah, which was very interesting to see both sides of the biosimilar and the reference products. I would like to ask you, what do you see, or what is the future of biosimilar in IBD management?
Well, I think, first of all, regarding the studies that is done or currently to compare biosimilar and biologics, all the studies, most of them are observational studies and cohort study, retrospective studies. I would like to see maybe in the future, maybe there's local data, first of all, that prove or can improve clinical decision making for clinician. More studies, of course. The penetration of the biosimilar in the market, I think that's really a huge factor. If the logistics around it can be facilitated.
Okay. I would like also to see if any of the audience has any questions related to the debate presented by Dr. Samah and Dr. Abdelhamid. Any questions from the audience? بس نحتاج المايك هناك.
Assalamu alaikum. Thank you, Dr. Hamid and Dr. Samah. My questions regarding the biosimilar use in the IPD patients. Thank you for addressing the facts and the fears in terms of switching to the biosimilar. So the first questions for Dr. Abdelhamid. Which population or which criteria you would like to switch to the biosimilar? And the second questions for Dr. Samah, in terms of a fear of the physician to switch to the biosimilar because the efficacy and the safety is not well recognized, and most of the studies is based on the observational study. So what population we don't want to switch to the biosimilar in IPD patients?
Well, thank you for the question. Really interesting questions. For which criteria that we can use to switch to biosimilar or start patient with biosimilar, according to the current studies, we only have moderate to severe patient with ulcerative colitis and Crohn's disease, patient who proved to have anti-TNF factor for their treatment. So first of all, they have to test for the anti-TNF. If the problem was the anti-TNF for sure, then the switch can be discussed or the start of the biosimilar can be discussed. Keep in mind that all the studies or most of the studies was switching between or from biologic to biosimilar. Only a couple of studies that was done that investigate only or start patient with only from biosimilar or the patient called anti-TNF naive patients. So I would, to sum up my question or the answer, Crohn's disease, ulcerative colitis, moderate to severe with anti-TNF factor. Thank you.
With the monitoring, so we can switch safely with the frequent monitoring?
Yeah, so for now, all the study that was done is resemble the one that was done in biologics. So all the monitoring that was done in biologics, they would go the same as the biosimilars. There's no advantage in that part that switching to biosimilar would have the advantage of not monitoring or things like that. No.
Sure.
Thank you for your question. So your question is about when you think it's not appropriate to switch from biologics originator to biosimilar. I think as for today, I'm talking about the status of the evidence for today in pediatric, in high-risk patients like in pregnancy, because we're using this agent with all the cautious when we use the originator, which is in the market for 20 years. So I don't think this is an area that we feel confident to switch. Even when they do the non-medical switch in other countries, they exclude these population. That being said, this is the status for today. If these medications show to be safe and effective in the future, there is no need to have that worries. And you mentioned something about the physician satisfaction. If we get back decades ago, that was the feeling when we switch from brand to generic. We know that brand and generic is the same now, right now, but back then, that was a huge thing in the manufacturing, bioavailability, biostability, shelf stability. So that was an issue that makes some of the physicians hesitate from switching from brand to generic. We know that we passed this age. And now we are in the same stage again between biologics and biosimilar. How we overcome that when we talk about the generic brand switching? It was by education and huge body of evidence that make all physicians confident. And once you got the confidence of the physician, automatically that will be translated to the confidence of the patient. If the patient don't feel like switching, all the studies showed that if the patient don't feel like switching or the physician is not confident with that switch, that will affect the outcome, even psychologically, but that will affect the outcome. So I think that our goal is to increase that satisfaction by the education, evidence, and the whole behavior of our practice to be that's an option, is not a mandated option. We all know that no one likes to mandatory changes to other agents. So I think that's the area that we should supposed to focus on in the future.
شكرا يعطيكم العافية.
Any other questions from the audience? Okay. It seems that like patients' physician satisfaction is a major issue. Even you just briefly discussed, Dr. Samah. What do you think are some of the modalities that might be used to improve these satisfaction? Education is enough?
If we see the surveys that is done for all the medication that for patient satisfaction and patient experience, all these parametrics are subjective, of course. So one of the things is perception. If we can change the perception, first of all, for the physician who will prescribe the biosimilar for the patient, and clearly educate the patient regarding the use of biosimilar and how is it similar to the original medication, I think that will build some confidence for the patient, and the experience with the patient in the treatment will go smoothly. So the key player or the stakeholder here are the prescriber. So as long as an adequate education is going on for the biosimilar, I think that will be one major factor.
I just want to add to that about the study that I discussed, which is regarding when they promote the biosimilars as a gold alternative or the gold alternative for the biologics. That didn't change the confidence of the patient to the medication, because we know that patient nowadays is checking in the websites and Google about information before even came to the doctor office. So they already have that in mind. If you check the Google, for example, a couple years ago, you will find a lot of skepticism about this medication. You will find a lot of high voices, do not switch us, our care matter, our care is better than the cost reduction. And it seems like if you check today's on the same phrases that you used before, you're going to find a lot of evidence to support the use of biosimilars. So I think the change starts from the company itself. If you open, for example, any major medication company, you're going to find an article or two discussing how biologics is similar in form that all the public will read. So I think something like that, advocate from the companies themselves, from the organization. So that will make there's a body of evidence. When the patient check for themselves at home, they will feel confident before even coming to the doctor office. But just telling them it's a good medication that's not working nowadays on our patient.
Thank you. Thank you so much, Dr. Abdelhamid and Dr. Samah. I will be closing with this last question coming from the audience. What is the role of internal medicine pharmacist in biosimilar in all aspects of pharmacy?
Well, this is a really important question. As a clinical pharmacist in internal medicine, I think one of the things is to patient education, or physician and patient education, first of all. Second is literature and research. So currently there is some use of biosimilar in patient with IBD. So collecting this data, doing research regarding it or about it to investigate more, I think this is one major aspect. The third thing is monitoring. So as we know, IBD is a long-term chronic disease. The use of clinical pharmacist or ambulatory clinical pharmacist in a GI clinic would be very beneficial. Why is that? Because medication usually go from the pharmacist, right? So I think this is one of the most important thing. We can see that in the future also.
Okay. I will ask if there is any more questions from the audience, or we can close the session. Okay, thank you, Dr. Omar, Dr. Abdelhamid, and Dr. Samah for this great session, and I hope you enjoyed the session. And thank you for the audience for being here and staying up to this point. Thank you so much.
Thank you for our speakers for such informative sessions. And now I would like to invite Dr. Abu Bakr Umar to honor our speakers and moderator. I would like to invite Dr. Umar Salami. دكتور عبد الحميد الثقفي. دكتور سماح الشهري. دكتور غزوة كريم. دكتور عامر العروي. Ladies and gentlemen, سيتم إعلان نتائج المتأهلين من مسابقة التثقيف الدوائي وأيضا صيدلة المستشفيات في تمام الساعة 1. So excited to see who will be with us tomorrow on the stage in the final round. Now let's take a break and we will continue our sessions after the announcement at 1 p.m. Thank you.
الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أسعد الله مساكم بكل خير. نرحب فيكم في اليوم الثاني من مؤتمر IHOP. نتمنى أنكم مستمتعين معنا إلى الحين، وإن شاء الله القادم أجمل بإذن الله. احنا معكم اليوم إعلان عن المرشحين لخوض نهائي مسابقتين مهمة جدا معانا بإذن الله. نبدأ. المسابقة الأولى هي مسابقة العربية للمشورة الدوائية، كذلك مسابقة صيدلة المستشفيات. وبداية مع المسابقة العربية للمشورة الدوائية مع الدكتور محمد المزنعي، تفضل.
السلام عليكم.
طيب، أول شيء نرحب بالدكتور محمد المزنعي، وحابين نسألك كم سؤال بخصوص المسابقة كذا. كيف كانت عدد المشاركين، الناس المتأهلين معانا، وكيف كانت أجواء المسابقة بشكل عام؟ صعبتوا الأسئلة؟ سهلتوها؟
طيب، يعطيك العافية أخوي فيصل. شكرا للجميع للحضور. الحقيقة المسابقة العربية هذه هي النسخة الرابعة. كان في تنافس السنة هذه. أدخلنا الجامعات العربية. كان عدد المشاركين تقريبا 14 جامعة محلية و7 جامعات عربية. الجامعات العربية غالبيتها شاركتنا عن طريق الأونلاين، وكان في منافسة جدا رائعة. صراحة يعني هذه تبشر بجيل من الصيادلة إن شاء الله مبدعين ومتميزين في التثقيف الدوائي. إن شاء الله من خلال الإعلان إن شاء الله الحين عن ال5 متأهلين بتشوفون كيف كان حجم التنافس بين الجامعات المحلية وأيضا العربية.
الله يعطيك العافية دكتور محمد، ولا شك
الله يعافيك
أنها منافسة قوية بإذن الله. طبعا عندنا 5 مراكز و6 مرشحين، أظنها واضح. طيب، عشان لا نطول عليكم ونستعجل بوصولكم له الجدول العلمي بإذن الله، نبدأ على طول بأسماء المرشحين. في المركز الخامس العلوم الطبية التطبيقية الأردن. المركز الخامس مكرر الجامعة الأمريكية اللبنانية. في المركز الرابع جامعة المعرفة. المركز الثالث معانا اليوم جامعة حائل. والمركز الثاني جامعة الملك خالد. أخيرا وليس آخرا في المركز الأول الجامعة الهاشمية الأردن.
فوق المتأهلين حظ أوفر للجامعة اللي ما تأهلت.
غير متأهل لا يعتبرون خسرانين. الجميع معنا فائز. نشكر الدكتور محمد المزنعي على هذه المشاركة. الله يعطيك العافية دكتور.
يعافيك إن شاء الله.
وننتقل سريعا للمسابقة الثانية، مسابقة التثقيف الدوائي مع الدكتور عواد الجهني. عفوا، مسابقة صيدلة المستشفيات. حياك الله دكتور عواد. حياك الله معنا دكتور عواد. حابين ناخذ عنك معك فكرة بسيطة عن أجواء المسابقة وكيف كانت، عدد المتأهلين، عدد المشاركين في الأصل، كيف كانت أجواء التنافس، وبرضه أظن عندكم أسئلة صعبة
جدا.
تفضل.
يعطيك العافية دكتور. الله يحييكم جميعا في IHOP. احنا صراحة
في صيدلة المستشفيات. فخورين جدا بالكفاءات والقامات اللي شاركت معنا. مسابقة صيدلة المستشفيات از بريف احنا في النسخة الرابعة الآن. بدأنا مسابقة صغيرة يعني كانت تقريبا محلية وحول تقريبا 10 مستشفيات، ونمت مع نمو المؤتمر اللهم لك الحمد. اليوم احنا وصلنا إلى تقريبا 45 مستشفى بتوتال تقريبا 90 فارماسيست 90 فارماسيست من المينا ريجن. اللهم لك الحمد. يعني السنة هذه كان ضيوفنا من خارج المملكة، كانوا عندنا من الإمارات، من عمان، من الكويت، أيضا من البحرين، وعندنا من المنطقة العربية، عندنا من لبنان، عندنا من الأردن، وعندنا أيضا من تونس، وعندنا أيضا من مصر. وفي بعض الزملاء يتعذر حضورهم، ولكن إن شاء الله نستضيفهم في النسخة القادمة بإذن الله. طبعا مسابقة صيدلة المستشفيات هي عبارة عن مسابقة تجمع التعلم والمتعة. فيعني it has to be a mix. Even studies يعني showed إن الفن if it's mixed with education it will be better، وبصير يعني المعلومة بتكون أفضل بالنسبة للمتسابقين. فحنا فخورين بالناس اللي تأهلوا معانا، وزي ما قال الدكتور الجميع كسبان يعني. فإن شاء الله اللي ما حالفهم الحظ النسخة هذه حالفهم في النسخة القادمة بإذن الله. الله يعطيك الف عافيه دكتور عواد، واكيد انها منافسه قويه لمسابقه مهمه جدا. طيب نبدا باسماء المشاركين قبل لا نقول المتاهلين منه. بدايه مع المشارك الاول كينج فيصل سبيشالست هوسبيتال. المشارك الثاني Lebanese American Medical Center Rest Hospital. King Fahd Medical City. Armed Force Hospital Southern Region. King Abdulaziz Medical City. جازان سبيشالست هوسبيتال. حرق النتيجة. كينج سعود ميديكال سيتي. كينج حمد يونيفرسيتي هوسبيتال. كينج عبد العزيز هوسبيتال. واخيرا كينج عبد الله بن عبد العزيز يونيفرسيتي هوسبيتال. طيب طبعا الكومبيتيشن كانت حاميه جدا، والاسئله يعني دكتور محمد شناوي توسط ان نحاول نخليها اسهل، لكن احنا يعني ما انصحنا للطلب هذا للاسف. يعني ما شاء الله الكفاءات عاليه، وكان في كلوز جاب بين المتسابقين. فطبعا تخصص الرياض ما شاء الله تبارك الله في المركز الاول بتوتال 89,000 نقطة. المركز الثاني بفرق بسيط جدا اللبنيز أمريكان ميديكال سنتر. المركز الثالث كينج فهد ميديكال سيتي رياض بتوتال 86,000 نقطة. والمركز الرابع كينج عبد العزيز ميديكال سيتي الحرس الرياض توتال 83,000 نقطة. المركز الخامس من نصيب جازان سبيشالست هوسبيتال بتوتال 79,000 نقطة. وطبعا معنا التوب 10 زي ما ذكرهم الدكتور، وان شاء الله حظ اوفر في النسخة القادمة باذن الله. التوب 5 ان شاء الله بيكونون معنا بكرة في النكست ستيج على المسرح، يتنافسون باذن الله لايف امام الجمهور. الله يعطيك العافية دكتور عواد، نشكر لك صعودك معنا، الله يعطيك العافية. نشكر جميع المشاركين. انا امانة اشوف انه مستشفى النور التخصصي كان المفترض يقوم من القائمة هذه، مو عشان تدربت فيه ومتحيز، لكن أشوفه فعلا يستحق. لكن نختتم بكلمة مع الدكتور محمد الشناوي، تفضل.
شكرا جزيلا، يعطيكم العافية. يمكن أكبر رابح في إعلان النتائج هو IHOP. احنا كلنا يعني في IHOP كسبنا وجودكم معنا، كسبنا الرابحين، كسبنا المتسابقين. ما في عندنا احد خاسر واحد فائز. عندنا كلها اللي خسر كسب خبرات كبيره جدا ممكن ان هي تؤهله وراح يطلع بعد اي هوب بشكل مختلف عما قبل اي هوب، واللي هيكون بكره موجود معنا بعد الظهر ان شاء الله على الستيج اكيد راح يبذل قصارى جهده ان هو يحصل على الجائزه والجوائز الاولى. فالجميع رابح. اهنئ المتسابقين الخمس اسماء في المسابقتين، واهنئ ويعني اتمنى انه يكون وجود المتسابقين اللي طلعوا. This is not the end of the world. This is the start of it. وان شاء الله القادم افضل لكم. يعطيكم الف عافيه.
الله يعطيك الف عافيه دكتور محمد الشناوي، يعطيكم الف عافيه على حضوركم معنا. نستكمل معكم باذن الله البرنامج العلمي ونلقاكم في وقت لاحق على خير باذن الله. شكرا لكم.
Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests, colleagues and friends, it's my honor and privilege to welcome you all again to this esteemed IHOP 6 conference. The program we have curated for you today promises to be both thought-provoking and transformative, addressing some of the most pressing issues faced by professionals in today's rapidly evolving landscape. We will begin our journey with a profound exploration of leadership. In this session, we will delve into the essential qualities and strategies that empower leaders to build cohesive, high-performing teams and navigate the complex dynamics of modern organizations. Attendees can expect to gain invaluable insights that will serve as a strong foundation for their own professional growth and betterment of their respective fields. This session will be moderated by Dr. Muhammad al-Shannawi. Dr. al-Shannawi, please, the mic is yours.
شكرا جزيلا يعطيكم العافية. It's my honor to introduce my friend Prof. Amir Al-Ainizi, the Dean of King Saud University College of Pharmacy. Prof. Amir, he graduated from the United States of America with a PhD degree in pharmaceutical technology as a major. He is currently working as a dean at the College of Pharmacy, King Saud University in Riyadh, and a consultant for the Saudi Council for Health Insurance, CCHI, with more than 20 years of experience in the fields of pharmaceutical research and development and innovation, pharmaceutical technical operations, business and markets developments, pharmaceutical logistics and supply chain. He was a biotechnology consultant for Riyadh Valley Company. He was also the vice president for Tabuk Pharmaceuticals Company, heading their technical operations. He was also working with Kaibura Emerging Markets Organization firm based in the United States and focused on the healthcare sector and as a consultant for their MENA region operations. Please welcome with me Prof. Amir. Prof. Amir, he will talk about the supply chain initiative in the kingdom. Dr. Amir, please.
الله يعطيك العافية. السلام عليكم ورحمة الله وبركاته جميعا، وأسعد الله مساكم بكل خير. في البداية حقيقة جمعة مباركة على الجميع، وأسأل الله أن يتقبل منا ومنكم صالح الأعمال. أود أن أشكر أخي أبو أحمد سعادة الدكتور محمد الشناوي، دكتور أبو بكر، وبقية الزملاء في هذا التجمع الجميل حقيقة والغير مستغرب على مجتمع الصيادلة. سعيد بتواجدي بينكم في هذا اليوم المبارك، وأشكر لهم على يعني الدعوة، وما شاء الله الأجواء الجميلة والحضور. حقيقة يعني بتكلم عن موضوع يمكن شوي يعني مختلف شوي عن النورم اللي نسمعه من مجتمع الصيادلة. بعرج على أشياء يعني ممكن أبدأ بالمسج هذه. أنا أعتبر drug supply chain هو البلو أوشن للفارماسيست and I think I have to switch in English. So I think I'm just now addressing the pharmacists who are about to be graduate or who are now on the job place. So drug supply chain, it's a competency that you need to have. Pre-COVID-19 era, totally different than the post-COVID-19 era. It's a competency that we all, as a pharmacist, as a leaders, as any healthcare giver, you need to have. So I will. Can I use this one to? Okay. So before this, I will talk about the robust supply chain networks. It's not just a chain; it's a real network, and how this can lead to a national drug security. We all now caring about the national drug security. So first off, I have no any potential or any conflict of interest in delivering this talk. So my objectives in delivering this in around 30 minutes or so, so to use the COVID-19 as an example on the supply chain disruptions. Either you are in a manufacturing facility, you are in a hospital setting, you are in a regulatory body, you are in an investment or funding agency that has to do with health insurance. We all were impacted by this global pandemic few years back. So, and the second part of my talk to propose and some solutions. If you are in the tender business, you are in the hospital, inventory management, you are in the manufacturing facility, what are some of the solutions that you can apply to at least ease out or help to, avoid such kind of disruptions? I keep getting back and forth in slides. And by the end, we need to understand, and hopefully I can convince all of you that robust drug supply chain, it's a gateway, leads to a national drug security. So in other words, without having a robust supply chain networks, we will not be able to achieve a national drug security. الأمن الدوائي الوطني. I have to use the green one. So what is supply chain? Just basically, before I dig deep. So there are many definitions. So in the industrial setting, I'm just here focused on the healthcare supply chain. So it is the connected chain of all business entities. You're talking about the procurement, purchasing, planning, either demand or supply. We're talking about the production, distribution, transportation, fulfillment center, all the way until you reach the customer. So both internal and external to the company, and then to support the logistics function. So this is a typical drug supply chain. So because when we talk about a chain, people tend to think it is a plan or a chain. It is a highly complex, highly dynamic. The interactions going on a, on a daily basis. So you have what we call it the upstream of the chain. So you have the planning, the sourcing. You are dealing with different kind of suppliers. Then you have vendors. Vendors that are at different level, tier 1, tier 2, tier 3. So there are some complexities also there when we are dealing with the suppliers. Then you have the manufacturer itself. So the manufacturer, here we're talking about if you are a hospital, then you are not directly interacted with the manufacturer. You are dealing with the vendors or suppliers to procure the medicines and start maybe the tendering or the dispensing of those medications. So then you have the delivery and again the customer. And the customers here are different levels. It could be the community pharmacy, it could be the polyclinic, it could be the patient itself. So it depends on where you are in this complex system. So, and the reason I'm showing this, because there are a cost, and when there is a cost, then there is a value associated with this cost. And we as now with the transformation program, the healthcare transformation program, we want to provide a value, not just a service. So we're moving away from just providing the service into providing an access and a value. So there is a cost associated with the supply chain. Either it could be a material cost, like buying those raw material, finished goods, work in progress material. It could be, then you have the manufacturing cost, the transportation cost, the inventory cost. So all of these are a cost. So how can we leverage this cost in order to bring a value to our patient? And this is part of the healthcare now, or what we call it, value healthcare based system. So some key dynamics also on the drug commercial and supply chain environment. And actually, I wasn't fully aware of this until a few years back. When I was working in some consultancy firm, I was working also in the manufacturing field because I was an academician, then I moved to industry, then I moved to consultancy firm, now back to academia. So I was, trying to understand the full spectrum, what it takes to do a drug supply chain. So in other words, you have to fully understand that you are in the middle of this complex dynamics system. You have the government as a legislator, you are dealing with the prescribers or the payers. We have now the CNHI, the Center of National Health Insurance, and we have the CCHI, the Cooperative Health Council Insurance. You have distributors, you have the patients, you have also the media making some pressure sometimes on pricing and the profits for the companies. I serve on the Drug Registration Committee by the Saudi FDA, and we deal with some issues when it comes to repricing, some disputes about the pricing of medications. It's a supply chain issue. So you have to understand the full dynamics, what it takes to give the medicine to the patient. So these are, we call it, the key dynamics in the ecosystem of drug supply chain. So, and another term also is when you talk about supply chain, we have to mention value chain again. Because again, I'm stressing on this definition, we are bringing value to our patients. So the value here, can be represented by the R&D, because the medicine now you are giving to the patient, it gone through an R&D and innovation process, repurposing sometimes, formulation, reformulation, development. So this is a value added. So whenever the drug processed through this manufacturing processes, you are keep adding value until you reach to the supply chain. You have the production, logistics, marketing, services. So even the customer relationships departments, it is also part of the supply chain. You cannot look at your departments as a silos. There should be some crosstalks, vertical communications across all departments in order to achieve what we call it, a customer experience for your patients. There are also, and this is again another blue ocean, another area that hasn't been touched at all, the IP management, intellectual property. So there is intellectual property associated with this. There are CROs, contract or clinical research organizations. There are also contract manufacturing organizations, CMOs, and CDMOs, contract development and manufacturing organizations. So we are, as a pharmacist, either you are in a hospital setting, manufacturing facility, in academia, R&D, regulatory body, funding agency, wherever you are in this ecosystem, you have to be fully aware of all what it takes to do pharma and to understand the full complexity, because without having a full knowledge, fully aware of what it takes to do pharma, you cannot participate. You cannot be part of this very nice ecosystem. So basically all this has to do with the pharma industry. There is a venture capital working training program supporting industries. So because we are part of our national economy. We are not just doing pharma in a segregation or in isolation of other sectors or economic sectors when it comes to a national economy or national GDP. So in order to have a leadership position, leadership career, you should step into these, areas. When I mentioned here venture capital, has to do with entrepreneurship. So I'm as a pharmacist, I call myself a pharmacist. Now, forget me as a dean. As a pharmacist, you are entrepreneur by nature. You should also explore this space, the entrepreneurship space. So I did successfully established 2 companies. One of them failed, but I learned a lot, and one of them is still ongoing. It's in the consultancy field, and one of them in the supply chain field. So you are, as a pharmacist, you should also explore. This is totally untapped area for pharmacists. Entrepreneurship, either in consultancy, in trading, and logistics. So this, again, I'm just trying to disrupt some of the status quo, some of the comfort zone that the pharmacist, male or female, have in their minds. So COVID-19, I think I don't have to say it was a hit, big hit. So the effect was massive and remarkable. So it got some financial implications. So, and it is, from raw material, finished good. So again, it is a global value chain issue. I'm coming back to the value chain. So when we think about it, what happened? Most of now, even our, government pay more attention to the access of medicines, stability of medicines, making sure there is no disruptions. So we are really, proud of what we had achieved so far when it comes to having a national drug security. So, China, why I'm mentioning China, it is the global factory. So when China, there is, a slogan, when China sneeze, everybody gets sick. So, and this is true because they are, the global manufacturer and they have a global supply chain that we are impacted by it. And also during the COVID-19, there were some, issues when it comes to clinical trials because, the COVID-19 vaccine was fast-tracked, so that impacted other clinical trials for other vaccines. Why I'm mentioning so? Because you have to understand that sometimes when we have such kind of pandemic, it will affect the approval for other vaccines. Then the global supply chain again will be disrupted. And there were some white paper came out of PwC, PricewaterhouseCoopers. It's a global consultancy firm. They were mentioning the effect of global COVID-19 on some of these clinical trials, some of the the things that happened. So some companies, they witnessed a shutdown or premature, and they had to rerun their clinical trials. So there were some financial complications. So again, this is a value that we have to pay attention to. And in terms of generic prices, investment in the healthcare developing market, M&As, merger and acquisitions. So when I was working with Kybora, I witnessed a lot how scarce we have M&As, merger and acquisitions. So here the pharma companies, there are no investment chances. Let's say another company to acquire or to merge, to have what we call it a strong bargaining power when it comes to procurement, when it comes to making some pressure on pricing. So we don't have such kind of, ecosystem. So during the pandemic, there were a huge, demand for generic medicine over the branded medicine. Also investment were increased, which we are thankful for our government. They were injecting a lot of capital in order to just avoid some of the underinvestment that were made pre-COVID-19 era. Some of the solutions I am proposing here, and this could be applied in a manufacturing setting, it could be applied in hospital setting. Those are very broad, very generics, and I'm very glad to talk on a side if anybody who would love to have more insights on those. So some of these you could have what we call it inbound material visibility. You have to understand, your inventory. You have to have production scheduling. Agility here. It could be a tendering, process. you have to have a global scenario or a drill, just like when you do a fire drill, you have to do also a drill if there is a shortage or closure or stock outs of your medicine, which kind of thing you have to do. You have also to secure some capacity in your inventory or warehouse. So these are, I would say, just local solution that could avoid or ease out some of the disruption. Either there is a pandemic, there is a stock outs, some also solutions towards security, access and availability. And those are the three key terms I want to emphasize. So take home message, you have to pay attention to the access, you have to pay attention to the stability and also availability, because it is not just enough to have access to the medicine. They have to be stable at any various conditions. There is an earthquake, disaster, a flood, embargo, cybersecurity, anything that could happen. So access to medicine is very crucial, but also stability. I was giving a lecture at the Royal Commission of Jubail and Yambo 2 years back, and when I finished my talk, I stepped out of the lecture. The pharmaceutical care services director came to me and told me, Prof. Amir, I can see all the medicines in my system, but physically I cannot access them. So from the get-go, I told him this is a true failure of your supply chain system within your organization. So there is an issue with your distribution system. So what is the point if the medicines are available in your inventory and you are unable to access them? So that's a very typical failure in the distribution chain of this organization. So you have to deploy a green inventory strategy. So there are many big implications to it. Number 4, you can do stockpiling. Stockpiling, there is a very nice company. It's called Civica. It's in the US. It is working with the US government. They do stockpiling based on a charity level. So there is no cost associated with this one. So stockpiling, that's another level. Once you secure and you have your stock of medicines are well stabilized and you can have access to them, you can go higher level, which is stockpiling. So اللي هو المخزون الاحتياطي. So that's again something we have to think about, in collaboration with other entities within your ecosystem. Shifting of localization efforts towards services, not just manufacturing. I am a very advocate to localization of medicine, but localization doesn't mean you have to localize the manufacturing. You can localize the services, and there are many examples, but due to the conflict of interest, I cannot mention them here in this talk. But you can localize some of the services. We don't have to manufacture everything under the sun. In the US, do you know, in the US, they don't have any single API manufacturing facility. They procure them from China, from India, from some of the East European country. So in the US, it is the world's largest pharma market. They do not have any single API facility. And some people here, I know them because I am sitting in some board meetings, they claim that we have to manufacture APIs. It's not feasible. And is it something that we have to have in order to achieve a national drug security? That's a debatable point. But again, I'm just trying to disrupt the normal thinking in the pharmacy that we have to have API facilities, we have to manufacture biologics, we have to manufacture everything. We cannot. You have to rely on other countries, but you have to maintain your competitive edge, الميزة التنافسية. So where we are we good in branded generics? Are we good in giving the services to our patients? Are we good in API? We have to do the due diligence work for that. So, and this is just to show you, I'm about to end my talk, traditional supply chain to digital. So I am strongly urging the hospital settings, the medical cities, manufacturing facilities to invest in healthcare supply chain, because that's something we are really in need of. There are many softwares, there are many investment that we have to take when it comes to supply chain, because again, we are still reliant on some manual processes, outdated processes. That's not going to help us. Some of the shortage of essential medicines right now we are witnessing, I am witnessing by myself, due to the underinvestment in healthcare supply chain. So we have to boost this, investment. So because now we are moving from a traditional supply chain to a digital. So again, you have to have a clear feasibility when it comes to your supplier, to your vendor, to your patients, to your payer. The whole ecosystem should have a very strong visibility in order to give the value we are all in need for. I will end just by the national drug security. So again, hopefully I can convince you by this, slides that in order to have, or one of the pillars, I should say this, one of the pillars of national drug security, you have to have a robust supply chain networks. And when I say supply chain networks, that means investment, that means having a skilled Saudi, labor. You have to have all the softwares, you have to have the, full visibility on the ecosystem. So the three main pillars, you have to have availability of sufficient drug stocks, the stability. So availability is not enough by itself. It has to be stable and it has to be available, or you can obtain them, you can access them under any various conditions. Just like when we had COVID-19, if there is cybersecurity, sanctions, embargo, earthquake, anything that could happen in the world, you should be able to access those medicines. So that's what it takes to do. So, and drug security, it's part of the comprehensive national security. There is an economic, food security, so it is under the health security, in line with other securities in the country. Influential factors, you have to also, if you are responsible about the spare strategic reserve, if you are working with the vendors or suppliers, if you are taking care of the inventory, you have to keep in your mind that there are some financial balances. There are some monopoly, global factories. There are some demands sometimes for critical care medicine, the national distribution system. This is like the foundation in order to reach to the drug security. The speed of supply, or how to access them, again, stability and adequate supply, all leads to a national drug security. So with that, I have ended my talk. My home message is this: you have to pay attention to the stability of medicine, availability and access. Without those three key pillars of national drug security, we will not be able to achieve. So thank you for your listening, and shukran, Dr. Mohammed.
Thank you, Prof. Amir, for this enlightful presentation. I believe this is one of the challenges that we are facing, or regardless we are working as a clinical or as a pharmacist or in a drug company or. The problems of out of stock and supply, and to ensure the supply. From myself in the ministry, if I talk about myself, it's taking almost more than 50% of my time, problems regarding supply, availability, how can we ensure the drug security. Thank you for this great presentation. We can open now for questions from the audience. We have just only one question because of the time. Dr. Abu Bakr, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Prof. Amir, for sharing your experience and give us a wealth of knowledge صراحة about the supply chain. I've heard so many things that I've never realized that's going on in the back scenes of supply chain. My question is despite I'm going to be specific شوية. Despite the ongoing efforts with establishing NUBCO, for example, الاشتراء الموحد, despite ما شاء الله وصفتي to direct the patients multiple channels to get their medications, we still have this kind of issue. If we would like to pinpoint a root cause for such shortages, and sometimes in essential medications that we cannot wait for long to get supply for, what would be, from your experience, the root cause for sudden supply chain drops? per se.
Okay, thank you, Dr. Abubakar. This is very actually touchy question. I get to be asked about it all the time. I think the issue, there are no well-structured alignment between some of the governmental, entities when it comes to identifying the true essential medicines that you need to have. This is, I would say, the first level of the issue. When you go higher level, you need to really have a strategic reserve. In other words, the essential medicines, you cannot jump on having biologics, or you cannot jump on having, let's say, some innovative medicines, even if they are, let's say, treat the, not just the symptoms, they treat the root cause of the disease, without supplying the essential medicines. Should be the core of our talk. Sometimes I was part of a committee was led by NIDLIB, which is one of the the Vision 2030 programs, and we had 13 different governmental bodies or entities, and we were trying to talk about how to localize some of the biologics, how to do vaccines, and that was, before COVID-19. It was, I think, early to 2019. So I told them, I disrupt the whole notion of that thinking at that, committee meeting. We are jumping on something that we need first to fix our internal home. We have now to identify which kind of essential medicines are we now localizing them in terms of manufacturing, or do we secure, we have to make what we call it a blanket order, or we have to make a strategic partnership with some of those vendors in order to secure them. Then 1 year after this, COVID-19 came. So I was anticipating the shortage even before the COVID. But I think we need first to identify the essential medicines. Also, we have to invest in the distribution chain, because it is not an issue of lack of funds. It's not an issue of talking to those out of the country manufacturers to procure, because again, those are manufacturing not to export. They want some profit out of their medicine. But the problem, we are unable to identify our essential needs, because now we have the priority list by the local content authority. I know the industrial clusters or the national center of المركز الوطني للتنمية الصناعية, they have their own list. So these lists, who are identifying this list? Are these lists based on essential demand? Are these lists based on a chronic disease we have? Is there any epidemiological statistics associated with those lists? So there are many implications to this. And again, the shortage will be there always, but you want to mitigate this as much as you can, because again, you cannot have 100% supply all the time under all conditions. But what we are seeing, the shortage of medicine doesn't reflect the investment we have from our government, doesn't reflect all these governmental bodies. They are talking to each other. So I think the issue it's a communication issue, identifying the essential medicines, and under investment when it comes to healthcare supply chain.
Thank you, Prof. I believe if you want to contact Prof. Lainezi, it's on the screen on X and LinkedIn for further clarifications or questions, and I'm sure he will cooperate and give us from his time in order to reply. Thank you, Prof. Thanks for being with us, and by this we adjourn the session and give the time for the next session. Thank you. Shukran.
As we come to the end and the close of this session, I would like to take a moment to recognize the contribution. Please, Dr. Abu Bakr, come with us on the stage. First, we would like to express our science gratitude to Dr. Muhammad Al-Shannawi for his moderating of this session. Secondly, we would like to thank Dr. Amir for his remarkable discussion about this topic. Following this, we will turn our attention to the critical issue of burnout in the professional workplace. As the pace of business continues to accelerate, it has become increasingly vital that we address the mental and emotional well-being of our workforce. This session will feature experts' insight and evidence-based approach for identifying, mitigating, and preventing burnout, empowering all in attendance to foster healthier, more sustainable work environment. This session will be moderated by Dr. Abu Bakr Umar. He is a clinical pharmacist of ambulatory care, consultant clinical pharmacist. Please, Dr. Abu Bakr, the mic is yours.
السلام عليكم ورحمة الله وبركاته. طيب اليوم الدسكشن هذه يمكن شوي تكون مختلفة عن باقي الدسكشنز. It's going to be a little bit different because it's not going to be 100% scientific, and it's going to touch on a very sensitive topic that we've never touched based in the previous versions of the IHOP. A topic that's very essential for our daily life, for our productivity, for our daily interactions with other colleagues, with our families, and even with our inner selves. اليوم إن شاء الله راح نتناقش both عربي وإنجليزي for a reason, to touch the hearts, to touch the souls. فاستضفنا ناس بسم الله ما شاء الله قامات وهامات في مجالهم، مختصين بهذا المجال. كلنا في يوم من الأيام تعرضنا لفترة من الزمن النورمال لايف ups and downs. الداونز هذه قد تطول وقد لا ترجع ونرتفع مرة ثانية، وخلال الوقت هذا قد نتعرض إلى ما يسمى الاحتراق الوظيفي، باختلاف قدراتنا على التعامل مع الاحتراق الوظيفي، باختلاف فترة الزمن اللي راح نبقاها فيها في الداون. بدون ما اطول عشان ما احرق عليكم السيناريوز، لانه الاكسبرتس ار هير، مو انا مجرد انسان حاب اسمع منهم زي ما انتم حابين تسمعون منهم، اتعلم منهم زي ما انتم حابين تتعلمون منهم. I would like to welcome Prof. Hadil Dagash, who is the Professor of Health, Mental Health and PharmD Psychiatric Consultant, Certified Life and Driving Coach. She holds a black belt in 6 Sigma. She is currently a black belt master. She holds many certificates in the field of leadership, quality, and human development. She has many contributions in the field of psychopharmacological development and self-development, as she participates in many committees and development programs for the Ministry of Health. Please join me to welcome Dr. Hadil Dagash. Next, I'll have on the stage Dr. Anas Sidais, who's joined Remedica on March 2024 as a country manager with diversified experience in different roles as management, pricing, market access, tender, worked in leading pharmaceutical companies, holding a bachelor's degree in pharmacy from King Saud University and executive MBA. And last but not least, Miss Dalia Ramal, who has a leveraging background in medical sciences, transitioned from healthcare to business consulting, which is very interesting. Focusing on organizational health, culture, and change management, with over 9 years of experience and expertise in navigating change, holds both ProSci and CCMP certifications. Currently thrives as a senior culture and change management consultant, partnering with both government and private organizations. Please welcome Dr. Miss Dalia Ramal. طيب اسمحوا لي بس بجلس. We're going to have a nice 25-30 minutes inshallah. All right. So allow me, I introduced the subject to my audience. And we all know that the signs and symptoms, I'm not going to be explaining them, I'm going to leave the floor for you, of occupational burnout, it can reach to a devastating ends. And so my first question in this kind of panel discussion about such an important, what's the signs and symptoms, psychological signs and symptoms per se, for a person to be diagnosed or labeled as having occupational burnout? Prof. Hadil, if you can help me with answering such a question and outline such a thing for my audience.
مساء الخير عليكم جميعا، جمعة طيبة. الكلاسيك symptoms أو manifestations of burnout الاحتراق الوظيفي ممكن تكون واضحة clear، لكن التشالنج هنا كله حيكون في ال early signs of burnout. ليش؟ لأنها ممكن تكون subtle دقيقة ما نقدر نلاحظها، وهذه هنا خطورتها، إنه هي ممكن تمر وتتطور إلى clear full manifestation florid symptoms of burnout وبدون ما أحد يلاحظها. طب إيش هي هذه ال early signs of burnout؟ عادة بتكون هي unjustifiable negativity. يعني مثلا احنا عندنا في يوم من ايام الرياض الرايقة long weekend، ما في زحمة، ما في مدارس، الجو كويس، لكن اكون طالع لشغلي وانا نفسيتي سيئة. I am negative. طول الوقت متهكم، ساخر. Nothing is pleasing me. Unjustifiable. Although the circumstances they are good, they are appealing. فهنا هذه حتكون one of the earliest signs. وعادة بتتركز فين؟ في محور العمل and the colleagues، يعني العمل وزملاء العمل. الشيء هذا النيجاتيفيتي عادة والسخرية والتهكم تقود الإنسان دائما، سبحان الله، هو دائما عدم الرضا ياخذ الإنسان إلى circles of depression and stress out. نبتدي نشوف الشخص هذا is concentration is low، ما يقدر ينتج بشكل احنا لسه في البدايات، لكن يكون الكونسنتريشن، المود في تشينج. انا دائما بقول لهم في المنتل هيلث دائما بنقول انه هذا لما يكون في تشينج، وابسط تشينج لان احنا بنتكلم على الايرلي سيمبتومز، هيكون في تشينج في السليب اند ابيتايت، الاشياء الطبيعيه النورمال اللي بتحصل لكل احد هحصل فيها تشينج، وهذا فعلا يدل انه this is an early symptoms of burning out.
دكتور أنا I believe إنه الواحد لو يعرف ال signs and symptoms حق ال early signs and symptoms حق ال burnout, it can help them to seek help to avoid the debilitating consequences of the burnout.
يس دكتور أبو بكر إذا تسمح لي، لأنه ال early symptoms هذه عادة الناس they cope with it with unhealthy strategies. يعني تحصلوا بياكل كثير، بينام كثير، بياخذ مشروبات أحيانا طاقة، مشروبات illegal، to overcome الإحساس النيجاتيفيتي اللي داخله.
هل could be the other way around يعني ما ياكل ما ينام؟
ممكن both the
Okay.
both extremes يعني ممكن إنه هو ينام كثير أو أحيانا يصير في عنده أرق insomnia ما ينام، ممكن ما ياكل، ممكن يصير في عنده binge eating اللي هو الشره أو الإيموشنال eating الأكل العاطفي to overcome الانكزايتي حقت أو النيجاتيفيتي حقت early burning out.
ممتاز ممتاز. أنا أعتقد التوك هذا will raise a lot of questions today. بس طيب my question to Dr. Anas يعني would الريتس يعني أو البيرن اوت أو الoccupational burn out أو خلينا let's agree على شيء. هل البيرن اوت يختلف عن الoccupational burn out؟ هل هذا يعني البيرن اوت هي مظلة والoccupational هذا نوع من أنواع البيرن اوت ولا it's all the same؟
طبعا first of all I would like to thanks for the organization committee for everyone who is doing a lot of effort for this conference. Special thanks for you Dr. Abu Bakr and also Dr. Muhammad for amazing conference that let's say reflecting in the level of the regional, not in Saudi Arabia. For sure in burnout it's very important topics. And also based on my experience with different industry, let's say I'm working with international and multinational industry, this topic is very important for them to address, to be provided, and also one of the important parameter for the company to address how we are achieving, what's the level of the satisfactions, all of things. That it's important. الشركات بصفة عامة أو المقدمين الرعاية الصحية تقيس هل الإمباكت هذا موجود وهو يختلف من جزئية إلى أخرى. الشركات اللي يكون عملها يتطلب ساعات عمل كثيرة a lot of pressures that will be impacting clear. الأذر سايد الكرياتيف وورك أو الأشياء هذه اللي بتجدها انها لا تنقص بشكل كبير جدا وامباكت على الكمباني بشكل كبير او على السيرفيس يو ار بروفايدد بشكل كبير للجهات.
ممتاز. طيب هذا يخليني اسالك سؤال ثاني دكتور انس يعني هل البيرن اوت يعني في اختلاف بين المالتيبل اندستريز؟ يعني انا قبل يعني let's say شهرين I was a hospital pharmacist. Now I'm in a company. So would I be expecting يعني exposure لل-occupational burnout would be the same? How is it different between different industries?
Yes, for sure it's different from industry to other. If you get to each separate industries who's, for example, in hospital, in preparations take a lot of times that in the preparations, prescriptions, facing patients, that will including a lot of pressure for you. But in the other, in the manufacturings, or in the analysis, who's looking for that, it's different, yes. It's based on the organizations. One of the very important, each organizations, let's say it's three responsibility. The organizations, the manager themselves, and you as employee. And for sure, someone who's recently joined to any, let's say, new sector, new area, you will not facing burnout within the first 6 months for you. It will be coming with a long time, with a lack of clear from the organizations, from your side, from your managers. It's cumulative together.
ممتاز ممتاز. So يعني in a simple words يعني حتى organizations would be precipitating factor للburnout. يعني it's not only a self thinking أو a thought process. طيب خلينا نسأل مس داليا. What would be a strategies that I can pursue or that I can do to fight such يعني burnout? I know some people are able to do their own self strategies. Some are not. They would like first line. They would go to seek help from a therapist or something. But what first line things or options or interventions I can do for myself to help overcome the early signs of burnout, and at the same time, when would it be a good time to seek help?
يديكم العافية جميعا. I feel very privileged to be here today with you all. خلينا نتكلم عن some things that you can do, not necessarily big steps that you can do, but tasks that you can do on daily basis to help you combat burnout. First things first is time management and task prioritization. There's a tool that I like to use personally. It's called the Eisenhower matrix. Basically what that is you prioritize tasks based on importance and urgency. So the first things that you have to do is you do the urgent and important task first. And then for the important but non-urgent tasks, you schedule those for later. And then for the important but not urgent tasks, you can do them, like I said, later. For the tasks that are not important and not urgent, you can just delete those or delegate them to someone else. So this is very helpful because time is of an essence and we need to use our times most efficiently. Another thing is to schedule or set realistic deadlines for yourself, whether it's in coordination with your direct manager or something that you just have to do with yourself. So when you prioritize tasks first, it's going to be easier for you to set those deadlines later. And try to be realistic. Don't give yourself too much time and also don't give yourself too little time. Just try to balance between the tasks that you have to finish urgently and thus are most important. Another thing that you can do is that, and this is something that I personally strongly believe in, is that you set times to take breaks. Sometimes when you're working on a task for such a long time, you get fatigued really easily, and then your efficiency levels are going to decrease over time. So if there's a task that you're working on and you know that you're going to be working on it for such long times of periods of time, just set an alarm on your phone, and then when the alarm goes off, just stop, take a break. It doesn't have to be like a 30 minutes or an hour break. Just for 5 minutes, just go refresh, wash your hands, wash your face, maybe eat a piece of chocolate, spray some perfume or cologne, just something that would make you feel refreshed to start all over again. Because when you start again, it's like you went back to the beginning and your energy levels are not as when you took that break and the energy levels were decreasing. So you're going to start again fresh. So those are some of the strategies for time management and also for self-care.
Correct, yes. I totally believe in these kind of strategies. I do some of them usually, but I feel like taking a vacation would be one of the strongest reliefs.
Vacation is something a bit more extreme. So let's try to do things on daily basis that we can incorporate in our daily work. That will just give us the refreshment so
build
we
a
can
habit
go back.
kind of thing.
Exactly. Yes. Building habits.
All right. So how about taking things from the other side? My question would be going back to Prof. Hadil. So we've discussed now the early signs, some strategies, but that's on the personal level. But I'm taking it from the other perspective. Like if I was a manager and I have an employee, عندي موظف ظهرت عليه الأعراض هذه. Most of المانجيريال thinking أو العقلية الإدارية البحت يمكن تأخذ هذا الشيء على إنه تسيب أو إهمال أو إنه الموظف طفش خلاص ما عاد يبغى عندنا أو إنه أكيد إنه يبغى يدور مكان وبيطلع ما عندنا ما عاد يبغى. فأنا as a manager الآن I want to learn يعني كيف I identify إنه الموظف هذا عنده early signs ولا خلاص وصل مرحلة burn out يعني and what to do in these cases.
even في التشخيصات الصعبة يعني من الأصغر إلى الأصعب دائما بنقول الفيصل هو change وتغيير يكون عن السابق. change from previous, change from norm. يعني أنا موظف كان عندي دائما dedicated وبيجي في وقته punctual بيأدي مهامه. فجأة صارت productivity, البرفورمانس، الكرياتيفيتي ننتبه كثير لأنه الكرياتيفيتي كثير مرتبطة بالباشن وبحب الشخص للمكان. فإذا كانت البرودكتيفيتي and creativity is down, this is one of the signs إنه في شيء هنا يعني حاصل. غالبا ممكن يكون بيرن اوت. احيانا في ناس يعني بتعترض تقول لك انه الكرياتيفيتي از بير كوانتيتي، يعني مثلا كميه الوصفات اللي هو بيطلعها في اليوم، كميه المعاملات اللي بتطلع من يده they are the same، لكن شوف هل quality of the work is it the same، النمبر of errors. احنا طبعا كلنا بشر، وارد انه احنا نخطئ، لكن النمبر of errors is it the same like
صحيح.
before or صار في reckless، يعني صار في عدم اهتمام، عدم تدقيق في المهام هذه. So this is burn out. How to overcome and how to deal with it as a manager if you are a manager. دائما سياسة الباب المفتوح، سياسة الكوميونيكيشن الأوبن شانلز. ليش؟ علشان الغرض الأساس، ويمكن إحنا حنتكلم عنه في النهاية، اللي هو أعرف السبب. Why he's burning out، ليه هو قاعد يحترق وظيفيا.
ممتاز.
فهذه هنا بس إحنا هنتوقف عند الجزء هذا الآن. open واتكلم واحاول اني انا اكون صريح واجيبه ناحيتي، اوكي، نو كريتيسيزم، يعني ما انتقد ما اوبخ هذا، لكن احاول اني اجيبه علشان اعرف ايش السبب. This is the most important.
ممتاز. طيب دكتور انس، لو بسالك يعني ايش الاثيكال كونسيدريشنز؟ احنا الان قاعدين نتكلم purely emotional و how to deal with these kind of situations, how to identify an employees as a manager. بس as a manager again برجع as a manager لأن I would believe إنه إذا ما كان عندنا هنا managers very soon most of إن شاء الله will progress at one point to manage people of any number. بس as a manager what ethical considerations المفروض إني أحطها في بالي لما نتعامل مع موظف أشك انه يمكن محترق وظيفيا؟ الموظف ما عاد زي ما تفضلت بروف هديل، ما عاد يعطي زي اول، ما عاد هو باشن. الموظف هذا كان يدخل ابتسامته تملا المكان ويغير المكان الى المكان ايجابي، الان صار يدخل يخرج ما كان موجود. يمكن سياسه الباب المفتوح يمكن تنفع، يمكن استدعائه نجلس نتكلم on one to one يمكن ينفع، بس what ethical considerations لما تيجي الموضوع affecting الكواليتي حق الورك مثلا؟
يس طبعا نتكلم الورك لايف بالانس او البيرن اوت، هذا فيري امبورتنت توبيك لكل الاندستري انه فوكس عليه وعندهم باراميتر. انت كمانجر او مسؤول او موظف او ليتس سي ليدر اللي هذا التيم اللي عندك بيكون عندك فيرست او ايثيكال بريورتي، يكون عندك اللي هو الكونفيدنشاليتي. لما تيجي وتتكلم عن الموظف او تجلس مع الموظف هذا يجب انه يكون تحسسه بالامان، انه yes we are it's a confidentiality, I am know what you are facing what you happen. وبرضه بتكون انك ما توجه له الاتهامات انا expecting from you result 1 2 3 this is our KPIs this is one. There is a different language. بدل ما تيجي تقول you are not achieving or what happened, you achieve a lot in the last couple months. Anything can أنا support، وش السبورت اللي أنا أحطه أنا، وبرضه تشرك الموظف عندك باللود الموجود. إحنا عندنا الفترة هذه a lot of workload وتبين له ليش الموجود هذه، وش الفيجن اللي إحنا بنأتشيفت بهذه الفترة هذه اللي بتعدي، ويكون شريك معك بالإنجاز للعطاء. وهذه مو دور مانجر فقط أو الليدر، دور الاورجنايزيشن بلس لازم يكون عندك مانجر هايلي ايثكس فاهم اندرستاندينج بلس ماتيوريتي في يور امبلوي دايركت الموظف هو فاهم الان موجود ليش.
هذا يخليني اسال سؤال دكتور معلش اوف ريكورد، يعني جاء في بالي الان يعني از يو سيد، هل المنشاه او المنظمه لما تحط يعني جولز تو بي اتشيفد فور هذه السنه مثلا وتكون اعلى طبعا بالتاكيد من السنه اللي قبلها، والفيلينج اللي تنزله على الموظفين انه احنا لازم نطلع كي بي ايز ومؤشرات افضل من اول افضل من اول افضل من اول، ما نرضى المؤشر حقنا يصير احمر لازم اخضر، لازم نطلع 30% 10% از نوت ساتسفاكتوري. هل هذا كايند اوف الباترن او توجه الشركات او المنظمات بي بريسبيتيتنج فاكتور، يعني شيء يسبب البيرن اوت بسرعه، بالذات للناس. احنا عارفين ان الموظفين ما هم سواسيه، في الحالمين، في المنجزين، في اللي الملتزمين، وفي اللي يلا يمشيها. بس هل setting such parameters و KPIs ومؤشرات يمكن يكون له دور في الموضوع؟
وطبيعي بيكون له دور كبير جدا. لما اجي الموظف عندي واقول له انت achieved like this next year الاتشيف حقك double or triple، في بعض الموظفين اوكي يعني بيبغاني اجيب زي كذا او achieving زي كذا which is it cannot be happen. بس الدور كاندستري or organizations first of all لما setting the objective for the next calendar year, discuss these objectives, communicate with your team why we are achieving, how we can achieve it. Is it easy to achieve it or not? After that absorb for this objective, for this KPIs, they can achieve, they can understand it, and you as a manager to prevent the burnout for your teams. End of day that will impact the result or the quality of service you are provided as an organization.
ممتاز. أنا متأكد إن الحين بتجينا أسئلة كثيرة، بس ما بطول عليكم. سؤالين. مس داليا، يعني قبل شوي أعطيتينا self let's say strategies اللي واحد بنفسه يقدر يسويها. هل في شيء ثاني أقدر أسويه؟ يعني أنت قلتي لي إنه إحنا I try to set alarms ولا أخذ small breaks والapproach اللي أعطيتيني، بس هل في شيء ثاني على شوية higher level I can do قبل لا أروح officially أقول أنا يا دكتور فلان أنا burn out، لا عاد تعطيني شيء ما أقدر أسوي شيء؟ تفضلي دكتور.
And another very important aspect is to always prioritize your mental and physical health. Sometimes your body will give you symptoms, body aches, inability to sleep, or insomnia, like Prof. Hadid mentioned before, and you have to listen to those signs. If you don't listen to your body early on, whatever problem that you have might exacerbate, and then you may not be able to fix it right away, and you may need major interventions, like maybe you will seek out help of a mental professional, or you need to visit a physician. Maybe you'll have to schedule something for surgery or major procedures like that. So just listen to your body. What is it telling you? The small symptoms, the small changes that you're facing on a daily basis, and don't ignore those. Another thing that you can do, and this has to be with self-awareness and also to raise awareness for those around you, is to know they call it your style of work or style of management for managers. Know how you can function. If your manager is talking to you, giving you a task, are you one of those people who prefer to have detailed description of this task, or you just like to give you like an overall description of it and then you can build on it right away? Discuss that with your manager. Have open communications with them. Also with your colleagues, ask them about what ways of communication and what is the best way for them, for you to approach them, for you to work together, how you can handle conflict if it were to arise. That is very important, because a lot of times when people have conflicts with their colleagues or their managers, the first thing that they do is avoidance, and that is very popular here in our culture. We don't like to confront each other, so just don't shy away from confrontation. Just use professional language, explain what happened, why you don't like this, or this is not going to work for you. Tell them what your red lines are. So just be open about what you like and what you dislike, and just how you function in general.
صحيح. طيب برضو أجين أنا تطلع لي أفكار كذا وأنا قاعد أتكلم وناقش. من منكم سمع كلمة resilience؟ دائما لما نسمع burn out نسمع resilience، صح؟ طيب بروف هديل، يعني I'm sorry يعني أرجع لك مرة ثانية، بنتعبكم كل شوي بسأل واحد فيكم. إيش معنى resilience؟ وكيف الواحد يقدر يسوي هذا الشيء اللي اسمه resilience عشان يقاوم؟ لأنه أنا عن نفسي قريت كتاب حق البيرن اوت، وit always build resilience، ويتكلم عن الكونسبت حق resilience to prevent هذا. هل هذا الشيء يعني كبريفنشن ولا أداء لمقاومة، يعني أو إنه شيء للتعايش مع اللود اوف وورك، الضغط العمل، الضغط زملاء العمل، مدير العمل وما إلى ذلك؟
لما تكلمنا في الايرلي ستيجز قلنا انه واحده من اللي يعني الايرلي ستيجز او الايرلي ساينز هذه بتخلي الانسان to go for the unhealthy coping mechanism اللي هي البنج ايتينج، السهر، ينغمس كثير مثلا مع اصحاب خارج اوقات الدوام، خلص هيز تعبان ريزنتينج. الداء العكس، فانت you want to overcome resilience هذا خلاص انت سوي healthy coping mechanisms. زي ايش؟ دائما اقول لهم go back to yourselves. الحل دائما من عندنا من جوا. ارجع لنفسك، شوف انت ايش كانت المشاكل اللي حصلت. take time to breathe، تنفس. في مقال كبير بينزل ويمكن يتحول إلى كتاب عن أهمية التنفس. إحنا we don't breathe. تشوفوا البيبيز أول ما ينولدوا كيف بيناموا، إحنا حتى بنقول he sleeps like a baby لأنهم بيتنفسوا deep up to their abdomen. إحنا we don't breathe. take time, breathe. البريذنج هذا بيعطي oxygenation your brain, your body, your aches اللي تكلمت عنها مس داليا. كل المشاكل هذه إذا إحنا تنفسنا، استرخينا، relax, meditate and meditate and meditate. We are Muslims لكن في ناس ثانية عندهم other ways of meditation. Go and meditate by your own way. Okay? اعرف ايش الاسباب. go back, dive deep. اعرف ايش الاسباب. root cause analysis في اغلب مشاكلنا هو بذرة الحل. اعرف بس ايش السبب. اذا عرفت السبب مش حيبطل العجب، حتحل المشكلة.
توني بقول
فنحل المشكلة by resolving the causes، لانه هي اللي سببت المشكلة. فإذا أنا عرفتها وهي هذه زي ما قلت لك بتكون الكي والخطوة الأهم. طبعا في other things اللي هي الإكسرسايز، الهيلثي سوشيال ريليشن شيبس. روح للناس اللي تحبك، روح لأمك، حتى لو ما أعطت نصيحة في البيرن أوت لكن حتعطيك دعوة، حتعطيك طبطبة، حتعرف هي تطلع من الجو. فهذه الأشياء it can make a real difference.
خلينا نتكلم عن التكنولوجيا. دكتور أنس، خليني أعطيك هذا السؤال. أعطيتني ابتسامة بعطيك سؤال. هل في التكنولوجيا الآن شيء أقدر أسويه عشان مثلا موضوع البيرن أوت؟ هل كان I can use مثلا تكنولوجي in any way AI ولا التكنولوجيا العادية اللي احنا نعرفها to overcome ولا to deal with the burnout؟
وطبعا التكنولوجيا ممكن يعني انها تساهم بالبيرن اوت، وبالاذر سايد برضو انك قد تستخدمها بالجانب الايجابي. يعني بالجانب الايجابي انك يعني بيكون عندك تايم مانجمنت، تنسق الوقت، تستخدمه للتاسك اورينتد، وين التاسك اللي عندك تجي تكون، فتستخدمها بشكل جميل ايجابي، easy to communicate with the people. and الاذر سايد بالتكنولوجي بيكون ما عندك يعني البرايفت تايم لك او الوقت العمل الخاص فيك. هذا هو الوقت العمل لي من الساعه الفلانيه للساعه الفلانيه. التكنولوجي تساهم انه الان you received a message every time we need this to add it, we need that to do it. However, some organization prevent, let's say, using a WhatsApp as official communications for the organizations to make work-life balance for the employee. This is time for his family. You have your task, you have weekly meeting, let's say, to agree in the weekly objectives to achieve or monthly objectives. So it will be in both sides, either in positive, that you can time management, organizing your calendar, having or your access as in the healthcare to the information easily, directly to achieve it. And there is the other side also, and based on the organizations, in the manager, in the employee themselves.
Interesting. أنا يمكن one of the earliest things I can do is Netflix على طول. عشان اطلع نفسي من الجو. طلعت انا ادخل نفسي بعدين زياده في البرنامج. طيب يمكن الثيم اللي اعطيتك اياه الحين الاسئله كلها prevention self strategies، بس فعلا كاورجنايزيشن الحين توكينج، مو كسلف يعني بيرسون. كاورجنايزيشن what can I do to my employees to slow down الانكلاين حق البرن اوت في my organization ولا في my employees ولا في my team حتى. تفضل دكتور.
Like for me in my line of work, because I work with organizational health, culture, change management, things like that, we use a model, it's called the OHBI, Organizational Health and Behavior Index. And basically what that does is it addresses 3 types of needs. It addresses the employees' needs, the organizational needs, and the strategic needs. And organizations need to be aware of that, and managers need to be aware of all of 3 levels. So I'm going to address the employees' needs personally because, like we talked about before, we were addressing strategies for employees to address. So we can do in healthy working environments. The first thing that employees need to do is to have awareness of the mission, awareness of the mission, the organizational values. What does their organization stand for? And there's a story that I love about this security guard in NASA. And they asked him, what is it that he does in NASA? And his answer was very interesting. He said that he helps and he contributes to sending spaceships and aircrafts to outer space, even though he's a security guard. But because he was aware of his organization's mission, he felt a sense of belonging and higher purpose. Exactly, yeah. Another thing that employees need is to form healthy relationships, whether it's with their line managers, and this is the number 1 relationship that causes resignations globally. They need to have good relationships with their colleagues, and they also have, the organization needs to invest in the relationship with the employees' families. If we mention organizations like Aramco or STC, you always think how much invested they are in the families of their employees. They give them great health insurance, they give them health benefits, they involve them in decision making, many other things. And again, another nice story about Alm company. What they do is, because they're a tech company, so they usually work overtime. And some of their employees, when they work overtime, what they do is that they send flowers to the wives of these employees that are staying overtime.
شركة علم؟
شركة علم.
Nice.
Yes.
سوون هالموضوع
They do
بالنيابة
that.
عنا يعني.
Yeah, they do that. So yeah, because they are so invested in the relationship with the family then can appreciate what their family members are going through. So that's one of the techniques that I absolutely encourage. Another thing the employees need, an organization needs to work with, is appreciation.
صحيح.
Employees need appreciation from their organizations. They need credit for their work.
صحيح.
They need appreciation from direct managers. A lot of the times that when we ask employees in focus group discussions, what is it that you need from your direct manager? Some people will say, I just need my manager to tell me thank you, and that's it. I don't need financial income or incentives or gifts or anything like that. I just need my manager to tell me thank you, and that's it. So when organizations are aware of those employee needs, they can tackle those. Something else that we can do is, and this is for usually corporate, but some other organizations can do it well, is internal communication. They can activate internal communication, send strategic messages to their employees, tell them about the news, what's changing, do you have an organization restructuring, did we change the managerial levels, are we going to a new building, for example. A lot of the times because we have resistance from the employees for these things because they're not aware of it beforehand. So just keep your employees informed, update them regularly about what's going on in the organization. These things matter a lot to them because when you keep them updated and also maybe involve them in the decision-making process, like for example, if you have a new building and you're going to be choosing the vendors or the cafeteria, just involve them in that. It's something very simple. They don't need to be involved in strategic decisions, for example, but just like let's share a voting with all the employees. What type of food would you like to prefer? Healthy? What type of cafeteria? Would you like vending machines or restaurants or something like that? Just involve the employees and keep them engaged with you, and that way they can feel more connected and loyal to you, so they don't resist as much.
صحيح. Thank you very much. honestly, I have a lot of questions, but the time is running, so I was just pinpointed على التايم. عندنا سؤالين من الاودينس عن طريق الابلكيشن. فالاولى يمكن we talked about العلامات الاولى لوجود الاحتراق الوظيفي. We addressed it at this first thing in this discussion panel. The second one was what are the main reasons of burnout with clinical pharmacists, specifically clinical pharmacists? And we know asker is a clinical pharmacist. So anyone would like to answer it very quickly? يعني possible reasons for clinical pharmacists to go into burnout.
إذا تسمحوا لي as an old clinical pharmacist في بداياتي في مجال psychiatric clinical pharmacist أذكر كنت لما أخلص الراوند أكون كذا متماسكة وكويسة يعني أنا الحمد لله فاهمة اللي بيحصل كله. يمكن هذه أحد المشاكل إن أنا فاهمة مرة. أحصل بس الله يكرمكم أول دورة مياه أول مكان كذا بعيد أدخل أبكي. ليه؟ لأنه حصل لي كذا emotional charging من المرضى ومشاكل
negative
وتشالنجز mainly for me it was in psychiatry اللي مثلا بيكونوا في الاندوكراينولوجي في الليت terminal diseases. يعني كل أحد إحنا نتعامل مع patients مرضى ومهما كان أنت زي ما نقول إحنا set boundaries افصل نفسك اعزل نفسك لا تتدخل don't involve emotionally لكن at the end of the day we are humans.
It's a nature of a human being.
نعم إحنا وكمان الكلينيكال فارماسي قربتنا أكثر للبيشنس ومشاكلهم. ما تقدر بس مجرد والله تعطيه الدواء this is the medication regimen go to your home and take it.
صحيح.
حتتورط وحتتدخل ولازم تعرف أمه وأبوه أخوانه البيئة هل هي داعمة سبورتيف متفاعلة. الأشياء هذه بتدخلك في الداينامكس حقة البيشنت فتحصل نفسك نوعا ما ارتبط. This is I know against all of the recommendations all of the guidelines لكن at the end of the day we are a human. This is from my own modest experience. The emotional involvement with the patients and their struggle.
Okay, so the time is over. So إذا أحد عنده أي سؤال ولا شيء المفترض والله أخذ بس at least سؤال. طيب دكتور غالب أول واحد رفع سؤاله. مايك بس آخر سؤال أنا آسف. دكتور أثمن أنا آسف. بروف هديل النسخة الماضية من IHOP أعطتنا ليكتشر كانت من أروع الليكتشرز اللي أنا سمعتها وبالعربي. I had as a scientific committee chairman to suggest للكوميتي ان احنا we host her again نستضيفها مرة ثانية. كانت كريمة بالنسبة لنا السنة هذه وعرضت انها تجيب الدسكشن كامل مع expert panel معها عشان to touch base على different levels of البيرن اوت. إنسانة رائعة جدا ما شاء الله ولا قصور بالمس داليا والدكتور أنس. فأي أحد عنده سؤال من بعد دكتور غالب يقدرون يسألون الزملاء اوف الستيج ان شاء الله. تفضل دكتور غالب.
يعطيكم العافيه جميعا صراحه محاضره شيقه ويعطيكم العافيه. سوري انا ما جيت من اول المحاضره او الورك شوب هذا. في تعريف متفق عليه عن البين اوت يعني ايش هو البين اوت؟ انا ممكن انكم ذكرتوها بس انا جيت متاخر بس هل في تعريف اتفق عليه علميا علشان نقول اوكي اللي ينطبق عليه التعريف هذا بين اوت. شكرا.
كيف دكتور؟
تحب حضرتك تجاوب على السؤال هذا؟
ما اعرف ماني الاكسبرت لكن ماني الاكسبرت. افضل تجاوبي جملكم انتم.
زي ما دائما نقول البيرن اوت إنه في dramatic significant change from the norm وحتحصلوا دائما في الكواليتي في الباشن في المعاملة مع الزملاء. This is burning out. شخص بيتشكى وبيسخر وأحيانا ممكن يعني حتى بيئة العمل تحصله كذا ينكش فيها أشياء. this is burning out. واحنا زي ما قلنا في البدايه انه this is unjustifiable. مو والله هو مثلا موظف عنده ظروف او مثلا بيعاني في الفتره هذه. No, this is from the ظروف, his own circumstances. But burning out, this is something negative, sarcasm without a justifiable reasons. يعني ما في، يعني هو ما هو مظلوم في العمل، ما عنده مشاكل خارج العمل، لكن هو exhausted، خلاص تعبان مو قادر، فبتبتدي تظهر النيجاتيفيتي والتقصير والبور كواليتي ان ورك. باختصار هذا البيرن اوت.
ثانك يو فيري ماتش دكتوره.
اذا تسمح لي بس ازيد نقطه كمان. في دكتوره تكلمت على خلينا نسميها الاوفر ساينز، في كمان كوفر ساينز اللي هي signs of resistance احنا نسميها احيانا. لما نشوف شخص disengage مثلا in meetings ولا important event، تشوفه جالس كذا they don't want to disengage, they don't make eye contact with you. When you assign them with new tasks احيانا ممكن انه هو يسحب عليها ويطنشها. في الاتندنس حقهم تشوف في مره اختلاف، ما عاد يداوموا زي اول، ما عادوا ملتزمين، يتاخروا عن اوقات الدوام، ياخذوا اجازات كثير. فهذه كلها اشياء not necessarily negative انهم قاعدين يتكلموا عنها، بس it's covert signs that يعني خلينا نعرف انه okay there's something wrong that's going on. Resistance, disengagement, burning out.
Thank you very much Prof هديل والدكتور أنس Miss Dalia for such يعني rich صراحة discussion panel. أنا عن نفسي مرة مبسوط عليها. وأنا دائما أقول للزملاء ترى لو ما تسكتوني ما بسكت، زين إنهم جو قالوا لي إن الوقت آخر، وعشان ما نتأخر على الدكتور عثمان من بعدنا. يعطيكم العافية. Please join me to thank Dr. أنس وبروف هديل ومس داليا.
As we come to the close of this discussion panel, I would like to take a moment to recognize 3 individuals who have made invaluable contributions. First, I would like to express our science gratitude to Dr. Hadil. Your expertise and insights have truly enriched our understanding of this important topic. Please, Dr. Hadil, be on the stage. Secondly, I would like to thank Dr. Dalia for her remarkable contribution of this panel discussion. And finally, join me in thanking and appreciating Dr. Anas. Thank you all for your participation and engagement. Next,
السلام عليكم. رجعنا لكم مرة ثانية. عندنا كوبونين مقدمة من دكتور هاوس. الكوبون عبارة عن قسيمة شراء الأولى بقيمة 100 ريال والثانية بقيمة 150 ريال. الآن الكاميرا راح تدور عليكم وراح تختار واحد منكم، فكاميرامان اختار لنا واحد من الحضور، نشوف من المحظوظ فيكم. ألف ألف مبروك، تفضلي معنا على المسرح. وين اللي فازت هنا؟ طيب يا أهلا وسهلا. الكوبون الأول اللي هو بقيمة 150 ريال. ألف مبروك. شكرا جزيلا. الكاميرا الثانية، المرة هذه بنختار من الميل، معليش بنغش شوي، فالكاميرا ركزي لنا على اللي هنا، في شوي قدام بعد. ألف ألف مبروك، تفضل معنا على المسرح. ألف مبروك. شكرا جزيلا، وبنستكمل الجدول العلمي.
And next, we will shift our focus to the vital domains of safety and quality. In an era of heightened regulatory scrutiny and growing consumer expectations, organizations must be proactive in ensuring the safety and reliability of their products and services. This panel will equip attendees with the knowledge and strategies necessary to strengthen their organization's safety and quality assurance, ultimately bolstering their competitive edge in the marketplace. This session will be moderated by Dr. Rabi' Dablez. He is the Senior Manager for Quality and Medication Safety Services at Cleveland Clinic at Abu Dhabi. Dr. Rabi', please make your way to the stage.
Assalamu alaikum, everyone. It is my pleasure to be attending this conference, and thank you for the invitation. It's my first time in Riyadh and definitely will not be my last. I would like to introduce Dr. Uthman Al-Umair. Dr. Uthman currently serves as the Dean of the College of Pharmacy at Shakra University since September 2023. He also holds the position of Assistant Professor in Pharmacy Practice. He completed his bachelor's degree from Riyadh Elm University in 2012, followed by his master's from King's College London in 2016. He then successfully completed his PhD in pharmacy practice from the University of Reading in 2020. And Dr. Uthman is licensed as a consultant pharmacist by the Saudi Commission for Health Specialties in Pharmaceutical Administration and Outcomes. He is a board-certified pharmacotherapy specialist, and his his areas of research is primarily focused on patient adherence and behavioral change. So please help me in welcoming Dr. Uthman, who will be talking about the unlocking the key to patient adherence, promoting safe medication practices. Thank you.
Thank you, Dr. Rabi'. السلام عليكم. سكرين ما تشتغل. من زمان نروح هناك. السلام عليكم جميعا. Hello everyone. First, allow me to thank the organizing committee for inviting me today to talk about a topic that I'm really interested about, which is patient adherence. Today, I'm going to be talking about patient adherence, defining it, and then taking you through the journey of behavioral change and how to change a behavior in a systematic manner. First, let's define adherence. What do we mean when we say adherence? What is the definition of patient adherence? So, patient adherence is defined as the extent to which a person's behavior, either taking a medication, following a diet, or executing lifestyle changes, correspond with agreed recommendation from a healthcare provider. There is a key word in that definition. The key word that is in that definition is the agreed recommendation. And this is a shift in healthcare. It shifted in early 90s to that definition. Before that, we used to think of patients as passive obedient. People who come to the clinic, we tell them to take the medication, and then they go home, and we expect them to take it. That's not actually suitable anymore. Patients now are part of the medical team. They have to agree on a recommendation. So they go home, and they do it themselves. When we agree with a patient on a certain treatment, this is our role. This is pivotal because we build a trust and a rapport with the patient. When we tell them to go home and take a treatment, we don't establish that rapport that we need to. So for a patient to actually respect you, you need to establish that rapport. And this is the definition of adherence. You have to provide tailored education. When you discuss any treatment with a patient, you tailor the education based on their needs. If they actually need, let's say they are afraid of the side effects of the treatment, then they need education. You educate them on the side effects of the treatment, thus improve their adherence rate. Let us go back a little bit and discuss the history of adherence research. The attention to adherence or compliance wasn't drawn until the early 50s. We used the term compliance by then. However, it wasn't until 1975 when compliance was introduced as a MISH term. And it was introduced due to the symposium on compliance that was held in 1974. However, it wasn't until early 90s when we shifted from the term compliance to the term adherence. Does anyone here know the difference between compliance and adherence? So the term compliance is used interchangeably. They are quite similar. However, there is a very brief difference between the two in the connotation. Compliance as a term means that patients comply with what we told them to do. While adherence, as we said, it's based on the agreed recommendation. We agree with them on doing it. However, it wasn't until 2009 when the term adherence was actually introduced as a MISH term. We have two types of adherence. We have intentional non-adherence and unintentional non-adherence. Unintentional non-adherence is quite simple. Patients are prescribed the treatment, they forget to take it. However, the issue we have is with intentional non-adherence, which is an active process in which the patient fully decide or choose to deviate from a treatment regimen. And this is a big issue that we need to study more. As healthcare providers, we love numbers. Now, when you do a study, a quantitative study about adherence, you try to correlate factors of adherence with the adherence rate. So factors such as patient-related factors that has to do with their demographics, their age, their gender, or therapy-related factors like the route of administration, the treatment complexity, or condition-related factor that has to do with the symptoms of the disease, socioeconomic factor, like the cost or the income, and health system related factor like the availability and accessibility of the treatment. Now, you can correlate each one of these factors to the adherence and come up with a percentage. But is this the way of doing it? We're going to discuss this more. To measure adherence, we have two ways. We have direct measure and indirect measures. Direct methods of assessment, like direct observation, biological indices, where we check the blood or the urine for the drug or its metabolite, or by ingestible event markers, like smart pills, which are like capsules with a smart chip in it. When the patient swallows it, it actually shows and it actually triggers the app in a phone, and then it sends the information to the healthcare provider, so we know exactly what time did the patient take the treatment. Or indirect method, which is the most common, where we actually ask the patient, did you adhere to the treatment? Did you take it in time? Electronic devices like electronic bottles, retrospective databases where we check refills, check prescription, all pill counts, or clinical outcome where we check the clinical outcome, did the disease improve or not? If it improved, then that means the patient is adherent. If not, then it means he's not. So what is the problem, you might ask? And the problem of adherence is when you check the literature, you will find that patient adherence rate is really quite low. Of course, it's related to the disease itself, but if you check for hypertension, for example, the adherence rate is as low as 50%. Similar for breast cancer, which I find quite shocking. Why would someone who's prescribed tamoxifen, for example, decide, I'm not going to take that treatment? What would drive someone who's prescribed letrozole to decide, I'm not going to take a treatment? That other healthcare provider, I think it's a savior. It will save their life. It will extend their life. So what is the reason for that? If we do that study in a quantitative manner, we can relate it to any of the factors that we discussed before. But correlation does not imply causation. We need to understand that problem better to come up with an intervention that actually works. And to understand the behavior, adherence, of course, is a behavior. There are a multitude of health behavioral theories. We have the health belief model, we have the social cognitive theory, we have the theory of reasoned action, we have the theory of planned behavior, we have trans-theoretical theory, we have the fuzzy trace theory, and we have the temporal self-regulation theory. However, these theories, they're quite nice. They explain the behavior in a very good manner. However, they're not really as inclusive as we want them to be. We want a very comprehensive theory. And there come the theoretical domain framework. The theoretical domain framework is one of the most comprehensive behavioral change theories there are. It's quite nice. It consists of 14 domains. It combined the theories of health behavioral change into one key theory, and it serves as a very valuable tool for researchers, to practitioners, to guide an intervention. These are the theoretical domain framework domains. We have knowledge, skills, social, professional role identity, beliefs about capabilities, optimism, belief about consequences, reinforcement, intentions, goals, memory, attention, and decision process, environmental context and resources. We have social influences, emotion, and behavioral regulation. Inside that theoretical domain framework came the COMBI model, the capability, opportunity, motivation model of behavior. The capability, it shows us the capability of an individual to do a task, adhere to the treatment, for example. Opportunity refers to the external factors that actually enable or hinder an individual ability to engage in a behavior. And motivation is the internal drive that actually drives someone to do a behavior. The COMBI model is, as you can see here, it consists of capability, motivation, opportunity. If by the interaction of these three subheadings, they give us a behavior. Now, adherence is a behavior. So if we want to change a behavior, you have to change one of the three, or change two, or force the change in the behavior itself. If you change the thing in that model, it will give us a new configuration, thus giving us a new behavior. That's the theory. Now, the domains of the theoretical domain framework are actually connected to the COMBI subcomponent. So the capability psychological, the theoretical domain framework for that are knowledge, cognitive and interpersonal skills, memory, attention, and decision process, and behavioral regulations. The same goes for the rest. In 2014, Jackson et al. Published a very interesting paper, actually doing what we did, studying adherence and fitting the reasons for non-adherence into the COMBI model. It actually showed us adherence in a continuous manner, as we see here. So we have adherence, we have over-adherence, and we have under-adherence. He then took the factor associated with adherence and correlated them to the COMBI subcomponent that we discussed before. So something like the comprehension of the disease and the treatment comes underneath psychological capability. Something like perception of the illness comes underneath reflective motivation. And something about physical opportunity, like cost, for example, come underneath physical opportunity. By using that model, we were able to actually identify the barriers of non-adherence in a very systematic manner. Now, we can identify the capability barriers, we can identify the opportunity barriers, we can identify the motivation barriers. What they did after that, and this is the work of Susan Mitchie, Dr. Susan, she works in UCL, and her work is terrific on behavioral change. So what she did is then she developed the behavioral change wheel. In the middle of that behavioral change wheel, we have the COMBI model, and then around it, we have the 9 intervention functions, and then it is surrounded by 7 policy categories. Now, using the COMBI model and the theoretical domain framework, we were able to assess the capability, opportunity, and motivation factors. Then, using the COMBI model, we were able to identify the barriers and facilitators. Now it is the time to actually select the appropriate intervention. And this is what Susan Mitchie did and her team. You can see now if the factor of non-adherence is underneath physical or psychological capability, the intervention function to improve adherence in that patient group is through education, training, and enablement. If it falls underneath reflective motivation, it falls underneath education, persuasion, incentivization, coercion, and so on. So now we assessed the need, we selected the intervention. Now it is the time to actually implement that intervention. We have to plan how to implement it, and then we have to monitor and evaluate. Let me take you through some example of my own study where I was working with women who were prescribed tamoxifen. As you know now, tamoxifen is prescribed for up to 10 years, so you can actually imagine that adherence issues are there. One of the interview that I did showed that one of the patients had trouble remembering to take the treatment. Now, the ability to remember to take the treatment is associated with cognitive function. Cognitive function falls underneath the CUP component of psychological capability. So what is the intervention function here? It's either education, training, and enablement. In theory, the proposed intervention we came up with was to advise patients to use Reminder app, or by tailoring the treatment to their daily routine and habits, they will be able to actually remember to take the treatment, for example, with their coffee in the morning. Let me give you a second example. One of the issues we had with the patient is that they didn't trust the treatment and its necessity. They didn't trust tamoxifen. They didn't trust letrozole. So this falls underneath beliefs about the treatment. Beliefs about the treatment come underneath the COMBI component of reflective motivation. What are the intervention functions for reflective motivation? They're education, persuasion, incentivization, and coercion. Now, for that reason, we gave the patient information about the consequences of not taking the treatment. They don't believe that it is necessary, okay? If you don't take it, this will happen. Then we discussed the belief about the treatment. What's the reason they don't believe that the treatment works? We need to understand it better. When we actually identify the issue, we will be able to actually correct it. The third example is discussing cancer taboo or acceptable. In many societies, us included, discussing cancer is still a taboo topic. Not a lot of people like to discuss cancer in their social gatherings. So this falls underneath the factor associated with adherence of the stigma of the disease or the fear of disclosure. This is related to the COMBI subcomponent of social opportunity. The intervention function in that case has to do with restriction, environmental restriction, modeling, and enablement. So the intervention we proposed was to provide survivor with a safe haven to actually express themselves, or choose speakers to actually come and talk in public about the issue of cancer, about the stigma of the disease, thus normalize the experience of those patients. After we implement that, and here where it gets a bit tricky, we have to measure the effectiveness of the behavioral change intervention that we actually applied. We have to evaluate and study the impact and effectiveness of this, and this takes a long time. Then we have to systematically measure the outcome of this intervention. If it succeeds in increasing adherence to a certain percentage where it becomes acceptable to us. It's quite challenging because this will take a lot of time. However, this is necessary. But what we need to do, we need to secure stakeholder buy-ins. Healthcare providers, policymakers, everyone should be and take place in that in that method. Also, we have to adapt to organization culture. We have to make this the norm in our healthcare system. When patients come to you suffering from issues with their adherence, you have to actually understand what they're going through. You have to adapt that in the culture in the pharmacists. You have to train the pharmacists. You have to train the physicians in a way they can actually systematically find out what is the reason that patient decided I'm not going to take the treatment. Then we have to ensure adequate resources allocation, because this will cost money. It will cost money because you need training, you need education, and so on and so forth. And the most important thing is to maintain long-term sustainability. This does not happen overnight. It will take a lot of time. Training will take a lot of time. Adapting this into the healthcare system will take a lot of time. In conclusion, we adapted a comprehensive approach to understand the behavior. We then personalized intervention based on the need of the patient, based on the understanding of what they're going through. Then we collaborated with the patient themselves. We actually heard from the patient. They are engaged with us in deciding what treatment is the good for them. And then we have to continuously evaluate and improve our treatment plan. This is a quote that I love to end every presentation I give about adherence with. This is by Charles Everett Kopp, the former Surgeon General in the US, and it is a very simple quote. Allow me to read it. Drugs don't work in patients who don't take them. As scientists, we love coming up with new medications. We love developing new interventions. However, you have to keep in mind the patients, if they decide not to take the treatment, what's the point of it all? Thank you so much.
Thank you so much, Dr. Osman. Next, I wanted to introduce Professor Derek Stewart. Professor Derek is a professor of clinical pharmacy and practice in Qatar University and visiting professor at Robert Gordon University in Scotland and the Royal College of Surgeons in Ireland. He's also the editor-in-chief of the International Journal of Clinical Pharmacy and immediate past president of the European Society of Clinical Pharmacy. He is an international renowned educator and researcher and a past recipient of the Royal Pharmaceutical Society Practice Research Award. His research focuses on the development, evaluation, and implementation of models of clinical pharmacy practice and medication safety. He has published over 260 peer-reviewed papers and supervised about 30 PhD students to completion. So please help me in welcoming Professor Derek Stewart. Thank you.
Salam alaikum wa masal khair, and that's my Arabic. So I'd like to start off by thanking the organizers for inviting me to this wonderful conference. It's my second time in Riyadh in 6 months. Can you all hear me at the back? Yeah? Yeah? Thank you. I'm going to try and waken you up because we heard about burnout and overload. So I'm going to try and get you involved in this. This is quite a special event for me as well because this is my last week at Qatar University. I've been there just over 5 years, and Dr. Osama yesterday said not to use the term retire. So I'm not retiring, but I'm going back to Scotland to think about different things to do. And I'm quite happy to come out and do some consultancy. So if you want me to come and do anything on research or education, please let me know. So yeah, I've got a position as professor at Qatar University, and I'm also editor-in-chief of this wonderful journal, International Journal of Clinical Pharmacy. So I'm going to be speaking today about quality publications. And that's really, really important, because if we don't publish, we don't have evidence. If we don't have evidence, we can't generate evidence-based clinical guidelines. And I speak to lots of people who say to me, Derek, I've collected lots of data and I just don't have time to do anything with it. I don't have time to publish it. And I tell them, well, stop collecting the data. Because until you publish it, the research is not complete. Nobody can access it. If you collect data and you don't publish it, it's a waste of resource, it's a waste of time. It's also unethical if you've collected data from people not to put that data into the public domain, into the scientific community, so we can all access it. So I'm going to start off asking, how many of you here have been an author on a paper? Can you put up your hands and let me see? So a few of you. Can you keep up your hands if you've also been a reviewer for a paper? So we've probably got more people authoring than reviewing, and I'm going to come back to that in a minute. And I want to focus on quality publications, because we could probably get anything published, but we need it to be quality, which means we need it to be original. We need it to have impact. It needs to make a difference. It needs to be well designed. We need to have robust, rigorous data with appropriate analysis. So what I'm going to take you through today is thinking about why do we do research and why do we publish it? And it has to be to make a difference. We need to get impact from our research. We then get really fixated and hung up on impact factors and quartiles without really understanding what they are and what the limitations of these are. It's the most common question I get asked: what quartile is your journal? Rather than what's the scope of your journal. Then want to think about the actual quality of the publications and how to report quality publications. And there are lots of checklists on a website called Equator that are really useful. And then I'm going to and we're working together to try and advance the discipline. So a bit about my journal, International Journal of Pharmacy Practice. Anybody published in it? I know one person has. Well, hopefully you all will after this think about it. So we are an international peer-reviewed journal. We publish really anything to do with clinical pharmacy practice, education, and research. We're also affiliated with the European Society of Clinical Pharmacy. So we are not a society journal, but we've got a link with that society. That society is also very close to my heart, because until last November, I was the president of that society for 3 years. And I was very fortunate to be invited to speak at the Saudi Clinical Pharmacy Conference last year as president of that society. So why do we publish? You know, we publish to improve our profile, our career, our reputation, but those are all minor things. What we should be publishing for is to make a difference and to have some impact. And this is a really nice definition that I like, which comes from the UK. It's quite old now, but it's still really important. And when you look at that definition, there are some key words in it. And every PhD I've supervised, they put this into their final chapter. Because in the last chapter of your PhD, you're thinking about, so what? What difference has this made? So research impact is about the demonstrable contribution excellent research makes. So the research has to be excellent. And we want to make a difference to society, how society works, or economy. And that difference might be on you, but also so it might impact the researchers. We might do better research because of that study being published. Hopefully we make a difference to professional practice, to patient care, maybe to our organizations, and then hopefully to society as well. And this is a great graphic. Again, for PhD students in the last chapter, I always get to reflect on this, because this diagram speaks about the impact of research in two main bits. So the orange bit is about the academic impact, which is about the knowledge economy. What do we know that we didn't know before? It speaks about highly skilled researchers, things like that, improving our teaching, because our research should underpin our teaching. But then the bit green is the wider impact, the impact on patient care, on professional practice, on economy. And that's why we should publish. That's why we need quality publications. Not having data languishing in computers or drawers that never sees the light of day, nor just having the approach of, I'm going to do a tiny study and let's get it published. in the journal, I have got a publication budget. I can publish about 150 papers per year. I get around 1,200 submitted per year. The biggest reason I reject them is that we know the answer before you've done the research. So if I get submitted a paper that quantifies drug-related problems in an intensive care unit over a period of 2 weeks, I can tell the answer before I read the paper. There will be drug-related problems. Some of them will be the wrong drugs selected, some of them is the dose too high, dose too low, that the duration's incorrect, the formulation, the dose, and so on. And that the prescribers accepted the majority of the recommendations. So why publish that? Because we know the answer. That will make no impact at all. And thinking about quality publications, these are questions that we ask our reviewers to report on. So these are really important to think about as you plan your study and as you think about publishing. So is the issue worthy of investigation, or do we know the answer before we start? And I was really pleased to see the last presentation all about theory and research, and that's something really also important to me, because a lot of the research that we publish, we look for the theoretical framework for the research. People doing interviews, questionnaires, it's less likely to get published if there's no theoretical underpinning to that research. Is the article original enough for an international journal? So your studying drug-related problems is maybe really important in your country, so it's likely to get published in a national journal, not an international one. Has the research been conducted ethically? Now that doesn't just mean has it got ethics approval, but has it been conducted and reported in an ethical manner? Is the method sufficiently rigorous or robust? Which means we need a very, very clear aim. So if I read your study and I can't understand the aim, I can't judge if your method's appropriate. I can't judge your data because your data and your results must answer the aim. So that takes on the data and so on. And quite often I read papers and the conclusion has got nothing to do with the results. So the conclusion must relate to the aim, the method, and the results. And just to touch on journal metrics are important, but you have to know what they are and what they're not. And there are two main bodies that produce journal metrics. The big one's Clarivate, which produces the impact factor, and there's also one called Site Score that comes from the Scopus database. It's produced by the publisher Elsevier. Now they calculate the Site Score with 3 years of data. The good thing for Site Score is that it's got a category for pharmacy. So the journals within that category are all similar. So we are comparing like with like. You can see there that International Journal of Clinical Pharmacy we rate quite highly. We're in the top quartile. That's not too important, but it's understanding what it is. The big one is the impact factor and the quartile that comes from that. That comes from Clarivate, which is a massive analytical organization. It works out the impact factor, the citation, the last 2 years. It uses a massive different metrics that I get confused by them. But we need to know what's the impact factor good for and what it's not. And I'm not going to read this, but if you go into the Journal of Citation Reports, you can search for every journal, get all the metrics, but every journal's got this statement with it, that we should not use the impact factor for tenure. It's to use the impact factor. So don't always think when you're selecting a journal, what's the impact factor and what's the quartile. And again, you can see one of the difficult things for pharmacy journals is that we're classed pharmacology and pharmacy. And the big pharmacology journals, that includes the Lancet, the New England Journal of Medicine, we will never compete with them because the pharmacy journal is a very small group of journals. So we always end up at the tail of the quartiles in that category. IJSP this year moved into quartile 3. And that takes me on to the Equator Network. Now, if you are going to conduct research or report research, please look at this website because it will improve the quality of your publications. This is an international website that hosts lots of different checklists for reporting different studies. And they have checklists for just about every study design. So when you submit to my journal, you must submit the completed checklist for your study design. And just an example is the PRISMA checklist for systematic reviews. So look at those because they improve the quality of your reporting. To finish with, I want to tell you a little story about, I've been editor for about 3.5 years. And I started to think, well, what's my role? I manage the journal. We reject most papers. We accept some. We provide feedback. But how do we actually move the academic discipline of clinical pharmacy, pharmacy practice, social pharmacy? So 2 years ago, and this is very unique, a group of editors across many journals, we got together in Granada in Spain, which is a beautiful place, to really think how can we work together. And we produced what's known as the Granada Statements, and again, very unique, that same paper of these statements was published at the same time in every journal. And that's the IJSP publication. There are 6 categories of statements, and I'll just go through them quickly. The first one is think about using the right terminology in the paper. Is it compliance? No, it's not. It should be adherence. So are we using the right terms? So the authors, the reviewers, editors need to think, have they used the right term in their paper? And that's particularly important for the abstract, because it's from the abstract that the MESH, the National Library of Medicine in the States, pull out the MESH headings. They don't look beyond the abstract. So if the abstract doesn't have the right terms, you might not get the right MESH term allocated, which means that your paper might not be identified in a systematic review. So we need to think about using the right terms in the title and the abstract. We need to think about the required peer reviews. We need to get researchers much more active in reviewing. You'd be surprised the number of times we accept a paper, then I invite that author to review for us, and they decline that invitation. Which means it's okay for us to get someone to review your paper, but you won't participate in the review. We need to educate our students, our undergraduates, PharmD, PhD students on how to review. We need to think about journal scattering, actually taking some of the best work into the pharmacy journals. Quite often the randomized controlled trials go to other journals and we get the more minor piece of work. They're still high quality, but why not bring the randomized controlled trials to us? And to think about using these metrics wisely. So don't get fixated on impact factors, quartiles. Think about the best journal for your research. And then to think, if I am going to publish in a pharmacy journal, what's the most appropriate pharmacy journal? So bring the clinical things to me, bring the social ones, maybe to Research and Social Administrative Pharmacy or International Journal of Pharmacy Practice. And the work of that group is continuing. So next month, we're going to be in Basel in Switzerland, thinking again, how do we keep moving that discipline of clinical pharmacy, social pharmacy, pharmacy practice? And I just want to finish by speaking about artificial intelligence, because that's really changing the landscape of publishing. And that's a tool to make our writing better, but it's not a tool to substitute for us. So if you are using one of these tools to improve your grammar, make sure you declare it in the acknowledgements. But don't use artificial intelligence to write your paper, because we can identify it. It uses standard terms if you use ChatGPT. So if in your discussion I see these findings underscore the work of others, I know straight away that's ChatGPT. If you haven't acknowledged that, your paper is likely to be rejected. Or if you're using these systems, read your paper. I had one yesterday that in the introduction said that clinical pharmacy is responsible for drug supply and selling cosmetics. Really? Really? Is that the best that we can say about clinical pharmacy? And I had another one yesterday in the discussion, spoke about pharmaceutical care was developed in the States, and that's why all the leading researchers are from the US. And that wasn't referenced. You think that has come straight from ChatGPT, has not improved that grammar, it has written that for you. So ChatGPT, these systems have come on really quickly. They are useful systems, but do not use them to generate your text, because it will be identified and your reputation will really be affected. So just in summary, if you go back to the objectives, I wanted you to think about the impact of research, quality publishing, think about the right journals, using checklists, and really think about impactful research as you design it. Why are we doing this research? What difference can this research make? And if you're not going to publish research, please don't do it. Thank you.
Thank you, Professor Derek. If you want to invite you on the stage. So we're going to have another, for about a 5-10 minute session, Q&A session. I'm going to start with Professor Derek. And as you were talking throughout the session, I was thinking about AI, and then you ended with AI. So just to kind of recap or try to get an understanding. So is it acceptable for someone, if as they are initiating their research on a project, to do a search through ChatGPT and use it as a reference, actually reference that they've actually, part of their research, done a ChatGPT search?
Absolutely. I mean, these large language model systems have come in very, very quickly, but they are going to change the landscape of what we do. And actually, we're about to launch an IJCP call for a special issue on using artificial intelligence and advanced technology in research and practice. And it's completely acceptable to use these systems to help generate research questions, to help develop interview schedules. If you're using them in the development of the research or the conduct of the research, you must declare that in the method. But you cannot put ChatGPT as an author, because authors have to be able to defend the work, and ChatGPT can. So if you've used it as part of the research, and we've got a nice commentary just coming out now, IJSP, about how some authors have used ChatGPT in research and delirium to help identify and really fine-tune the research questions, interview schedules, and so on. So if they're used in the research, they need to be declared in the method. If they're used in improving the language, that should be acknowledged. If you go onto the website, IJSP is published by Springer. On all the Springer journals, there's a free AI grammar improvement tool. It's free for one use, and then you have to pay beyond that use. So yeah, I can see it being a bit like SPSS. I'm sure when all the stats software came out, the pure statisticians thought this is terrible. No one will know about statistics, they won't know what they're doing. I see these as a tool to really improve what we do. We just need to know how we're using them and to declare that we are using them.
All right, thank you. Any questions from the audience? Okay, I have a question for Dr. Othman. You've mentioned in your presentation around the use of COMBI as a way for you to assess and work on the conversation around persuasion and then getting adherence with your patients. Do you have any, or can you give some feedback on the use of COMBI when you're developing patient education material, for example, where you would benefit of having a form of a structured behavioral change theory when developing content that addresses patient adherence?
Thank you. That's a very interesting question, and this is actually the strength of the COMBI model. It is to develop educational material. This is the work that I did. When I tried to actually understand what women were going through, the idea that I had in mind is to come up with a prevention, a one-fit-all solution. This is impossible, especially in the case of cancer. Everyone experiences cancer differently. So the COMBI model gave me the basis of identifying the barriers of adherence in that patient group. Based on it, I was able to develop an educational material, multiple pictograms, if I can say. It's around 78 pictograms where women can look at it, identify themselves in that experience. The problem with patients is they don't actually know sometimes what they're going through. You need to give them a basis of identifying their issue themselves. So when they look at that pictogram, at that drawing, they find themselves, for example, in that drawing where they're suffering from side effect, as an example. This comes underneath the COMBI model component of psychological capability. So now I can actually give them an intervention based on the experience that they just now identified.
I mean, that's an excellent point. As we're developing patient education material, because I think one of the biggest challenges that we see right now is we have a lot of abundance in information. We have a lot of people that are pushing out research and data and information, and now becomes how do you utilize it to be able to modify it in a way that's actually could be used by our patients. My next question, you talked about use of grammar enhancement software. Can you elaborate a little bit more about the ethical use of that software, and is it making everyone's now writing very, very similar, or does it still allow you to have a bit of a flexibility?
I mean, the appropriate use of it is, as you say, it's grammar enhancement and improvement and not substituting for you. So what it will do is improve the grammar that you have got. So it should still be using your style of writing in that. And it's that fine balance between, I quite often send papers back because they're poorly written. So it's thinking about using these tools, but you need to have written it yourself, and then the grammar tool will improve your grammar. But where I see people just using ChatGPT or these sort of systems to write things for them, that's where you see the standard bits coming through. I had a paper just a few days ago that in the strengths in the discussion actually said a strength was that the study was meticulously crafted. That's not a scientific term. So nobody has written that. So that has been written for them. So it's thinking about using these systems appropriately and then declaring them. But maybe more and more the emphasis will be on the science and less on the writing.
Any questions for the panel? Yes.
Assalamu alaikum. My name is Faisal Al-Amri. I want to thank everybody on this panel. My question will be mainly for Dr. Derek. We see some AI tools, like rather than focusing on generating content, it's more of generating references. You can see some authors that will write their opinion and will use these tools to generate reference to prove their viewpoints. I want to see your view on how this will impact the author and his
Again,
validity.
it's difficult to give a generic answer to that sort of question. But one thing that does get checked, every time a paper comes into us, there's an automatic plagiarism check, AI check, and check on the referencing. And one thing our reviewers will do, and that I will do, is make sure that discussion is balanced. So we want to see that coming through as well. So if it's just given one-sided, and these tools are not great at referencing, but they are improving. The new release of ChatGPT is likely to go on to the new release of Word. So it'll be there as a tool as you're writing to continually improve what we're doing. So I think the difficulty we've got just now is just the speed at which these things come in. If you go back a year, they really weren't there. So it's just changed it so much. Where it's even a bigger issue is within schools and universities. If you've to write an essay on something, it's really difficult for a school teacher to know where's this come from and who's done this. So yeah, it's very much a changing field. We rely on the editors, the reviewers, think things are balanced with the referencing. I mean, people who are reviewing papers should be experts in their fields, so they should know the literature that should be cited and not cited within that.
Thank you very much.
Thank you. Any other questions from the audience? I have one last question for Dr. Uthman. So you mentioned on a topic where you had been using pictographs, one educating patients on breast cancer or cancer, correct? Can you give example of which area of education you've been using the Combi the most, or what topics you're seeing are requiring a lot of development of content for patient adherence, at least maybe in the Saudi experience?
Sure. So one thing I want to discuss before answering that question is the importance of qualitative research. And I think this is something that here in the region we don't really focus on. We focus a lot more on quantity. So in the time it takes me to publish one qualitative paper, I can publish 4 or 5 quantitative ones. However, for a poorly understood phenomena such as adherence, we need to understand what is happening. That's why we need qualitative research in that field. And this is just one topic. We can actually say the same about a multitude of topics in healthcare in the Middle East region. So to understand what women are going through in the form breast cancer, for example, women are prescribed tamoxifen or aromatase inhibitor for up to 10 years. Their adherence rate is quite low. It reaches as low as 40% by the 4th year. You can imagine that as they continue, the percentage will decrease even more. Why is that? When you ask the patient, why did you do that? When you write a questionnaire, for example, and one of the answers in the questionnaires is side effect. They tick side effect. What does a side effect really mean? What does it mean exactly? So I was reading lots of qualitative research about breast cancer, and I wasn't able to find any qualitative research that actually underpinned that phenomena and connected it to one of the health belief theories that I discussed before. And this is quite important. The other thing is we don't have really a lot of trained academic in the field of qualitative research, especially in the Middle East region. So what I used is I just took the theories that are already out there. I asked the patient what they're going through, and I then started to code what their answer is, connect it to their answers to the theoretical domain framework and to the Combi component. Then I was able to develop pictogram that actually inform the patient of the experience they're going through. Then underneath this pictogram, I developed multitude of intervention. So for example, side effects, is it fear? If it's fear of side effect, these are the intervention. If it is misinformation about side effect, this is the intervention. If it has to do with where to find information about how to manage your side effect, these are the intervention. This is how we educated patients. We just help them identify themselves and their experience, and then give them the intervention. Thank you.
All right. Thank you. Thank you both for your time and for your questions.
Yeah.
Thank you so much. Thank you.
Thank you.
As we come to the end of this session, I would like to take a moment to recognize 3 individuals who have made invaluable contributions. Dr. Rashid, please come with us on the stage to honor our dear guests. First, I would like to express our science gratitude to Dr. Rabi'. Your expertise and insight have truly enriched our understanding of this important topic. Secondly, I would like to thank Dr. Uthman for his remarkable contribution of the panel discussion. And finally, join me in thanking Dr. Derek. Thank you all for your participation and engagement today. Your contribution have helped advance our understanding of the best practices in ensuring safety and quality. Thank you again. Finally, we will delve into the fascinating realm of toxicology. This session will explore the far-reaching impact of this specialized discipline, highlighting its crucial role in shaping decision-making and informing organizational policies across a wide range of professional sectors. Attendees will gain a deeper understanding of the latest advancement in toxicological research and their real-world applications. This session will be moderated by Dr. Abdelaziz Al-Dilgan. Dr. Abdelaziz is a consultant forensic toxicology and section head of toxicology lab at Security Forces Hospital at Riyadh. He has master in toxicology from Birmingham University and PhD from UK. Dr. Abdelaziz, please make your way to the stage. The mic is yours.
السلام عليكم ورحمة الله وبركاته. بداية I hope not just a conference, it's more than this. بداية أحب أني أشكر الدكتور محمد الشناوي والدكتور أبو بكر وجميع اللجنة أعضاء اللجنة العلمية واللجنة المنظمة. This is toxicology season. Please let me to introduce my friend Dr. Fawaz Al-Asmari. Dr. Fawaz Al-Asmari graduated from King Saud University with a bachelor in pharmaceutical science in 2011 with a case of honor. Dr. Al-Asmari then joined the executive director of pharmacogenetics and crisis management of Saudi Food and Authority and Drug Authority as a pharmacist. In 2012, Dr. Al-Asmari moved to the Department of Pharmacology and Toxicology, College of Pharmacy at King Saud University as a teaching assistant. In 2013, Dr. Al-Asmari started his graduate studies at the College of Pharmacy and Pharmaceutical Sciences, the University of Toledo in USA. In 2015, Dr. Al-Asmari obtained his Master of Science in Pharmaceutical Sciences degree in Pharmacology and Toxicology. In 2018, he graduated from the University of Toledo with a PhD in experimental therapeutic. Dr. Al-Asmari returned to the College of Pharmacy in King Saud University as an assistant professor of pharmacology and toxicology. He is working on different research projects related to toxicology of drugs of abuse, and he has published more than 50 peer-reviewed articles in the field, and he is now associate professor of pharmacology and toxicology. Dr. Al-Asmari supervised several graduate students, and he is teaching graduate and undergraduate courses related to neuropharmacology. In the end of 2023, Dr. Al-Asmari got his Master in Healthcare Administration from Saudi Electronic University in association with Colorado State University Global. Please welcome with me by Dr. Fawaz. Dr. Fawaz will talking about effects of beta-lactamase of fentanyl-induced neurotoxicity and hepatotoxicity.
يعطيك العافية. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساء الخير. في البداية حاب أشكر اللجنة المنظمة دعوتهم الكريمة لأكون أحد المتحدثين اليوم. Today we will talk about the fentanyl overdose and how we can modulate the toxicity effect of fentanyl, because we know that fentanyl can induce the respiratory depression, but no one knows about the molecular effect of fentanyl on liver and central nervous system. So in the beginning, I will talk about the fentanyl statistics. As you can see here, there is high increase in fentanyl overdose use in male and female over years. So this suggests the misuse of opioid in healthcare organizations, and we need to target this issue by attenuating the toxicological effect of fentanyl. So also this diagram shows the synthetic opioids such as fentanyl, which was the most drugs that was used in 2020, and there is dramatic increase between 2017 to 2020 in fentanyl use. So we know now that fentanyl is overuse is a problem, and the misuse of fentanyl should be monitored and should be evaluated carefully. And next, as you can see here, from the drugs that are approved in 2021, 438 drugs contain box warning related to neurotoxicity or hepatotoxicity. So this suggests that hepatotoxicity and neurotoxicity is a major problem associated with approved drug use. In addition, as you can see here, the withdrawal drugs, they were withdrawn because of the hepatotoxicity and neurotoxicity in the most of the drugs in 2021. As you can see, 43 out of 326 drugs were withdrawn because of hepatotoxicity, and 15 drugs were withdrawn because of neurotoxicity. So today we will focus on two different molecular targets, the central nervous system. So here we can see the presynaptic neurons and postsynaptic neurons, and we can see here the astrocyte. So we will focus on glutamate system, and we will explain the role of glutamate system in fentanyl overuse toxicity. So the downregulation of glutamate transporter expression in astrocyte is associated with high extracellular glutamate concentration in the synapse. So once we have decreased expression in glutamate transporters in astrocytes, we will have also increased in extracellular glutamate concentrations. So increased in glutamate concentrations in the synapse is associated with neurotoxicity and neuroinflammation. So drug of abuse generally can cause downregulation of glutamate transporters. So the glutamate will not go into the astrocytes because lower level protein levels of glutamate transporters. That will lead to neurotoxicological effects. If we go to the hepatocytes here, we will see the glutamate transporter, which is here. Once we have decrease in glutamate transporters, the glutamate will be accumulated inside the hepatocytes. So that will lead to high cysteine and will lead to glutathione reduction and reduction in the reactive oxygen species, which is very important to reduce the toxicity effect of fentanyl. So our hypothesis is to target glutamate transporters to reduce the toxicological effects of fentanyl overdose. So once we increase the expression of glutamate transporters, we will reduce the accumulation of glutamate in the synapse or inside the cells. That will lead to reduction in the toxicity effects of fentanyl. So we
used beta-lactam compound. So in preclinical research, the beta-lactam containing compounds are essential and critical to reduce the drug-seeking behavior, including morphine and heroin. So in our study, we used fentanyl as a synthetic opioid compound to evaluate the effects of beta-lactam containing compounds on glutamate transporter expression after exposure to fentanyl overdose. So we have three different objectives. We will have molecular objectives. So we will do Western blot techniques in animals, and also we will use the metabolomic study using the gas chromatography to evaluate the brain and liver metabolites after fentanyl overdose and after treatment with beta-lactam containing compounds. Also, we did kinetic study, pharmacokinetic study, to evaluate the dose of fentanyl that can induce toxicity effects in liver and the brain. In chapter 1, we will focus on brain. So in our study, we used the animal model C57 mice, which is the black mice. We divided the groups into 3 different groups. The first group, or 4 different groups, control, received only normal saline, and fentanyl, which received the fentanyl, escalating dose of fentanyl in different days, day 1, day 3, day 5, and day 7. And we have other treatment groups, fentanyl with MC1095. The MC1095 is a synthetic beta-lactam compound. It retains beta-lactam ring, but it has no antibacterial activity. And also we have fentanyl ceftriaxone group, and these 2 groups received the beta-lactams on day 5 until day 9. Then the overdose was in day 9. So in this study, we used behavioral analysis. We used only locomotion, which can evaluate the total distance traveled by the mice. So we can evaluate how long the mice was traveled inside the box, and we can evaluate the effects of beta-lactams on distance traveled after fentanyl overdose exposure. And also we did the metabolomic study to check the metabolites in the brain and in the liver. And also we checked whether the beta-lactams can modulate the alteration in brain and liver metabolites induced by fentanyl overdose. And also we did histopathology to check the neuroinflammation and liver inflammation. And also for protein expression, we used the Western blot. This is the average body weight. There is no difference in average body weight after overdose. And we found there is increase in the distance traveled in fentanyl overdose group. And this effect was reduced by ceftriaxone and MC1093 treatments. This suggests that the beta-lactams containing compounds can modulate the distance traveled or the change in distance traveled induced by fentanyl overdose. So we did also we measured the metabolites in the brain, and we found there are several metabolites was reduced by fentanyl overdose. However, beta-lactam containing compounds did not normalize or restore this change. So the beta-lactams containing compounds have no effects on brain metabolites. So we did BCA analysis, and we found there is clear separation between control and fentanyl, as you can see here, and the beta-lactams has no effects. They did not change or normalize the brain metabolites. So as you can see here, the green one, which is the control group, and the other 3 groups they were decreased in most of the metabolites. These metabolites include sugars, amino acids, and fatty acids. So the beta-lactams containing compounds also, as I said, did not normalize these metabolites in the brain. these metabolites, as I said, fatty acids, amino acids, and sugars, they have a role in the brain or central nervous system for brain activities and other membrane damage and other function in the brain. So these change in brain metabolites are associated with signaling pathway, and these pathways, the most important pathways that are associated or involved in these certain metabolites are lactose degradation and other pathways, including bile acid metabolism and amino acid metabolism. So we also did the Western blot, and we evaluated the effects of fentanyl overdose on brain inflammation, and we found there is increase in the TLR4 and IL-6, which are most biomarkers for neuroinflammation. And the beta-lactam compounds were able to modulate or normalize this neuroinflammation. The most important results here is the GLT1. The GLT1, which is the main protein or glutamate transporters in the brain that can transport glutamate from the synapse into the astrocytes, was reduced in fentanyl group, and the beta-lactam compounds could increase the reduction of GLT1 or glutamate transporter that was induced by fentanyl overdose. So this motion graph shows the role of GLT1, which is the, as you can see here, the GLT1 is the green, the blue one, which is localized in glial cells. So with fentanyl overdose, as you can see, there is reduce in the GLT1. So once the glutamate is released from presynaptic to postsynaptic neurons, it will be accumulated in the, they will be accumulated in the synapse, inducing the neurotoxicity and the neuroinflammation. So we need to reduce the accumulation of glutamate in the synapse by upregulating the GLT1 by beta-lactam treatments. So once we have beta-lactam, so we increase the expression of GLT1, which is the glutamate transporter 1. So most of the glutamate will be transported into the glial cells through GLT1 or glutamate transporter, reducing the neurotoxicity effects of fentanyl overdose. So the GLT1 can be molecular target to attenuate the neurotoxicity effects of fentanyl overdose. So from this study, we conclude that there is a neurometabolic change associated with fentanyl overdose. Beta-lactam could not normalize this change. Also, there is reduction in GLT1 glutamate transporter. Beta-lactam could increase or normalize the glutamate transporters, which associated with restore neuroinflammation and neurotoxicity. So we did the same study in the liver, but here in the liver we found that beta-lactam compounds could restore and normalize the liver metabolites. So the beta-lactams can have good effect or positive effects on liver metabolites, but has no effects on brain metabolites. So this graph shows the majority of the glutamate. So each point here shows one metabolite. So as you can see, in general, the fentanyl overdose can reduce the most of the metabolites, and the MC1093 was able to upregulate or increase or normalize most of these metabolites in the liver. These are the metabolites. And these metabolites that was changed are involved in glucose alanine cycle and gluconeogenesis and other signaling pathway. So we noticed that D-glucose, alanine, succinic acids were the most affected metabolites by fentanyl overdose, and the MC1093 was able to restore at least the glucose. We also did the Western blot, and we found there is inflammation with fentanyl overdose, and this inflammation was reduced by ceftriaxone treatment in the liver. And also cytochrome 3A4 was reduced with fentanyl overdose, and ceftriaxone was able to increase the CYP3A4 enzyme. There is inflammation, as you can see from the histopathology study. There is inflammation associated with fentanyl overdose, and the ceftriaxone and MC1000 were able to reduce this liver inflammation. So from this study, we concluded that there is liver toxicity associated with fentanyl overdose. There are changes in the several metabolites in the liver, and the beta-lactam were able to restore these changes. This study was published in Metabolites Journal. And the last study, which is the pharmacokinetic study, in this study we predicted the toxic dose of fentanyl that can be localized in the liver and the brain after overdose exposure. We utilized software called BKSIM software. In this software, we can modulate 3 different parts. The first part with the drug properties, including physiochemical properties, and also we can modulate the healthy model, healthy population, and also we can do the software, the last parameters. And also we did fentanyl kinetic using this software. We supported drug-drug interactions. We used haloperidol as a substrate for cytochrome 3A4. So as you can see here, the therapeutic effects of fentanyl in the liver should be not exceed 23 microgram per kilogram. If it's higher than 56 microgram per kilogram, this is toxic effects. So we used this software, and we tried to use the therapeutic dose, which is 300 microgram of fentanyl, and we also tried to use the toxic dose of fentanyl, which is 680 microgram. And as you can see, the concentration in the liver was increased higher than 56 with the toxic dose. This program tells us that fentanyl overdose can induce toxic effects in the liver. So we used haloperidol as a substrate, and we used this program, and we checked whether there is interaction between fentanyl and haloperidol. And as you can see from this result using this program, the area under the curve of haloperidol was significantly increased with fentanyl overdose or higher dose of fentanyl, but it was not, and also the half-life was increased with fentanyl, and the total body clearance was decreased with fentanyl. So this suggests the drug-drug interaction between haloperidol and fentanyl overdose. So the conclusion that MC1093, which is the upregulator of GLT1, has a similar effect of ceftriaxone in GLT1 expression. They both attenuated inflammatory mediator IL-6 and behavioral change associated with fentanyl overdose, and both compound normalized morphology appearance of liver tissue after fentanyl-induced histological change. So this is the reference, and thank you very much for attending my talk.
Thank you, Dr. Fawaz, for the great lecture. Our second speaker is Dr. Mubarak Al-Harthi. Dr. Mubarak, emergency medicine and medical toxicology consultant at King Saud Medical City, Riyadh. He had his fellowship in University of Arizona in medical toxicology, currently working as the medical director of toxicology consultation services at the National Referral and Appointments Center 937 and 1937. Dr. Mubarak will talk about pharmacist's fatal role in toxicology consultations at the 937 National Referral Center. Please welcome by Dr. Mubarak.
Thank you. Assalamu alaikum. So let's start with talking about the toxicology and pharmacist. I do believe that the toxicology is an area of a pharmacist practice. We lately invaded this territory as physicians, but when we go back to the roots, it is a pharmacist job and it is a pharmacist science. So we will start talking about our agenda in this presentation. Some definitions here and some explanation. What is the difference? What are the differences between 937 and 1937? And we will show some of our statistics and how we can monitor our job and our staff. And we will talk also about the education and our future opportunities. What are the differences between 937 and 1937, or what is the definition of them? So it is a rapid response consultation services. So it is public for everyone. So public for Ministry of Health, public for private, military, and any other hospitals. It is public for it is free for public too. The aim of this service is to provide the best possible recommendation, and the one is to mitigate the ED crowdedness, and to save some resources, and to raise concerns if we need, especially with outbreaks and so on, to transfer patients to any other hospitals where the services can be provided. And we will talk about our guidelines and how we can write guidelines to our employees, and finally education and evaluation. So 937 is a public phone call for free. It is an initiative by Ministry of Health just to make the consultation an easy job for everyone. We have a specific category of the 937, which is the toxicology consultation services for everyone. The other one is 1937. 1937 is for healthcare providers, for hospitals, and this where we transfer patient to other hospitals. How we can define the best possible way of service? The best possible way. The duration of the call to answer. We need to shorten that time, and the SPI is working so hard to shorten that time. The other way is to obtain the right information in order to give the right recommendations to the public calls. It has to be evidence-based, and it has to follow the protocols if there is a protocol. Sometimes there are no protocols, so we need to invent some protocols for them. And accurate triaging. We will talk in details about the accurate triaging because it is an important job that we do and the pharmacists do in the consultation services. And finally, the follow-ups. There are specific criteria for the patients to be followed up. So let's get some statistics here. In 2023, we received more than 63,000 phone calls. It's consultation services. Some of them are public, which is the majority of them. It's around 66%, and 33% from the hospitals. So this number can be classified according to the regions. You can see here Riyadh, which is the most common area for consultation. Other areas can be part of it. The second one, and you can see the amount or the xenobiotics that have been consumed or have been exposed to. Pharmaceuticals is number one, 36,000 cases, and so on. So the main job in the public phone calls is to triage the patient. Which patient needs to go to the hospital and which one does not need to go to the hospital. So according to our SPI and the statistics, SPI is a specialist in poison information, just to be familiar with that term. We triaged almost 76% of our callers to stay at home, to be observed at home. They don't need to go to the hospital. So this triaging system is done mainly by pharmacists. We have around 8% of great nurses. They are working with us. And how can they do this? We have some references. So they have to follow these references in order to be accurately triaging patients. One is approved references like Talkspace and Micromedics, approved guidelines, especially in our center. The third and last one is the clinical judgment. The SPY, after a certain period of time, they develop some experience. They can tell this patient needs to go to the hospital or not. Do we save resources? One of the most important areas for our center and service that we need to save resources in order to justify the justify the budget. We need to save resources. So, roughly speaking, the AD visit cost around 500 to 1,500 riyal. We don't have real statistics in the Ministry of Health because of immature coding system, but we can assume that this is the average number of them is 800 Saudi riyal per visit. So in 2023, there were more than 32,000 patients. We ask them to stay at home. They don't need to go to the hospital. So roughly speaking, theoretically, we saved more than 30 million riyal. So this is a good saving resources job that we have done with the great pharmacist at the center. Reducing toxicologist consultation. So we have limited number of physician toxicologists, around 20 to 25 in the whole kingdom. So you cannot provide each tertiary hospital with a toxicologist. So what we need to do is to take the whole phone calls and to see if everyone needs to be connected to the toxicologist or not. Most of them, they don't need to be connected to the toxicologist. The SPY, the specialist in poison information, they are doing this job. Reducing unnecessary procedures, for example, gastric lavage. So before they call us, some centers, they perform some procedures in order to do to save the patients. For example, gastric lavage. It is outdated. We don't recommend this anymore, for example. So we recommended 0 gastric lavage, whereas around 130 cases, gastric lavage was done before they call us. So, we save this kind of resource just to make sure that it does not harm the patient and it saves the cost. What concerns that we raise? We have a center, we have a huge number of calls that we can pick up the very worrisome calls. For example, the outbreaks, especially in the lately botulism, and methanol and ethylene glycol cases. They come always in clusters, so we need to be prepared. We inform the hospitals to be ready, and we have to arrange transfer between hospitals according to the need. The second concern we are working on is the mental health crisis concern. Who are those people? Those people who call us and they want to commit suicide. So we need to arrange for them a way to get connected to the National Center of Health Program اللي هو المركز الوطني للرعاية الصحية. Recurrent suicidal callers, we can connect them through their data between hospitals. So we can tell this patient has been here according to the ID number. And lastly, trending dangerous social media ads, for example, sprayed organophosphate. It has been lately observed, it's actually 3 years ago observed in some of the regions. And Benadryl challenge, it was on TikTok. Our fifth job here is transfer patients between centers. So if the hospital or someone called us from the hospital that this service is not provided, so we need to arrange a transfer to another hospital where the service can be provided. And in 2023, around 450 cases needed to be transferred. Why? Lack of appropriate service, for example, dialysis or ICU. The second one is unavailable antidote, NAC. Sometimes unavailable labs. What are the requirements that the pharmacist has to make sure it is present before the transfer? With the discussion with the toxicologist. The first one is the stability of the patient. The patient cannot be transferred while he's unstable. The pharmacist needs to check, and our pharmacist done a great job to ensure this. Availability of needed services in other hospitals. Not always the right case here, but sometimes we work on it to make sure that we transfer the patient to the other area where the service is available. The sixth job that we are doing here with the pharmacist is establishing guidelines. A great team of clinical pharmacists, well-experienced clinical pharmacists working on guidelines. Usually they choose the right topic based on our statistics. And they need to go first with literature review if there is any benchmark that we can rely on. Second thing is they need to write it down according to our need. And it has to be reviewed by toxicologists and to be monitored, and we have to rearrange it if we need to change or edit the whole thing. One example here is acute paracetamol overdose. We need to make it more of realistic guidelines. Most of the hospital, they don't have paracetamol level. So if you go to the international guidelines, you'll find that they need paracetamol level after 4 hours of exposure, but we don't have it. So do we need to transfer this patient because if there is no paracetamol level, or we should treat? So we came up with these guidelines to fix those kind of issues in our experience. Another example here is snake bite, which is a very geographical and a very, very spot kind of issues, medical issues, needs to be organized based on our numbers. Educations. How do we do educations? We have daily evaluation. We have a quality team that they do daily evaluations. We have certain criteria. We will talk about it in the next slide. The second thing is we have weekly activities, usually presented by the toxicologists, and mandatory attendance for the spies, and monthly meeting if needed. And we are working here with the Saudi Commission, with the Saudi Pharmacist Society on the SPI certification program. It's a 1-year program. It's going to be seen, inshallah, amma qareeb. And toxicology fellowship program, it has been approved by the Saudi Commission for Health Specialty. We are working on it. Now we have multiple emergency medicine residents and pediatric emergency medicine fellows. They are rotating with us. So these are the KPIs. For example, in one of the days, few days ago, on May 22nd, I'm going to give you an example how we do this. Here are some criteria that we do it on daily basis. نسبة إنجاز المكالمة، متوسط مدة المكالمة، عبارات الافتتاحية. We have another more scientific KPIs here. For example, following the protocols, the المام المعرفي, الجودة, the knowledge itself, it has been improving or not. We are targeting 100% on daily basis, but sometimes we reach to 92, 93, which is good. Another here, القدرة المعرفية. What kind of xenobiotics, what other xenobiotics has been involved in the exposure. So what are the opportunities of the toxicologist consultation services? We think that it can be expanded in the future to multiple areas, multiple regions, multiple jobs. Now we might need to change the model from part-time job to a full-time job in order to save some resources and costs and to cover most of the areas. Research project, we have more than 500,000 cases actually documented, uncharted, some of them are uncharted territory, so a lot of research opportunities. In terms of continuous education, we are working on a certificate of specialist in poison information, as we stated previously, and CMEs for the activities that are ongoing. And thank you so much.
يعطيكم العافية دكتور فواز ودكتور مبارك. First, I have a question for you, Dr. Fawaz. Can you talk about beta-lactams in clinical side for human and used in hospitals?
Yeah.
Just
So the beta-lactam containing compounds in clinics, there are many side effects associated with the beta-lactam use in clinic because the bacterial resistance is the major big issue associated with beta-lactam use in clinic, and also other side effects related to antibiotic use such as diarrhea and vomiting and others. So to treat neurological disorders including drug of abuse, the beta-lactam are potential in preclinical research in animals. So to make them successful in clinics, you have to solve this problem by using other beta-lactam, which they can retain the beta-lactam ring, but they don't have antibiotic activity, such as the MC1093, but it needs a lot of preclinical studies and clinical studies. And also the preclinical research found that beta-lactamase inhibitor, such as clavulanic acid or sulbactam, can also reduce neurotoxicity and neuroinflammation with drug of abuse. So they can also look at the beta-lactamase inhibitors to avoid the toxicity effect or side effects of antibiotic use.
يعطيك العافية دكتور فواز. My question for Dr. Mubarak. Great lecture, and I think it's the important role for the 937 in Saudi Arabia. Now, in your lecture, you mentioned about some statistic in 23. It's about 66% of calls from the public and 33 from the hospitals, and also some statistic about the toxics or poisons from where's the sources. My question is, do we have any statistics about drug-related deaths rate in Saudi Arabia? Like you mentioned about paracetamol, some toxics. Do we have statistics like this? What's more drugs can lead to death, like what we have in USA, in some European countries, drug-related death? Do we have this in Saudi Arabia, or maybe you suggest to be like one of the recommendation of this? Or can you comment about this?
So the statistics are there. The problem is the follow-up. Most of the time, we lost the follow-up, so we do not know exactly what's going on with the patients after we lost the follow-up. So yes, we have some statistics of mortality, drug-related mortalities, but we cannot tell this is this is the peak of the drug itself, because a lot of cases have been lost during the follow-up.
يعطيك العافية. Another question for Dr. Fawaz. What's the pharmacist role in a hospital and medical settings in toxicology?
Yeah, for my topic, which was focused on the fentanyl, we suggest that the pharmacist also focus on other side effects related to fentanyl overdose, because the respiratory suppression or depression is the major concern associated with fentanyl overdose exposure. So they should also look at other side effects that might be also associated with fentanyl overdose, including the neurotoxicity side effect or hepatotoxicity. They should counsel or discuss it with the healthcare providers about the optimal treatments, also what's the recommendation for the patients. And also they should look at the drug-drug interaction. As I mentioned, because if the patient has on cytochrome 3A4 compounds, such as haloperidol, for example, the concentration of haloperidol in the body can be changed if he was exposed to fentanyl overdose. So they should also evaluate or monitor patient for haloperidol, for example, toxicity. So the pharmacist has big role in the toxicity of fentanyl and other abused drugs.
Thank you. Dr. Mubarak, 937 Center, we know now that it's a great job, not just in Saudi Arabia, even in the world. Before Corona pandemic was 937, it's now there is like jump. But do you have any plan to develop or taking 937 Center to another stage or another level?
From toxicology perspectives, our plan is to develop, yes, in order to
Yes,
achieve
especially
some-
for toxicology, you are right.
just to make it easy for the callers, either public or hospitals, we need to unify 937 with 1937, and we need to do some promotions in order for people to know our service and how we can save money for the health, for the Ministry of Health and for insurance companies and so on and so forth. So yes, and this is what we are working on it. The other part is there is a special department تحت الخدمات المساندة وهو laboratory toxicology. We need to work in collaboration in order to ensure that the service from lab-wise and from clinical perspective working together to provide the best care possible and to save resources.
Thank you. Is there any question, please?
Assalamu alaikum. We all heard about the last incidents. We all heard about the last incidents of poisoning that happened, that become a trend in a lot of social media. So what the role of National Repair Center in this incidents, specifically?
Dr. Mubarak.
So I think the most important role is to notify authorities. When we receive the call and the specialist in poison information, discuss it with the consultant, to go through the case and the presentation itself, whether it goes with the case definition of wiqaya. So we need to notify. If this is okay, according to the case definition wiqaya, this is positive, so we need to inform the public health. And they go with a special team. It costs huge amount of money and huge amount of resources in order to do this job. And they send labs and they take to go to the origin of it, whether restaurants or coffee shop or whatever. So yes, our job is to notify according to the case definition of wiqaya and to send the public health to that area and to that patient to investigate and to track the case.
Thank you for your question. Any other question, please? Okay, thank you. Sorry, yes. The last question, please.
I want to thank you all for the amazing session. My question is about the toxicology fellowship program. I want to know who is eligible to apply and the duration, and mainly what will be the topics that people will be trained in this fellowship program.
So the toxicology fellowship is designated for physicians. It's a 2-year program designated for physicians. But we have another course that we're working on it and سيرى النور قريبا إن شاء الله اللي هو certificate for specialist in poison information. That it would take some requirements, 1 year of experience, certain hours of phone calls and so on. So probably 2 to 3 months from now we will be able to announce it.
Thank you, Dr. Mubarak. Thank you, Dr. Fawaz.
Thank you for our speakers for such informative sessions. And now I would like to invite Dr. Rashid Al Ghanem to honor our speakers and moderator. I would like to invite Dr. Fawaz Al Asmari. دكتور مبارك الحارثي. دكتور عبد العزيز الدلقان. دكتور أحمد العارضي. By that, we reached to the end of our scientific program for the second day, and we are looking forward to seeing you all tomorrow to complete what we have started. Thank you.